Yeah, and
मेरे को ये दोनों यूबीआई दोनों ये देना, मेरे को यूएसबी निकाल के इसमें से दोनों दोनों टिकट डाल दो इस पे।
this is how slowly but steadily we are making our way. This is the ureter. Now can I have
Yes.
Maryland, and I will show you better that what I am doing, so that all of you get an idea of what is the tunnel. So this is the area that we have to be very, very careful. And this
Yes.
is Maryland, and I will show you better that what I am doing, so that yeah. So now once this is done, now you see the ureter is like this. So what I have to do is 45 different. So this is the ureter. You
With
can
the
see
legs,
that
yeah,
this
yeah.
is the ureter. Can you
Yeah,
see the
yeah, yeah.
ureter going there now?
Yes.
Yes, sir?
Absolutely.
Yeah.
You
so
are
this
entering into the
is
tunnel.
ureter, which is going towards this area. And this is a wrong instrument which was given to me, but I will show you correctly. So you see that is the vein on the top. Can you see the vein which is open?
Yes, yes,
Liga
open.
Shore? So,
Open.
so this is the vein which is what was bleeding when we did this on the left side, if you remember.
Yes.
So this is the vein, that is the vein which is always there. This is in the tunnel. You can see the tunnel now. Can you see it clearly?
Absolutely.
Yeah, and then this is what I am going to do. So now I do this, and you see, pull chahiye mere ko, pull chahiye uterus ka. And now slowly and steadily, what we are doing is trying to push the ureter. See the ureter going away?
Yes, yes.
Yeah, and slowly and steadily, without
That is-
damaging the ureter, what I am doing is lateralizing the ureter. So this is the ureter. You can
And
see
ureter
getting
is-
slowly but steadily,
Gone up with the
100%
bladder.
getting lateralized.
Yes.
And once this is lateralized, then what you do is you get enough parametrium which is below. Can you see?
Yes.
The ureter was here.
Yeah.
So I have lateralized it, and once
now
I
this-
lateralize the ureter, so this is the ureter which is lateralized, and now I take care of the entire parametrium, which is called as the anterior parametrium or the infrauretral parametrium. So you see now this is the infrauretral parametrium. If you don't take this out, that is what happened in the LAC trial. They didn't clear this parametrium, and because they didn't clear this parametrium, they landed up into recurrences into the areas which is like vaginal and vault. So this is not something that I recommend, and always should be taking. See how much, sir, I have gone below the below
Yes,
the
yes, yes.
all of
Behind, below the ureter and this
and
thing.
below the ureter,
Up to the
and
pelvic.
I am taking care of this entire thing so that we don't land up into any kind of recurrence. And this patient has unfortunately a very, very big tumor. I have to make sure that I go underneath the tumor and take care of this. So you see the levator ani now, sir?
Yes.
And
It is
this
visible,
is-
and that.
You can see how much
And
lateralization I have
ureter is
done.
totally free all around
Yes,
from this
and
thing.
now this is the area that I have totally freed. This is always the inferior vesical vein, which is very, very critical. You have to take care of the inferior vesical vein there. That was the inferior vesical vein, which is always coming there. And this inferior vesical vein has to be ligated, because if you don't ligate this vein, again what I will do is I will push this further down. Are you all happy about my clearance, sir?
Yes, yes, absolutely clear, sir.
Yeah.
And we appreciate your confidence about the structure, everything.
Yeah.
Yeah.
So this is something which is on a, and I published this after the LAC trial, and I won the America's highest award, which is the Golden Telescopic Award.
Oh, great. Congratulations.
Sir, thank you. So this was the award for describing anatomical description of this anterior parametrium, which is what the failure to clear this anterior parametrium was
Yes.
the reason for failure of the cervical cancers by the Americans. And unfortunately, we have to follow them, because this is, they have a multicentric trial, but now the latest trial, which is the SHAPE trial, has conclusively proven that you can use this. Now all of you can see both the ureters in one line. Can you
Yes.
see? So that means, so this is one ureter, this is another ureter.
Yes.
That means we have reached the trigone area because, show me. So
Yeah.
that means we have reached the trigone area. So can you see both the ureters there, sir?
Yeah, and we like.
Yes, so this is one
Yeah,
ureter.
a little bit of tissue, yes.
This
the
is
only.
one, this is another. And now what I will do is I will take a purse string suture now.
These are bladder pillars you are taking.
Yes, sir.
Okay.
And this is the entire area. Now I feel that I have, this is the tumor. You can see this is the tumor. I have gone below the tumor. And now what I have been doing for a very, very long time. So I will do this now. This is called as the Shautas maneuver. That is, I will close the vagina on the top. Give me 20 Vicryl. And now what I will do.
Shautas maneuver.
Sir, yes, Shautas maneuver
Okay.
is closure of the vaginal cuff before.
Before amputation.
Yes, अरे मेरे को ये दो reducer. So now what I will do is I will do a purse string suture, sir, and this purse string suture is very, very critical in preventing
No, but how you know that you have reached to the lower limit?
Sir, that is what I am going to take out the pack, and before I take, so that was a good question because this is what I was wanting. So this is where you can, अरे छोड़ना नहीं यार, तुम छोड़ो
So,
मेरे को.
before, you
So,
are not like in open, we are cutting, dividing it vagina.
Yes,
Then say
पकड़ो
before dividing,
इसको.
you are going to close it.
और left hand भी बराबर पकड़ो. So now, what he is going, pack he has taken out. He will put his finger, and tell me which is the free area. So is
Okay.
this free?
Yeah, that now.
This is free.
Yeah, this is.
So
free.
can you see that he is showing me the area
Yeah,
that
yeah.
understood?
We
So
understood.
it is same like doing the rectal examination.
Yeah.
Before we do, take out and put the pack again. I just wanted to know where is this. Come back. अरे तूने कितना लेंथ दिया? Full length दिया क्या? 1 minute, huh? So this is the area, and now he has shown me where to go. So I will take this purse string. मेरी तरफ लो अभी uterus को.
So this is the proximal purse string.
This is the purse string that we take, and we will cut below the purse string, sir, so that the entire, you will see that,
So-
this end, and you will see how it is important.
So it will ensure the adequate margin also.
Not only margin, sir, it
Prevent
will
the
also
spillage.
And prevent the spillage,
Spillage.
but apart from spillage,
Spillage.
it will ensure the
Mere
adequate,
taraf
because
do.
once you
Yeah.
part the suture, then at least 2 centimeter
Yes.
will be there, healthy
Yes.
margin.
So this is very, very critical, and if Harish has if we have sometimes if the patient is affording, then we can also use the stapler instead of doing this maneuver. So we have published this again using a stapler to close the vagina, and then you have to close and open. So you can staple the vagina, but then you cut the vagina
Again.
below the stapler line. Otherwise, the
And you are
husband.
taking full length bite Shailesh, huh?
Sir, yes, sir. Almost. Show me now. So this is the way in which. Show me. Come back. अरे मेरे को दिखाओ यार. So this is the way in which you take the purse string suture. So this is what we are going to do, and you will see how easily I am taking this, and then once I do this, then take तुम्हारे तरफ लो अभी वापस. So now you see I have gone underneath. This is the end of the suture, and there I will again come up and take this. So this will be the last of the bites. I have to be very, very sure that we take a good bite there. So this is,
Crossing
go
the
in,
original
go
stitch.
in. No, this is something which has never happened because the needle is, yeah. So this
Excellent.
is the area. Come back. Now what I will do is I will now see these are the 2 edges. I have closed it, and now I will tie this completely, 1 and then 2
And then 3.
and then you see.
You used to have a gynecologist knot, no? Earlier.
Pardon, sir?
With 3 throws, you used to
Surgeon
describe
has
a
2 throws.
gynecologist knot with three throws.
Yes, but I can do it with 2, I can do it with 3. Now this is cut through, this thing has gone, so I have to use only this, and now I am going to take out the needle is out, and now what I will do is sonicision, and you see now,
Yes.
so this is where we will take out this entire area. So you see now, अरे तुम छोड़ नहीं रहा है यार, तुम्हारा छूट रहा है. So this is the purse string, and
You are
this
dividing
is
below
where
the
we
purse
have
string.
to go.
You are amputating below it.
Yes, so that there is no spillage. I will take care
And
of
you are
this
quite
now.
away from the trigone area, and this
Yes,
you
and
clearly
you
visible.
are, I am away, I can see everything there, and now I will see the vagina getting opened. तुम्हारा बिल्कुल भी traction नहीं है boss, तुम्हारा छूटा हुआ है. पकड़ो इसको, इसको पकड़ो, इसको. Yeah, so every time it is all about the traction, counter traction techniques, and you can now see that this is the vagina. In a moment I will be opening it. You
Yeah,
see,
it is
go
opened.
inside, under pack hai. There is a pack, no evidence of cancer there. Can you see that?
Yeah.
Yes.
So we are clean over there. There is no spillage of the tumor, and this is what we are going to do. बाप सूचर लेके रखो. And now, तू क्या देखते रहता है क्या उत्कर्ष? So this is now the entire area, and I'm just going to complete this from this area to this area. Again, we have to make sure that this is the correctly taken thing. Go inside, so center में दिखाना भैया. Center दिखाओ. So this is the rectum lower down. You have to make sure that we are not. अरे तुम छोड़ो, तुम सिर्फ हवा में हिटा रहे हैं, तुम्हारा ये नहीं हो रहा है बिल्कुल भी. And now this is the complete area. Back देना. एक एक स्टेप तुमको पहले से मालूम होना चाहिए ना. हाँ. So now we are just completing this. All the little bit amount of blood that you are seeing is purely. Oh, this is continuing to work. It is not stopping. So this is the area that we are taking, because that thing.
The same, these are the same venous
Pardon,
plexus.
sir? These
The
are.
bleeding is from the same veins which are.
No, sir, this is all, whatever you are seeing lower down is the collected blood which is coming from the specimen. अरे तुम छोड़ रहे हो यार, तुम सिर्फ हवा में, अरे निकल, ऐसे नहीं निकलता है. चलो ठीक है. So this is the area that I have to go ahead and take it finally, and this is the last bit which is there. अरे तुम पकड़ेगे तो अच्छा रहेगा ना. चलो. So this is the.
Yeah, nice, good.
Now what
Good.
I will do, so now sir,
Yes.
Yes.
I will put this, why are you not ready with this?
Inside the vagina and take it
Yeah,
You are
so now
from-
I will put this, sir, we put
the
an
endo bag.
endo bag, which is always, ready sir? We will always use an endo bag. Back को पकड़ो, left hand से back को पकड़ो, ये वाला, ये वही left hand पकड़ो ना, और दूसरे हाथ से भी पकड़ो, दोनों हाथ से पकड़ो, ये पकड़ो, नीचे का, ये वाला, अरे बॉस, ये
तो-
पकड़, हाँ. So now what I will do, I will now put this uterus inside the bag. तो देखते रहे,
शैलेश।
मेरे को ग्रास पर चाहिए ना रे.
Shailesh,
Yes sir.
meanwhile, can I discuss one thing? While
Yes
you are
sir.
putting it in the endo bag, can you demonstrate some benign case also?
Shailesh,
Yes sir. What is
here audience, the lot of people, they are doing more benign work like this. So, yeah, if any benign case also here,
He has agreed.
if you can demonstrate that.
So what I didn't understand.
Choledochal cyst is there. Can you demonstrate after this?
Sir, we are going to demonstrate one, I think. esophagus, and then I will demonstrate a benign case also. Show me.
You are a malignant surgeon.
Sir, I am
So
a
we want to see how you do the benign surgery. That is the important.
No, sir, I am a benign surgeon doing cancer surgery.
Sir, choledochal cyst, you show choledochal cyst.
Okay, I will
Yeah,
show,
that is-
I
yeah.
will show choledochal cyst.
Yes.
No esophagus.
Please.
Okay.
Okay.
That is also done. अरे पकड़ना यार.
Thank you.
पकड़ते नहीं है. चलो. No, वो grasper को change करो. तुम
Hello,
लोग
sir.
निकालो. Now what I am going to do is take this out now from below. So this is, chalo jaldi utkar. So this is easily taken out from below.
Shailesh,
Suction
Dr.
there.
Azad Singh wants to interact to you.
Pardon, sir?
Dr.
Our very
Azad Singh
senior
from
surgeon,
Sarsa.
Dr. Azad Singh from Sirsa wants to ask something.
Yes, of course, sir.
Not ask, sir. I have a comment. Your surgery is not science. It
What?
is- your surgery is not science. It is pure magic.
Hello, Dr.
It is a magical surgery.
If it were magic, there must be at least 10, 20 Putambekars in the country by now. Unfortunately, there is only one Putambekar. And we are
Thank
so
you, sir.
proud.
Thank you very much.
We are so proud that you are an Indian. Thank
Yes,
you.
sir. Thank you, sir. Thank
Next
you.
OT ready, OT number 4.
अरे यार क्या कर रहा है तू? मेरे को एक निकालने को दो. So
A
thank you.
48-year-old female patient presented to
Chalo na.
us with complaints of lump in left breast since 1 year.
1 minute.
On examination of a left breast, a lump of around 3 into 2 centimeter was palpable at 11 o'clock, which was firm to hard in consistency, irregular surface, and it was mobile and not fixed to underlying muscles or overlying skin. Axilla, no lymph nodes were palpable in left axilla. Clinical staging is T2 and 0. On mammography, 3.6 into 1.4 centimeter lobulated cystic lesion was present in upper inner quadrant of left breast. FNAC was done, which was suggestive of carcinoma breast. We did metastatic workup on CCT chest. Complex heterogeneously enhancing ill-marginated solid cystic lesion was present, which was of around 2.5 into 1.5 into 3.2 centimeter in upper inner quadrant, and subcentimetric left axillary lymph nodes were present. We did a USG abdomen. Liver was normal, and we found a space-occupying lesion in upper pole of left kidney, which was 4.8 into 3.5 centimeter. So we did a CCT whole abdomen, which was suggestive of heterogeneously enhancing space-occupying lesion 4.3 into 4.2 into 4.5 centimeter, arising from the upper pole of left kidney on lateral side. So the plan was decided, left MRM with robotic left partial nephrectomy.
So which one you will do first?
Hello.
Partial nephrectomy?
Hello, yes sir. You are connected, sir.
Hello, good morning.
Good morning.
Can you hear me, sir?
Yes, Amitabh.
Yes, sir. So first of all, good morning to everyone who is present in the hall, and thanks for having me here. So actually, it's a good opportunity for me. I still remember the day when I started the robotic program here. I did first radical prostatectomy in Aadhar Hospital. After that, they did a lot many cases within very short span of time, and congratulations the whole team of Aadhar. And today, actually, we have got this case, this female who is diagnosed with the CA breast also, and a small renal mass also incidentally detected. So till now I am planning for partial nephrectomy, and if you'll see the things will go, then we will proceed with the partial nephrectomy. Otherwise there are chances that 4 to 5% chances that we might need to do radical nephrectomy, because this tumor is very endophytic tumor, but we'll try to do partial nephrectomy. So I am blessed to have Dr. Sarvartha, who is colleague of mine. He is junior consultant in my department with me, so he'll be assisting me. And so just a word about the docking port placement for this patient. So can you see the external view of the patient?
Yes.
So this is the left kidney, so left side is up, is standard this flank position. So these are the robotic ports. So we keep it in like 3 ports in the straight line, in the pararectal line, and 1 port basically is just 4 to 5 centimeter above the left, this iliac bone crest, iliac spine. And we are having this 12 assistant port just above the umbilicus, just for putting bulldog clamp, hemolock clip, and whatever, like vascular tape or whatever. So this is the whole thing about the setup.
You are on which side of the patient?
So I am towards the umbilicus side. So this is head end
No,
of the
umbilicus
patient.
is in the center, head or
So
left?
this is head, sir. This
Yeah,
is head.
Right, right.
Can you see? This is head. This is foot end of the patient.
Right.
So left is up. Left flank is up.
Okay.
Yeah. So now just we are setting the robotic arms. We are done with the port placement.
Amitabh, for the movement, can we shift to Shailesh because he's just finishing?
Kya
Amitabh,
hua? Yes, sir.
we are switching to Shailesh's OT because he's almost finishing
Okay, sir.
by the time you organize.
Karna is-
Hello?
Shailesh.
Yes, sir.
So you are using V-lock for
Yes, sir.
closure
I
of the
usually use
vaginal cup.
V-lock.
Yeah,
It is an easier option to do,
easier and faster.
and it is also, so you see now the technique is
Yeah.
very important, that whenever you do suturing, the needle has to be at right angles
Yeah.
to the vagina, and then just go pronation, and then you go supination, pronation, supination. And a lot of time the people used to say that I will do vaginal suturing, but going again down and doing it from the vagina is a mess. So this is very, very simple.
Yeah.
And now just if you can wait for 30 seconds more, because I am going to show you the final roadmap of the pelvis, which is the most important thing for all of us to understand the anatomy. And see now, this is all almost
Finished. The last bite.
So I'm just going to show you just one more suture, and then you will see the anatomy of the pelvis revisited again. Now this is something which is very, very critical to get the entire perspective. So this is the last of the sutures that we will take. We have to make sure that we do a very good job, and we don't want any kind of, so this is scissors de, left hand में scissor de, and now I will first take out the needle, and then मेरे को grasper, then no उसको पकड़ के रख, yes. So now you see, sir, Vashish sir.
Yes, sir.
Now you see this is इसको पीछे ले, इनको. So this is the anatomy, external iliac artery, the
Right.
genitofemoral nerve, external iliac artery, external iliac vein,
Vein.
obturator nerve, internal iliac artery, the ureter,
Ureter.
and you can see that the bifurcation. So this is where the
Yeah.
ureter crosses from the lateral to the medial side.
Right.
Always, this is the bifurcation. You can see the entire anatomy. I hope all of you have enjoyed the surgery.
Yes, yes,
Thank
yes.
you, Harish. Thank you, Aadhar Hospital. Thank you, the organizers, and thank you,
Thank you,
Karwasara
Shailesh.
sir and Vashish sir for excellently moderating this.
Excellent
I hope all of
surgery.
you have enjoyed this surgery. Thank
Yeah.
you.
Yeah, we
Yeah.
enjoy.
Amitabh? Amitabh? Yes, sir. Yes, we are with you.
Okay, sir. So we have docked the arms. So we are putting the instruments. So first I'll start with the two instruments, monopolar scissor and bipolar pro grasp.
Right.
जा नहीं रहा, टाइट है, ऊपर 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 ऊपर, हाँ हो गया, लॉक, चलो इधर बाइपोलर देना सिस्टर, इधर 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 जेली लगा दी है क्या? हाँ थोड़ा लगा दो, नहीं तो टाइट रहता है ना, फिर वो जाता नहीं है वो, उधर नहीं सिस्टर, यहाँ शाफ्ट पे, हाँ जो पोर्ट के अंदर रहेगा, बस ठीक, अच्छा, कैमरा क्लीन करना है एक बार, कैमरा क्लीन, ठीक, अभी देखते हैं इंस्ट्रूमेंट सही चल रहा है, नहीं चल रहा, गंदा, टिप साफ करो अच्छे से, मैं पकड़ता हूँ, अच्छे से टिप पकड़ के साफ करना पड़ता है उसको, ठीक, ठीक, चलो। So we are done with the docking. We already inserted the instrument. So just I'll be starting with the procedure. So these are the pretty standard step. अच्छा, हाँ ठीक है, वो लग रहा है यार ये, बट ये फिर मेरा स्क्रीन ऐसे लगेगा ना, हाँ ठीक है, वो 3D ग्लास, एक सेकंड उतार, कंट्रोल, बाइपोलर, ना टॉगल करना है, ठीक, सीजर का रजिस्ट्रेशन, ना 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 ना, मोनोपोलर कट सीजर, ओके, hello.
Hi, Dr. Amitabh.
Yeah, so can you see the internal view of the patient?
Yes.
Okay, so these are the pretty standard step. So first I will do the mobilization of the colon, of the descending colon. ये थोड़ा सा कैमरा और क्लीन हो सकता है क्या? थोड़ा और क्लीन हो सकता है क्या? तो एक बार कैमरा क्लीन कर दो जरा। हाँ, थोड़ा पानी में रखो 10 सेकंड तक ना, क्योंकि थोड़ा सा इसमें जी है।
So, Dr. Amitabh, you just have three.
बाद में डाल देंगे।
You have 3 ports in?
कौन सा 12 या 5? ठीक ठीक, अच्छा तो अभी डालना है, अभी डाल दो फिर। ठीक हो गया, ले आउट 12 यहाँ पे, चलो आ जाओ। अच्छा ठीक है, एक सेकेंड, लेट मी सी, आ जाओ। आ गया? हाँ, हो गया? ठीक, कोई प्रॉब्लम? ठीक है, अच्छा ठीक ठीक, अच्छा ठीक 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 ठीक। So it's very important to identify the exact plane between the descending colon mesentery and the gyrotas fascia, because what I have seen my residents and fellows, so they are having very difficult time in identifying this plane, because this plane is very, it's almost completely avascular plane, and if you are able to find this plane, then you won't have any bleeding, and it will lead to the ureter gonadal vein complex. Then probably you can reach up to the hilum also very easily in your patient. So first, just cutting the lateral peritoneal attachment at the line of told, then identifying the plane between the sigmoid descending colon mesentery and the Girotas fascia. So because this patient is thin patient, she doesn't have too much fat in the viscera, so you can see the kidney very well through the fat and the Girotas fascia. So this is the plane exactly. So the kidney wrapped into the Girotas fascia with perinephric fat. This fat belongs to the descending or the splenic flexor.
Right.
You can see this is completely avascular plane.
Yes.
So if you are into this plane, things become very easy for you. So there is another very important thing to identify, important difference you can say, the difference in the color of the fat. So the mesentery fat will be much yellowish in the nature, whereas this Girotas fascia will be much whiter compared to this thing.
Right.
And you can appreciate it very well. And it always helps you in identifying the plane. मेरा bipolar, 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 bipolar बाहर आ गया, अंदर थोड़ा पुश करना. हाँ 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 हाँ. हो गया. निमो जा रहा है क्या पेशेंट का? ठीक है. ये रेस्पिरेशन बहुत तेज कर रही है, मूवमेंट्स बहुत ज़्यादा हैं. पॉजिटिव प्रेशर थोड़ा कम कर दो या टाइडल वॉल्यूम थोड़ा कम कर दो पेशेंट का. ये रिलैक्स करना, देखना कि रिलैक्सेशन प्रॉपर है कि नहीं है. सेम प्लेन आई विल बी फॉलोइंग. मेरा बाइपोल. So you can see the stark difference between the color of mesenteric fat and the Girotas fat. And if you are into the plane, it is a completely avascular plane. You can just tease off the mesentery of descending colon from the Girotas fascia. यार ये ना इसका क्लच नहीं सही काम कर रहा है. देखो फिर चली गई बाइपोलर नीचे ना, ऊपर उठाना. आर सर्वर था, थोड़ा ध्यान देना पड़ेगा ना, क्योंकि स्ट्रीम मूवमेंट में चला जा रहा है ना वो. हाँ वो देखना पड़ेगा ना वो, क्योंकि निमो जा रहा है पेशेंट का ना. असिस्टेंट पोर्ट से होगा या फिर किसी का यूनिवर्सल सील देख लो. कितना है अभी प्लेन, कितना है? अच्छा कौन से? क्या करें? रुकना है? डू यू वांट मी टू होल्ड? हाँ रुकना है? कितना? What happened? अभी ठीक है? कौन सा? हाँ कर दो कर दो. बिकॉज हाँ कोई नहीं ले लो. दिखाना है? You want me to? हाँ? You want me to show? अच्छा ठीक. हाँ हाँ हो गया? अभी ठीक है? ठीक है. So you can see at this plane. So I am just teasing off this gyrotas fascia from the mesentery of descending colon, and this is completely avascular plane. So now this is ureter, this is in gonadal vein, and this is common iliac, left common iliac artery. I'll be just mobilizing this thing up to the pelvic brim. Especially in partial nephrectomy, we don't routinely mobilize the descending colon mesentery till pelvic brim, but because this is a demonstration case, so I would like to have a very good field of mobilization so that you can appreciate the anatomy. वो भी लीक कर रहा है. करो, मैं रुकूं? ठीक है. बाइपोलर बाहर चला जा रहा है ना, इसको थोड़ा सा पुश करना पड़ेगा, फिर से अंदर नहीं, इंस्ट्रूमेंट पुश करना पड़ेगा. वो टिप एक्चुअली ना कैनुला में चला जा रहा है ना, तो इसलिए वो फ्रीज कर जा रहा है. ओके. अरे यार, फिर थोड़ा अंदर पुश करो, थोड़ा पोर्ट बाहर निकालो इसका ना, या नीमो थोड़ा सा इंक्रीज करो. अब वो नहीं, उससे कुछ नहीं होगा, बिकॉज आई कांट मूव राइट नाउ ना, बिकॉज इट्स इन द कैनुला. हाँ, और अंदर जाओ, अंदर. हाँ, अंदर पुश करो इंस्ट्रूमेंट. हाँ, थोड़ा सा और पुश करो अंदर. हाँ करो. ठीक है. Instrument advance. Okay. Now I'll go towards the upper pole of left kidney because the tumor is situated in the upper pole. So I need to mobilize the complete upper pole of this kidney. So I'll be just going behind the plane of pancreas and spleen. I'll just divide this ligament attachment of this spleen to the diaphragm. मेरा कैमरा नहीं, एक सेकंड रुक जाओ, सेक्शन तुम्हारा हिट कर रहा है, एक सेकंड. प्रोग्रेस कैसे यार, अपने आप कैसे हो रहा है? हाँ बस एक सेकंड. फिर अब लीक कर रहा है, कुछ आवाज आ रही है. निमो लीक कर रहा है क्या फिर से? नहीं, टिप फिर कैनुला में चला गया है ना, ये थोड़ा सा अंदर करना. हाँ, शॉर्ट इंस्ट्रूमेंट डालो. नहीं वो, हाँ शॉर्ट इंस्ट्रूमेंट देना बाइपोलर अगर है तो. हाँ बिकॉज अगर ऐसे जाएगा तो सुचिंग कैसे करेंगे? ये अपने आप कैसे हो रहा है? कैमरा का टिप अपने आप कैसे हिल रहा है ये? तो प्रोग्रेस हटा दो ना, अभी प्रोग्रेस हटा दो, अभी हटा दो, अनडॉक कर दो उसको भी. हाँ अनडॉक कर दो, पीछे कर दो उसको, आर्म को बिल्कुल पीछे कर दो. हो गया? ठीक. अभी ठीक है? Now, the second step, I'll try to lift the ureter, gonadal vein, and I'll go behind this and between the psoas muscle. So this is actually a very easy plane to achieve. So once you are into this plane, it will lead you to the hilum of the left kidney or right kidney. किसका? Progress तो हम यूज ही नहीं कर रहे हैं अभी. हाँ कोई नहीं, हटा दो हटा दो. तो अभी हम यूज ही नहीं कर रहे हैं ना, तुम कर लो चेंज. So just I have lifted this ureter and the gonadal vein.
Right.
This is psoas muscle. Psoas fascia is preserved with this thing, and I'll lift it up, and this will help me going up to the hilum.
Very nice.
Yeah. So whatever the mesentery attachment is there on the gyrotas fascia, I'll identify it and I'll just mobilize this thing.
Dr. Amitabh?
Yes, sir.
So while you're just exposing the hilum and exposing the tumor, we have a very small talk on robotic hernia repair, which we'll be seeing simultaneously. So
I could not hear you, sir. Your
sorry,
voice
can you
is
hear me
very
now?
less.
Can you hear me?
You're not very loud actually. Your volume is very low.
I think they have to increase it
Acha,
in the
acha.
OT, I think.
Acha, ठीक.
So we'll just do a concomitant talk.
Hello, still I can't hear you.
Okay. So I would like to invite Dr. Vivek Bindal from Max Hospitals, Delhi. He has a very lovely talk on robotic
Short
E-TAP
instrument दे
RS.
दो.
So we all know that
इसको पहले अंदर
robotic is
डालो.
very good
इसको
for
push करो अंदर और इसको
intraperitoneal
निकालो.
surgeries. And in E-TAP the space is limited. So I think the adoption of robotic into E-TAP came a little later than
हाँ,
other
short
hernia
instrument दो जरा.
surgeries. So, Dr. Vivek.
Thank you, Dr. Harish, Dr. Banga, Dr. Deepak, Dr. Vivek Gupta, and Aadhar Hospital for inviting me. And I bring greetings from Max Institute of Minimal Access Bariatric and Robotic Surgery. It's an honor to be here in this August gathering. So this is ROBOSURGE 2024, and I am so happy to be a part of this. One special reason is this reminds me of our conference ROBOSURGE 2014, one of the first robotic surgery conferences which we did in Gangaram Hospital that time. And then we continued with a series of these ROBOSURGEs for 3 years in a row. And we know that Anand were there as fellows. So these are our previous trips to Aadhar. You can see Dr. Harish Sharma, Dr. Deepak Mittal in the OR. Mahipal is there sitting and laughing. And this is our, operating at the hospital. This is with Dr. Banga, the man in the show, Vinod Jangra, our dear friend. So, a lot of memories attached with Hisar and this place. So today I'll be speaking on robotic AWR. Robotic abdominal wall reconstruction is one of a big chunk of our practice, along with laparoscopic and open abdominal wall reconstruction. As general surgeons, I think hernia is something which most of us want to see. And why did we start AWR was because of these hernias. So if you can see this post-cholecystectomy hernia or post-laparotomy recurrent hernias,
कोई नहीं, बाद में दिखा देंगे.
these are big hernias which require more than just an onlay repair or more than just, IPOM, which we used to do. So now there are so many different options for ventral hernias. We have IPOM plus, E-TAP RS, E-TAP RS star. And why did we start robotic E-TAP? We had been doing robotic surgery since 2011, mostly for bariatrics. And then when we started doing E-TAP RS and TAR in 2017, That's when we combined robotic surgery
One
with
second.
ETAP and started this approach. This is a video of a transversus abdominis release being done robotic, and this is an external video. So
मेरा कैमरा मूव
inferior
कर रहा
crossover tar
है,
is
एक
a
सेकंड
very
मेरा कैमरा
difficult
हिट कर रहा है.
ergonomic position, but
तुम
you can see
नीचे वाले से आ
here
जाओ
the
ना.
assistant is sitting comfortably. The robot is
नीचे
locked
वाले से आओ
and it
जरा.
is working. This is in the COVID era, and that is when we did it. So there are many, good results of ETAP TAR, like this patient with large infraumbilical hernia, here with divarication post-radical hysterectomy. We see these kind of hernias very commonly in our practice, and you see after ETAP bilateral TAR, the functional abdominal, the abdominal function actually is now much better than what it was, rather than just an IPOM, which was a bridging repair. This is a post-appendectomy hernia. So large hernia, lateral boundary hernias are difficult to treat, and this is after ETAP TAR has been done. And you see the functional result is so much better, the cosmetic result is better. Upper midline post-laparotomy hernias. So we did using the Da Vinci SI system earlier, then XI system. We have done more than 500 incisional hernia cases, and more than 45% are recurrent hernias. So different approaches have been used, and we have published our approach. This is the first publication from India. So I'll just show an unedited video of a robotic ETAP TAR, as this is more of a operative workshop. So these are the 3 ports that we use for ETAP RS. This is a reef stopper repair. One port is in the left upper quadrant, one is in the umbilical level, and one is in between. So these are just medial to left linea simulnaris. You can see here, these are the 3 ports. This is the left upper quadrant port. This is the 5 centimeter below this, and this is just below the umbilical line. And these are medial to the linea simulnaris. And then we dock the system. When we dock the system, we do a crossover. This is at 4x speed, and this is an unedited video, so there is no editing there. Here I am doing a marking on the posterior sheath, few millimeters medial to the linea alba, the junction of PRS with linea alba. So you can see this is the falciform fat which has come up. So as soon as you go in this retroactive space, you open up the posterior sheath, you end up with the falciform ligament, and here we have to save any injury to the linea alba, and now I have opened the opposite PRS. So this here white thing is the linea alba. We have to go lateral to the linea alba and open the opposite retractor space. That is going to complete the crossover. So once we do the crossover, then we expand the space. With robotics, you can actually preserve a lot more peritoneum than what you can do with laparoscopy. And so here we are taking the peritoneum down, and we always keep a small gauze piece inside, just for some blunt traction also. So with the scissors we can use the gauze piece for some blunt dissection. Here you can see we are moving just very close to the abdominal wall. So when we move closer to the abdominal wall, we have we'll be saving a lot of peritoneum, and here the peritoneum will really get thin. As we move down, the peritoneum is getting thinner, and we are reaching the area of the hernia defect. So this is the hernia defect, and as it is an extraperitoneal surgery, we will open the hernia sac and see for the contents. Although we mostly have a plain CT of the abdomen, and we know that whether bowel is there or not. So here we are also going to try and save as much of the sac as possible. So this is the omental content which is being taken down, and this is the hernia defect. So you can see the peritoneum has become really thin. Still we are able to save it because of dexterity of the instruments, better vision, and ability to just remain flush to the linea alba. Now we can actually shave off a layer from the linea alba if the peritoneum is not very robust there. So that tends to prevent a lot of transversus abdominis releases. Now we go down into the cave of Retzius. This is going towards the suprapubic space. This is our routine TEP space, which a lot of us are used to when we reach below the arcuate lines. So you can see we have reclaimed the peritoneum. There is a small hole down there. And this is the cave of Retzius. So this is the entire reef stopa dissection, and you can see the neurovascular bundles. So the neurovascular bundles are seen as lamppost sign. This is the divarication and the hernia defect. And then we close these posterior and the anterior defects. So we use a barbed suture, and this suture is used to close the posterior defect. We do not use any assistant port. It is just 3 ports through which the instrument is removed and sutures are introduced. And then we suture on the roof. So we suture on the roof all the way from down till the epigastrium. And here it's a 45 centimeter suture. So here we are suturing the hernia defect along with taking the sac to prevent any sort of seroma. So, this suturing is difficult in laparoscopy because you are having very difficult suturing angle and you have to suture from xiphi to pubis. But robotics makes it, very precise and much easy on the surgeon. So here we have closed the entire linea alba. And then we place in a mesh. So we are measuring the size of the reef stopa space, and then we place in a large mesh there. This is a 30 by 15 centimeter macroporous polypropylene mesh, and then it is laid flat. So that is, after this mesh is laid flat, that completes the procedure. We also deal with a lot of dense bowel lesions like these when we do these robotic hernia surgeries, and with very, very complex hernias we have been able to do these endoscopic with bilateral TARs. So if you have to do a TAR, you have to, if you have to do a transversus abdominis release, you have to divide the TA fibers and be medial to the neurovascular bundle. In this picture you can see these are the neurovascular bundles. These are TA fibers which are lifted by our scissors. So one has to open the posterior lamella of internal oblique and then lift up the transversus abdominis and divide it and prevent any injury to the peritoneum. So this is a short video showing how transversus abdominis release is done. Here I divided the posterior lamella of internal oblique and now lifting up the TA. TA is fleshy in the upper abdomen. So when we used to read in our anatomy days, we used to say that the lateral muscles end at linea semilunaris. But now we know that transversus abdominis is much more medial to linea semilunaris in the upper abdomen, T12, L1, L2 level. And this is the fact that we utilize to do this transversus abdominis release. So here we have divided the TA. As we go down, you can see it is becoming aponeurotic. And what I am doing is I am, making windows, pockets on both the sides to have the peritoneum, saved. And as we go lateral, this is a retroperitoneal fat. So this is basically the, this is the area where you will not be injuring the peritoneum. And with this transversus abdominis release, you get a lot of medial mobilization, and then very large defects can be taken care of. So we can also use ICG. In this video, we are showing you how indocyanine green is used to identify the neurovascular bundles. As soon as we inject indocyanine green in the ICG mode, you can look at the green structures, which are the vascular structures. And when we do a transversus abdominis release, we have to prevent any injury to these green structures. So here you can see this is the lighted green structure, and I am doing a TAR preventing the neurovascular bundle injury. We also do a lot of post-IPOM recurrences. Many of us deal with post-IPOM recurrences, post-open only recurrences. And these are the mesh plates that we see. So the sublay plane is the best plane to go. Whenever there is a post-IPOM recurrence, you go in the retroactor space, you glide above these stacks, you glide above the mesh plates, and you provide a very physiological sublay repair in these complex cases. These are the previous mesh fit tags whom we deal with in these kind of scenarios. And then finally we recreate the anatomy and place in the mesh. Our studies have been published in Journal of Minimal Access Surgery showing the robotic surgery ventral hernia repairs to have less pain scores because there is no tacker use and much earlier return to work. And we save on the cost of mesh because we don't use a dual mesh, we don't use tackles. So it makes it cost neutral. So whether you do robotic or laparoscopic ventral hernia, the patient pays the same sum of money and they get a better repair in robotic. This is a huge advantage in ventrals. Also, there is a new technique called fasciotense. For very large defects, multiple previous operations, you can see the patients like these, loss of domain. You need something more than, to close the abdominal wall, very large defects. So fasciotense is the new thing. Fasciotense is a device which is used to attach on the abdominal wall to pull it. We do a chest optimization, put in Botox in the lateral muscles to paralyze them 4 weeks ahead of applying fasciotense. And I'll just show you this video of robotic fasciotense. This was done for the first time in the country by us. So this is a lady with recurrent incisional hernia. She had a post-hysterectomy, large hernia, phalansteal hernia, and she had a huge amount of small bowel inside. So this is the docking. We are doing the crossover. I think this is the opposite retractor space being developed. Then we go down, we reduce the entire small bowel from the content. This is the previous mesh. So you can see how the previous mesh plates in a recurrent hernia is dealt with. We take down the previous mesh sutures and now we have a large defect. So this is where we are applying the fasciotense. Fasciotense can be applied with the robotic system docked. Mostly people use it in open surgery. And I know that fasciotense has been demonstrated in Aadhar Hospital in open surgery. But now you can use it in laparoscopy or robotic surgery also using this technique, which is being shown. So we are taking 6 sutures from edges of the defect and they are pulled in the midline. So here we are taking them outside and then we basically, I'll just show you the device. So this is how the device is applied, and with the device application the edges are getting closer. So you can see with fasciotense the edges have gotten closer here, and then we suture from inside. So very large defects can be dealt without a component separation and they can be closed. So even the posterior rectus sheath lengthening is there. So the use of fasciotense with robotic surgery in minimally invasive scenarios is something which is a nice way to deal with these complex defects. And I think it is going to be more and more common in times to come. This is the final pick after the robotic fasciotense for this large hernia. You can see these suture bites and the 4 ports which have been used. So it's very, very cosmetic for the patient, and this patient happened to be mother of a surgeon only. So also there is so biosynthetic meshes is one new thing which has come up, and I was told to speak and share few of our experience about this. This is basically the abdominal wall reconstruction using physics mesh or biosynthetic bioabsorbable mesh. And so basically it is a poly-4-hydroxybutyrate mesh. I don't know, I think some of you may have used it. It is absorbable over 18 months. So when we look at meshes, we have been using always permanent meshes, but we have certain situations where physics is a good molecule. And I think, so these high-risk situations, basically in grade 2, grade 3 and grade 4, contaminated and comorbidities, physics has a good option. So I'll just show you some indications, like women of childbearing age, where we don't want a permanent mesh and the hernia is symptomatic, they need a hernia repair. Rectopexy, you don't want something where a permanent mesh can erode into rectum. Hiatus hernia, you don't want something where a permanent mesh can erode into your esophagus. If you are explanting a mesh and there is a hernia recurrence, normally we do an anatomical repair, now we have a mesh that can be placed. Prophylactic mesh in situations like ileostomy closure, high risk of reoperation, patients with Crohn's disease, inflammatory bowel disease, malignancies, history of COX, or if you have a suspicion of COX when you go in and do a hernia surgery. So many people would come out in a COX patient without putting in a mesh, if there is a suspicion during the surgery, but you can put in a phasix mesh. If there is a history of mesh infection, patients with open abdomen, and some patients also have a preference for phasix. So we started using it 3 years ago, and we have done 26 cases and used it in retrorectus plane, IPOM plus, ETAP RS, TAR, hiatus, rectopexy. This is TAPP. So this kind of patient, this is post-intracutaneous fistula hernia, large hernia, disruption of linea seminaris, and we did a TAPP. And when we did a TAPP, we had to take this fistula out, and we had to staple off the previous fistula site. So finally we used a phasix mesh in this post-intracutaneous fistula closure. This is post laparotomy incisional hernia with perforation peritonitis, and this lady had a very large hernia. We had to do a TAR, and she had not completed her pregnancy. So you can see we are doing a right to left crossover, opposite to what we normally do. Left sided TAR is done, and then we used a biosynthetic absorbable mesh there. Patients with these post-cola mesh explantation. So this lady had, this is a mesh floating because of mesh infection after scola done somewhere in 6 months ago. And now we had to remove this mesh. So this is the mesh with the mesh capsule being removed. So what do? Either you just close it, but we put in a retrorectus phasix. And this was done a year ago, and this patient is really doing well. We have a CT scan, and hiatus hernia repair, again a very good indication. This is a redo hiatus, very large hernia, and here we are putting in a mesh at the hiatus. So I think our longest follow-up is 3 years with very good results, and this is how some CT scans look like. These are pre-op, and this is post-op after 20 months. So even at 20 months, the mesh goes away, but you have a very good scaffold there. I think, thank you so much for your kind attention. I'll be happy to take any questions. Thank you.
Thank you very much, Dr. Vivek. It was a wonderful lecture, talking not about the scope of robotics in AWR, but also about phasix mesh.
Thank you, sir.
So we can probably just go back to Dr. Amitabh and find out what's happening. Dr. Amitabh, can you hear us?
Yes, sir. Can you increase the volume, please? Net holder thoda sa de do. So can you see us, sir? Can you see our screen?
Yes, yes. We can
Yeah, कुछ हट कर रहा है. सर्वर section हटाना अभी जरा.
We can see you're trying to dissect the renal vein.
So till now what I have done, so this is the gonadal vein,
Okay.
the ureter complex.
Right.
So this is the para-aortic node. So I
Okay.
took one vehicle because there was lymphoria
Okay.
from the lymphatics.
Oh, okay.
Okay, so this is aorta down below. Can you see? This is
Right.
aorta, and this was the gonadal vein, artery, where I have just applied a 10 mm hemolock clip.
Okay.
Now this is hilum of the left kidney.
Right.
You can very well appreciate. So this is the left renal artery, main renal artery.
Right.
I took one vascular tape on this thing,
Right.
and here you can see this lumbar vein also.
Okay.
This is the lumbar vein. So in most of the cases on the left side, you will find this gonadal vein, which is just arching over this renal artery. So
Okay.
while doing radical nephrectomy, where I had to apply certain clips, hemolock clip or metallic clip over the artery before cutting it, then most of the time I had to sacrifice this lumbar vein. then I would be able to reach over this part, the renal artery.
Okay.
So because this tumor is big at the upper pole, so just I want to take the vein control also, just to be on safer side, because suppose if I'll just need to control the vein, then it's better to have one vascular tape on the vein also at this time only. So the idea behind putting the vascular tape is basically just to have a almost complete control over the vessel. So when you want to apply the bulldog clamp, then you can retract it, you can pull it towards you, and you can apply the bulldog clamp very efficiently also. So this is the adrenal vein, this one. Can you see? So this is the adrenal vein which is draining from the adrenal and going into the main renal vein. This one is the adrenal vein.
Okay.
Yeah.
Right.
Yeah. So I'll be just trying to hold this going behind the left renal vein. Now you can see my scissor. So I'm just below the needle holder. हाँ क्लिप कर देते हैं, देखते हैं अभी, क्योंकि इधर ना डिस्टेंस है नहीं. हाँ 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 हाँ. अभी just we'll put a vascular tape. Let's see later on. Needle holder. Vascular tape is ready. One second. First. Yeah, la. 1 second, you are hitting me. पहले बाहर जाओ. फिर मुझे क्या हिट कर रहा है? आओ, अब आओ. हाँ. चलो. हाँ हाँ. Hemolock. Thick scissor. So I have completed the mobilization. That was the first step. After that, I identified the ureter and gonadal vein complex. That was the second step. After that, I lifted it up from the psoas muscle and fascia. That was the third step, which led me to the renal hilum. After identifying the artery and vein, I took umbilical tape just for a better control. So that part is also finished. Scissor. Yes, okay. Now I'll be just going towards the upper pole of left kidney. This is pancreas. You can see it very well. And yes, sir. You can see the splenic vein, splenic artery in this groove. This is the splenic artery.
Very nice
you can see, yeah,
sir.
Yeah. Now I'll be just mobilizing the whole this upper pole, because the tumor is situated at the upper pole. You need to see the stomach also. Sometimes stomach may come in this field.
Yes, sir.
Yeah. So you need to be on the safer side. Always better to see the stomach. So advantage of dividing the ligaments of the spleen, because then it falls back on its own weight. Okay. So it helps in identifying the upper pole of the kidney very well. Now you can see the stomach is coming in, or this is the stomach. Can you see the greater curvature of the stomach? Now I am almost done with the mobilization of the spleen. So my upper pole is completely free from the pancreas and the spleen. if the tumor is situated in the upper pole and you want to do the partial nephrectomy, then you need to do this maneuver. Now you can very well appreciate that you need not to retract the pancreas and the spleen because it is falling back on its own weight. एक सेकंड, क्या हिट क्या कर रहा है ये? अपने इंस्ट्रूमेंट से कैसे हिट करेगा यार ये? ऐसा कैसे? मतलब मुझे समझ नहीं आ रही बात. Now you can see this sauce muscle, diaphragm, this is adrenal gland, dirty yellow. You can see this thing, dirty yellow picture. So this is the left adrenal vein.
Right, sir.
Yeah,
Right, sir.
yeah. So it is a semilunar structure. This is the upper pole of the left kidney. Now the next step is I'll just mobilize the gyrotas fascia from the kidney. So I'll try to defatten this. Bipolar nahi chal raha.
Dr. Amitabh?
Yes, sir.
It's just wonderful surgery, very clean dissection. Thank you so much.
Yeah.
While you just continue to expose the tumor, we'll just have a very small talk by Dr. Magan. He has to leave.
Sure.
Dr. Magan, are you here? So I'm sure all of us are pretty excited by and intrigued by the robotic surgery system, but it seems like something difficult and intimidating to start at our own center. So Magan took the initiative and started robotic surgery at his center, and he has this very interesting talk on starting robotic surgery at his center. Magan, thank you.
Thank you, Dr. Vivek sir, for the kind introduction. At the outset, I would like to thank Aadhar Hospital, especially Dr. Harish Sharma sir, for having me here and giving the opportunity to operate and interact with all of you. And yes, I was told it is a courageous decision to take on the robotics in a tier 2 city and all on our own as a standalone center or a center which is not exactly a corporate practice. So here are some of my experiences in this 1.5 years of my journey with robotics at our center. So let us go back a bit. 2017, what did robotics mean in the medical world? So it meant high capital investment. It meant limited access for patients, limited access to surgeons for training, and what were the recurring expenses was one of the big worries that we had. But things have changed, and the newer robotic systems have a decreased cost to the tune of 1/3 of what the conventional systems used to be. They are more surgeon friendly with the open console, and so there is less stress on the surgeon when working on these robotic systems, and they are more like laparoscopy as compared to the older systems because they are modular. They work in the same way as we work in laparoscopy. There is increased awareness of robotic technology amongst the masses. There is a lot of buzz in the media and marketing, and there is better access to healthcare for most patients. And the technology is also improving. There is improved instrumentation. There is improved software-based enhancement of surgical skills. So the key ingredients for success, I would sum up, are a motivated lead surgeon, supportive OR team and administration of the hospital, marketing analysis of patient paying capacity, multidisciplinary involvement in robotic program, value addition, what are you giving along with the robot, and marketing and projection, clinical research and development. So I'll touch upon all these points with a single slide. So what does the lead surgeon do? So he allays fears and apprehension associated with a new concept or investment. He generates robotic surgical work through an established surgical practice. So this is like a small child that is born, and you have to assign some father to this child so that this child can come to his potential, what he can do. And then right now, wherever somebody adopts robotics, he definitely gets a first mover advantage. So anyone looking for robotics in that city will automatically land up with this person. And one has to train extensively so that the results do not, because there's a learning curve to each technique, so the results should not suffer because you're using a new technique. So that is very important. So as Lionel Messi said, I start early and I stay late day after day for 17 years and 114 days to become an overnight success. So this overnight success that you are seeing Dr. Harish Sharma in Aadhar is no less than 20 years, I feel. And that is what is required. In OR team, the dedicated team, they should be trained, they should be experienced in instrument and equipment handling. As the robotic systems platforms are becoming more open, there is role for us to
अब इसमें यही प्रॉब्लम है ना
increase
अपर
our
पोल पे अब हम
economic
नीचे से ऐसा लगता है जैसे मैं
viability
नीचे से देख रहा हूँ
by
I
better
can't go over the
maintenance
top
of
of
the
the tumor.
instruments and better maintenance of the system.
अभी वो 30 डिग्री
And
अप
your
करें डाउन
team should
करेंगे
be
तो फिर
committed to
सारा
success along with you. Then sympathetic administration, where the administration should not be looking at recovery of the capital cost from the first day of installation of the robot. Rather, we should just be looking at recovering the working costs of the robot, so that we can give the advantage to the patient who actually needs robotics. And we should provide the benefit to these patients by giving concessional rates. So this is our team, everyone interested in trying to learn. This is our training on the SSI. So market analysis. So if you see in your city, if the patients are paying for IPOM meshes and tackers, you can think about doing robotic hernia repairs. If they are paying for total knee replacements, then robotics is doable. If patients are getting bariatric surgeries and advanced surgeries done in your city, then why not robotics? So they have the money to pay. Then you have to look at the insurance and cashless facilities that your institute has. So TPAs is one of the ways in which you can generate income from robotics. And robotic surgeries at lesser cost than metros can be one exciting thing for patients who want robotics but do not have so much money to go to the metros, because in metros the same robotic surgery costs double or triple the amount. And the hospital image, so let us remember 25 years ago when we used to talk about hospitals, it was cath lab. If the hospital has a cath lab, it is an advanced hospital. It was branded as as a hospital which has the latest technology. So an analogy would be robotics in this time. Any hospital that has robotics right now has a branding that it is a center with the latest technology. And definitely integrity is a part of surgical practice which cannot be compromised on. So this is what robot is, like a James Bond image. So multidisciplinary, general surgeons right now are doing the maximum numbers in robotic surgery. Gynecologists are following suit. And urology, which actually was the starting point for robotics, is now at number 3. And GI oncosurgeons and cardiothoracic surgeons are also using. So the more the number of users in your center, the more sustainable your program will become over time. So now value addition. Value addition is the economic enhancement a company gives its products or services before offering them to customers. So when we do a robotic case, we have a robotic counseling desk, a person who explains to the patient why he is paying extra, what he can expect when he pays extra, and what will be the procedure like. So multiple surgeries with the same ports are possible. Example, it is not uncommon to find an epigastric or umbilical hernia with an inguinal hernia. So we can do it with the same ports. We can handle epigastric hernias with cholecystectomy also from the same ports. So it becomes more economical for the patient. We can follow ERAS protocols very strictly in these patients, because we, as a center, we give a tap block ultrasound guided to all our patients who undergo inguinal hernia surgery. So they are more comfortable. And planning port placement to potentially decrease post-operative pain. So let me give you an example of a laparoscopic cholecystectomy, in which I'll come to that point when I'm doing, I will be telling about procedures that we do. So advertisement has to be done extensively when we start. The robot is, as I said, is perceived as a progressive healthcare approach. Their online promotions has to be there, and this is something we should learn from the politicians. And we should use the hospital footfall to educate the patients through LED screens and flyers that we demonstrate in the OR, in the hospital setup. So this is just to show what previously it is. Now, clinical research and development, we should focus on this because this is what will decide the future of robotics. So we have, in fact, this is our publication which has been already published in JMAS, which was our initial experience with the procedure that I demonstrated today. And in fact, we are in process of publication of another publication with which is comparing the robotic procedure to the ETEP procedure for these hernias. The diagonal concept of OR setup has been published by us for facilitating ergonomics in and movement in the OT for robotic surgeries. We have got an 8.5 millimeter clip and claw forceps, clip applicator and claw forceps made for robotic cholecystectomies so that we can make it more ergonomic and more pain-free for the patient. And mindfulness to keep working on it all the time, how we can make the patient experience better and increase our surgical work by the robot. So general surgical procedures, I think midline primary ventral hernias are the first and most important. These are 2/3 of our ventral hernias. Looks very simple and looks like nothing. We are talking about umbilical hernia. But to come to think of it, ventral hernias, 2/3 of our patients are primary ventral hernias. So it is a big chunk of our work. TAPP is technically easier robotically. Expenses with an RTAP procedure may be close to a lap IPOM procedure because the mesh and tackers are avoided. And there is less pain and faster recovery, so better for the patient. And it is easy to learn and reproducible in overweight males, so that is where you can start doing. It has a good bailout procedure. You can use the same trocars positions, same docking to convert it to a TARP in case you are not able to raise a good peritoneal flap. You can go retromuscular and complete the procedure. And you can always convert to laparoscopy with the same ports. So it is an ideal procedure to propagate robotics. And in inguinal hernia, TAPP is a versatile procedure for large and complicated hernias. Suturing of mesh or plication of sac is easy. So we are working on it. We are plicating the whole sac nowadays to reduce the seroma rate in inguinoscrotal hernias, and we are seeing very good and encouraging results. And we combine procedures with umbilical and inguinal done with the same ports in the same sitting, and it closely replicates the laparoscopic procedure, so it's a good procedure in the learning curve. So cholecystectomy, just one word about it. This is the picture of a patient who has undergone a robotic cholecystectomy at our center. Can you make out a scar in the front of the abdomen? Becomes very important for young females that when they get a surgery done, that the abdomen should not look scarred. So if you can see, there are two scars at above the two anterior superior iliac spines and one in the umbilicus. And there is a 3 mm port that was made in the anterior axillary line, which is also not visible. So this was actual way in which this surgery was conducted. Because ergonomics is out of the picture, because the robot can bend at any level, we can put the trocars in these positions and do these surgeries. And because all the ports are infraumbilical, one thing, they are below the waistline, they are not visible. Second thing, the tap block works very well for relief of pain in the post-operative period. So abdominal wall reconstructions this robot is a boon for these ETEPs and TAR procedures, as the speaker, Dr. Vivek Bindal, before me has convinced you. And other common procedures, gynecological procedures, bariatrics, upper GI procedures are being done at our center. So there are different robotic systems available. You have to see your location, your patient paying capacity, your own temperament, and choose your weapon. So you can be a good warrior, just choose your weapon rightly. And definitely, I think a guru is like a live roadmap. If you want to walk uncharted terrain, I think it is sensible to walk with a roadmap. So choose someone you want to follow, and you will reach. Thank you so much.
Thank you, Dr. Magan. Very, very lovely and very inspiring talk. I'm sure a lot of us are now inspired to look into the robot more closely. Thank you.
Thank you, sir.
Yeah. And yeah.
Sir, question more to be discussed on a personal level, but I would say the conventional robotic system that was available till now costs 3 times the cost of this, the Indian robot that we possess and what is installed at Aadhar. So in more detail, we can discuss personally sometime, but wouldn't be good to discuss everything on a forum like this. But definitely it will be much more possible to break even at an earlier point, because one, it costs less. Second, there is no, as of now, there is no counter for the instruments. So the better you maintain them, the longer you can work with them, and then you can save on the cost per procedure. So both things will help.
Okay, thank you, Magan.
Thank you.
Thank you so much.
Thank
Thank you. Can we go to Dr. Amitabh Singh, please?
Yes, sir.
मोटा मोटा बाइट लेकर के
Dr. Amitabh, can you hear us?
हेलो
Can we get audio from Dr. Amitabh's OT?
हाँ so yes sir, can you hear me sir? Can you hear me sir? हेलो एक बार इस हाँ टिप थोड़ा सा डाउन करना इसका फिर से कैमरा का हेलो कैन यू हियर मी सर?
Yes, we can hear you.
Yeah, sir. So what I did actually by meantime, so I just और नहीं हो रहा है. I defattened the kidney. I incised the Girotas fascia. I mobilized the perinephric fat from the capsule of the kidney. Okay. So the purpose was doing this thing was because it is a upper polar tumor. So I need to see this tumor all along.
Sir, how did you decide the margin?
Okay, so now what we do actually, because if you'll see the CT scan of this patient, then majority of this component is endophytic, but this part is exophytic.
Okay, sir.
So the good thing about these tumors are they are capsulated tumors. So even if there is like 20% or 30% exophytic component, you will have some impression on the kidney surface. Like is in this kidney, if you'll carefully observe, like then you can see somewhere the transition point is here, because from here you can see the exophytic component starts.
Yes, sir.
And this is the normal parenchyma. Although if you have some difficulty, then intraop ultrasound can help you, and it is a very good tool, especially for the partial nephrectomy. In our center at Rajiv Gandhi, we routinely use intraop ultrasound until unless it is a completely exophytic tumor. But here we don't have ultrasound, so we don't mind that. We can use our clinical actually acumen, you can just to identify where is the margin of this tumor. So okay. I think you will be agreeing with me. This is the probably the transition point. This is the from where the tumor starts.
Yes, sir.
And all along the tumor I marked it. You can see this marking all along this tumor. Now this is the posterior part of the kidney. So I mark it here also. नहीं सर वार्ता है नहीं है ना, फिर से एक बार देखो, फिर से करो ना, because I can't see posterior tumor ना. हाँ. पहले जीरो करो तुम एक बार, पहले इसको जीरो करो. हाँ, do it जीरो. हाँ, अब हो रहा है ना 30 डिग्री डाउन. हाँ, हाँ तो पोर्ट बाहर करो, पीछे करो थोड़ा सा. Yeah, like this. हाँ, हाँ. हाँ, थोड़ा सा और पीछे कर लो. Port. So because this patient is very thin, I'm not getting enough space for the instrument. So that's why I'm just taking out my port out, just to get enough working space.
Yes, sir.
Yeah. हाँ, अच्छा, मैं कुछ नहीं कर रहा. बस enough है मुझे मेरे हिसाब से. Now you can see this posterior margin of the tumor.
Yes, sir.
You can appreciate very well.
Yes, sir.
Yeah. So this is हाँ ठीक है चलेगा. So this is the normal parenchyma, and from here you can appreciate this bulge of the exophytic component.
Yes, sir.
So what I'm presuming that from here the capsule will go endophytic. So I'll just dissect this normal parenchyma. I'll try to get up to the capsule of the tumor, and then I'll dissect this tumor all along this thing. देखना सर कैमरा फिक्स है ना, हमको लग रहा लूज हो गया है कुछ कैमरा वहां से. ठीक है, ओके, ठीक हो गया. अच्छा ठीक है. हाँ बुलडॉग आप ही को लगाना पड़ेगा, बिकॉज इट्स अ लैप्रोस्कोपिक बुलडॉग ना, इट्स नॉट रोबोटिक बुलडॉग. सो now I have marked this tumor all along from the posterior surface, from the anterior surface, lateral and the superior aspect. So now my next job is to clamp the renal artery. And now my vascular tape will help me in applying the clamp. So here we do have this laparoscopic bulldogs. So Dr. Sarvartha will apply this clamp via laparoscopic bulldog applicator. So I'll be just assisting him for the application thing. 1 second. 1 second. आ जाओ. दिखाऊं? ठीक. 1 second. आ जाओ. इसको रोटेट कर लेते ना? रोटेट कर लेते इसको. हाँ ऐसे. Okay. Come. थोड़ा सा ऊपर, एओर्टा से दूर थोड़ा सा. हाँ लगा दो. So now you can see the artery is clamped.
Yes, sir.
You can see the blanching of the kidney. Okay. Can you just mark the difference in the color of the kidney?
Yes, sir. Yes.
Yeah, now, okay. And now the kidney will become soft also. Because the arterial supply has been taken off from the kidney, so the parenchyma will not be as turgid as it was before, when there was supply.
Yes, sir. Yes.
So now just I'll just 1 second by 1 second bus. Just, है ना? Now just I'll be incising the capsule first of the kidney. I will try to reach up to the capsule of the tumor. Now you can see this is the cortex, this is the normal cortex, and I'll follow this plane. Now because I have seen the normal parenchyma, so I will follow this plane only. हाँ, कोई नहीं देखता हूँ, section ले आओ अगर कुछ है तो. ला सकते हो? आओ. हाँ, दबाओ इसको. ओके. इसका टिप थोड़ा सा डाउन कर सकते हैं कैमरे का. एक इंस्ट्रक्शन हटा लो पहले. हाँ, कैमरे का टिप डाउन कर लो. हाँ ठीक है, कोई नहीं. So the concept is basically just dissect this tumor all along. Don't have a very limited working space. Dissect the capsule of the kidney in a very wide fashion so that you can see the parenchyma. Now just I have flipped the kidney. I will just incise the posterior capsule, parenchyma. So you can get a little bit ooze from the parenchyma because kidney is a very vascular structure.
Yes,
so
sir.
there will be collected blood. You can get this small amount of bleeding, but nothing to worry about this thing. Now you can see this thing. Now there is a very good margin of the normal renal parenchyma over
Yes.
the tumor.
Oh.
So I am 100% sure that I am not violating the renal capsule, this tumor capsule, suction. Okay. Now if you get some oozing, continuous oozing, so it's probably venous ooze, it's not arterial ooze. So you can apply a bulldog on the renal vein also, just for your comfort.
Okay, sir.
Yeah. So I'll just see if like there is a significant ooze which is like hampering my field, then I will apply the renal vein clamp also just to have a avascular field. Otherwise, I'll progress with this thing.
Hello. Next OT ready.
1 second.
OT
one
number
second,
4.
1 second.
21-year-old female patient with BMI of 17.6 presented to us with complaints of 21-year-old female patient with BMI of 17.6 presented to us with pain in epigastric region associated with nausea and vomiting, and on and off episodes were present since last 3 years. A USG was done which was suggestive of secular cystic area of size 4.8 into 1.7 centimeter in proximal part of CBD, which was suggestive of choledochal cyst. MRCP was done which was suggestive of fusiform dilatation of CHD, proximal and mid CBD, maximum caliber 22 mm, smooth tapering at mid and distal CBD level. Fusiform dilatation of left hepatic ducts was seen, maximum caliber 16 mm. Mild fusiform dilatation of segmental left hepatic ducts, and it was suggestive of 4A choledochal cyst on classification. This was MRCP films of the patient. This was Torani classification for choledochal cyst, and in our patient it was suggestive of type 4A. The plan is excision of choledochal cyst with Roux-en-Y hepatico-jejunostomy.
एक मिनट हाँ मेरे को दिख नहीं रहा मेरे को ये दो नहीं तो इस टेबल भी ऊपर लो सर
Yes, Dr. Sailesh sir, you are connected, sir.
नहीं हार्मोनिक सर डिसीजन चल नहीं रहा है क्या देखो मेरे को ये दो सिस्टम सब ऊपर से ले रहे हैं हेलो
Hello, sir. We can hear you.
हेलो
Yes, sir. Can you hear us?
मेरे को हाँ yeah I can hear you
Yes, sir. We can see your screen, sir.
so we are just starting this go inside so we are just starting this now
Right, sir.
so you see now this is the area I have told my assistant to lift up the gallbladder yes can you see that
Yes, sir.
and now मेरे बीच में आ रहा है तो उधर से कहाँ यार तू खींचो या ना एक मिनट छोड़ ये क्या है ये ऐसे पकड़ना ऐसे और ये हाथ से नीचे खींचो so go inside now the first step is to have the gallbladder up which is what has been done and now this is the entire area उत्कर्ष मेरे सामने मत खड़ा रहे इधर आओ and now we dissect can you see the dissection
Yes, sir.
so we are now going अरे तू वहां से मेरे सामने से बाजू हो now we are going towards the area so this is the supraduodenal portion this is the supraduodenal portion sir table थोड़ा ऊपर लो और right side up चाहिए मेरे को so now what we are doing is we are trying to go between the cyst this is the choledochal cyst and you can see this is the area that we have to go slow and steady this is the supraduodenal area you can see that we are just going there slowly but steadily so this is the lower portion of the duct and this is very very critical that at this stage you should not have bipolar do mere ko so these are very very minute vessels which are to be taken care of when you do this surgery and slowly and steadily we have to work our way first in the supraduodenal area so I will take this now and try to go in this plane so this is the plane can you see the plane nicely coming up there
Yes, sir.
these are the vessels which are very very like these are the 9 o'clock and 11 o'clock vessels which have to be taken and then you go ahead and take care of these areas so this is the plan is to take out the entire duct and then do a hepatico-doco jejunostomy मेरे पैर की तरफ जो so do a hepatico-doco jejunostomy now important thing when you want to do this is to make a plane between the common bile duct and the portal vein that is a critical plane that we have to do so slowly and steadily we are moving our way slowly there they always and always remain parallel never go perpendicular to the tubular structures so what I will now do is I will take a stitch there stitch dena because this should not have happened but that's fine because this is too dilated I am just holding this Go, turn the camera. Turn other way, other way. Haan. So we will slowly and steadily, can you see the plane that I am developing, sir?
Yes, sir.
Yeah?
Yes, sir. Very nice.
And below that you will see the portal vein coming up. So slowly and steadily, can you see the portal vein lower down?
Yes, sir. Absolutely.
So this is the plane that is very, very critical and has to be done very carefully. Now, instead of, I think I can do one thing, I can get me a clip. Arre, kya kara? Clip dena. Instead of taking a suture, I can also use a clip. That is not a problem at all. Clip dena. कुछ भी नहीं लगाया क्या? Simple clip do. So what I will do is, ये pull करो जरा नीचे. So I will use a clip where there was a थोड़ा सा बराबर दे. I will use a clip because इसको पकड़ो. I will use a clip because anyway this is going to go. So this is where I have used the clip, and now I will continue with the dissection. So you see now, this is the choledochal cyst. Can you see the portal vein coming up, sir?
Yes, sir.
So come back, come back, come back, come back, back. ये छोटा तुम्हारा, ये तुमको लगता है तो आपने पकड़ा, लेकिन ये ना ऐसे पकड़ो. चलो, चलो गो. नहीं छूट रहा है तुम्हारा. चलो, हाँ चलो. Now this is, मेरे को गॉस देना. This is the plane. That is, give me the suction. I think that has come out. The clip has come out. Clip has come out. So it's not good. I'll take a suture. Otherwise, उसको नहीं लगाया है तूने ऐसे. You're making things difficult for me. Huh? Okay. Anyway. Till the time he gives me a 2-0 suture, we will go there and try and take this entire thing on this side. So you see now, can you see the plane that I am developing?
Yes, sir.
Yeah? Yeah. See this? And now this is a very, very big cyst, so it doesn't matter. This is the plane that bipolar though. It is very critical to develop this plane lower down. It is not the more the dilated choledochal cyst is, it is sometimes more vascular, and that is very, very important for all of us to realize. It is not the vascularity which is dangerous, but it is something which is so slowly and steadily. Can you see the portal vein coming up nice and clear?
Yes, sir.
And then I have to go across. So this is a nice plane that I have developed. See that? And from here on, I will go here and do this complete removal. So this is the plane we have to use. Go there. Again, you can see the lymphatics coming up. These are the lymphatics because of the dilatation. And now go back, 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 back. And now see, this is what we are going to do. Slowly but surely, we are going there and taking this plane. And now we go downwards. I can always use any instrument, but since you can use this, so this is something which you have to be careful. These are the supraduodenal vessels, which will always cause problems and have to be taken carefully. So this is where we are going to do. Thoda khicho, please. And one suction, suction. And gauze dena baad mein. Chalo. So this is the plane that we are going. This is the plane, this is the area. The vessels are now slowly, can you see my suction coming from there?
Right, sir.
Yeah, so this is the plane that we will develop. Maryland, please. And see now. This is the entire, Maryland बोला तो वही ना, पीछे चलो. हवा नहीं है. ये इधर से ये कट गया है. चलो देखो, चलो अंदर. Okay. Now this is slow and steady. We go there and I think we will come out from here very, very easily. So this is, now I need the 45 degree. And this is the instrument of choice. Always go parallel and then you will be able to come out from here. This is the correct plane. Can you see that now?
Yes, sir.
Yeah, let's come back. Once this is done, you see the portal vein has gone away. This is the structure that has to be taken. So you see now, you have to be very, very careful there. I have gone there, and now what I will do is I will now see and separate these structures. Can you see the portal vein nice and clear, sir, below?
Yes, absolutely, sir.
And these are the, ये बराबर नहीं लगाया है ये, बराबर लगा के दो, टाइट नहीं है उसका, टाइट नहीं है, क्या किया इसके ऊपर, रेड्यूसर के ऊपर रेड्यूसर, चलो. So this is the plane that we have to take. These are small, small vessels that I have to take care so that I don't damage anything. This is probably the branch of the hepatic artery. See? This is probably the hepatic artery which is coming up, and then slowly and steadily we will work our way downwards and towards this area. So we have got this now, and so again slowly, all this is very, very small, small vessels which are supraduodenal, and these supraduodenal vessels have to be taken. Can you
back with you OT number 3. OT 3 you are connected, sir.
Hi, Dr. Amitabh, can you hear us?
Yes, sir. I can hear you, sir.
We see you removed the tumor, you are closing the defect now.
Yeah. So I have removed the tumor. Now just I am doing the rhinography. So the main problem here was just space, because I couldn't get enough space to mobilize the kidney, because I need to flip the kidney, I need to dissect it posteriorly, anteriorly, everywhere. And the instruments were struggling actually, they were clashing with each other just because this patient is very thin. And even after pneumo, there was not enough space in the abdomen. But somehow I could able to dissect this tumor. Now I'm just going for the rhinography. So this is a barb suture, a V-lock suture, 3015 centimeter, 25 mm needle. So good thing about the barb suture is that once you just take it and you pull it, it becomes hemostatic suture almost. So you need not to be very precise with this suture. You just take it, do it, and pull it. Because kidney is very vascular structure, so we need to be very careful because the rhinography is very important. So partial nephrectomy has a lot of complication. If it goes well, the patients, they do very well. But if suppose procedure don't went well, then they do very badly. There could be pseudoaneurysm, there could be AV fistulas also, there could be secondary ooze because of the infection from the renal bed also. You can lead to positive surgical margins also if you're not having very good vision, and leading to the compromised survival rate of this patient. So if you are starting the partial nephrectomy program at your institute, then I would suggest you have a very good experience. First of all, start with like open, lap, whatever, but learn all the skills of doing partial nephrectomy. So it's not simple procedure. You need to be very careful. So I'm just trying to take this suture, inner rhinography, After completing inner rhinography, I'll take suture for the outer rhinography, and the procedure is finished. And by the meantime, I need to take care of the warm ischemia also, because I have clamped the renal artery, I have clamped the renal vein. So literally at this time, there is no blood supply to the kidney. And it is the basically ischemic time for the kidney. According to the studies, they say that we can safely clamp the renal artery for almost 25 to 30 minutes. But if the parenchyma is very good, there is no CKD element, chronic kidney disease, glomeruli are very normal, healthy, without any fibrosis, then the warm ischemia can even go up to the 45 minutes also, without having any significant impact on the GFR in follow-up of this patient. So I'm just trying to finish it as quick as possible, because I think warm ischemia is almost 15 minutes already. And almost I am done with the inner rhinography also. I'll take just 3-4 more suture, and then I'll be finished with the inner rhinography. But not but the least, it is very important to be 100% sure before leaving this thing that there is no renal sinus or the renal artery left over behind. Or if there is any pelvic calyceal system which is open, you need to close it also. Otherwise, the patient will get the urinoma at the same time, which will lead to the secondary infection to the patient.
Sir, we will always cut the tumor with cold scissors?
Yeah, so because the whole concept is just to preserve the nephron. So if you are using any energy source for cutting the normal renal tissue, so there are two side effects. First, there is a collateral damage, thermal collateral damage, and they will disturb the plane also. So you won't be able to see the, like you are entering the capsule of the tumor, you are leaving positive surgical margin or not. If you want to revise your plane, then it also becomes very difficult at the times. So it's always preferable to cut the parenchyma with cold scissors so that you can see the planes very well. You don't do any collateral damage to the tissue.
Okay.
Yeah. बाइपोलर बाहर आ गया, अंदर पुश करना थोड़ा. हाँ दे दो अंदर दे दो. हाँ ठीक है, चलो आओ हेमोलॉक लगाओ. इसके बाद वो मोनोक्रिल सूचर दे देना. कितना टाइम हुआ वार्म इस्कीमिया? व्हाट इज द वार्म इस्कीमिया? हाँ 20 मिनट्स. ओके ठीक है. सो warm ischemia till now is 20 minutes. We have got 10 minutes left. एक सेकंड सर बात, एक सेकंड. हाँ आओ. ओहो एंगल पे लग गई क्या? हाँ लाओ मोनोक्रिल वाले दे दो. छोड़ो. So now I am done with the inner rhinography. Now I will take interrupted suture for the outer rhinography.
Okay, sir.
Yeah. हेमोलॉक लगा है पीछे? एक सेकंड बस, एक सेकंड.
Yes, Dr. Salik sir, you are connected.
एक सेकंड देखता हूँ पहले मैं.
Hello, can you hear me?
We can hear you.
Okay. What I am now, छोड़ो नीचे, बस हवा नहीं, छोड़ना नीचे लेके. Now what I am doing is I am just taking out the gallbladder because we have reached the upper limit of our
Dissection.
yeah. of the CBD. Show me down. So you can now see this is ye upar utha. Yes. So I will just take care of the bleeding now. Wherever there was bleeding, the gallbladder
This
is
was
very,
intrahepatic gallbladder, that's why so
yeah,
much of
come back,
hepatitis.
back. So this is the upper limit. You can now see, so we are just trying to get the entire gallbladder and the entire choledochal cyst there. Can you see that?
Yeah.
And now I need a suction so that I can show them better. So we will just take care of this. Whatever biliary leak is there, it will stop the moment we go there. This is the area that we are, so this is the upper limit. Can you see that?
Yes, yes.
Yeah, now what I will do is I will use the scissors and take this away. So this is going to be the biliary little amount of leak which will continue there, but it doesn't matter because that is the upper limit. Can you see the portal vein,
Yes,
sir?
yes. Posteriorly.
Completely nice and clear.
Nice and clear.
So, so this is the area, and we can always use bipolar though. We can always use the liver mein mat ghuso. We can always use the harmonic, but I don't use the harmonic. The reason being, the harmonic is
After all, it is an energy device.
yeah. So I don't like to use harmonic there. I will not use harmonic here. Scissors, please. And now you see this is the entire area that we have gone into. Scissors, please. And this is where I will join. So I don't take stay sutures. Arey, ye ghoom nahi rahi hai. Chalo. And this is where I will take it now.
You will cut
So
it obliquely.
Yes,
Yeah.
and little bit. So this is at the level of the, can you see hepatic duct, both of them?
Yeah. Confluence.
Confluence. So I made it into one. Can you see that now?
Yes, 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 yes. Now we
And
can
there you can see the confluence
right,
very
yes, yes.
nicely.
Very, very nicely.
And this is the plane that we have to be very careful about. Now there will be always a vessel there at 9 o'clock and 11 o'clock. So this is where you have to be careful.
Vessel to the duct.
Yes. So this is probably the cystic artery.
Arteries.
Yes.
It is a branch of cystic artery. I believe.
Yes. So I will take care of this. The patient ko. And this is the final area. So this is where I will now use
Harmonic again.
no harmonic. So this is the plane. This is all coming from the liver area, but I have to be careful that we don't have to go there. And this is, I can have a gauze now. ये निकालो, gauze दो. जो पहले ही बोला था, अरे क्या करके? Because all this should have been ready, no, before. So give me the, I will use a gauze there so that the little amount of liver bleeding will also stop. It is go inside. Yes. कौन सा हाथ उससे किया है? So this is, can you see the duct now?
Yes, yes, yes. Very well.
Very clearly.
Very clearly.
And then there is a bleeding from underneath this area. Yeah, under dalo.
From the margin.
Under dalo. So what I will do is I will take care of this. This is the bleeding area. And there is a little bit of bile which is coming. So what I will do is I will take care of these bleeders. These bleeders. This is a small bleeder there, and show me here. And this will, there you can see the bleeder very carefully. You just take care of this. That should be the end of the story. over here, and again, isko pakad ke rakho yaar. Yeah, and there will be a bleeder on the top also. So here also we have to take care. As I said, usually 9 o'clock, 11 o'clock is the bleeding, and this is the bleeding which is coming from the cut edge of this area. So this is fine, and then this also we will take care so that it stops. Okay?
Excellent.
Now this is, show me. अच्छा गॉल देना ऐसा आड़ा टेढ़ा नहीं चलेगा ना. And now I will just place it there for the time being, and now we will take care of this. Oh, ये इसको पकड़ो. Just hold it with your right hand, and then this is the choledochal cyst. Give me the ligation. As much low down as possible we have to go down. So this is the entire choledochal cyst which has to be taken out. हवा कहाँ से जा रहा है? So this is the cyst. Now this is the retropancreatic one that we are entering into. I will need the vascular clip again, and this is the entire area that we have to take care. These are the vessels which will always be there in the supraduodenal area, and that have to be taken care of. So you see now the entire cyst. This is coming up. Hawa band karo, hawa. So this, choda abhi. And now this is the retropancreatic area. You can see the pancreas coming up. Can you see the pancreas lower down, sir? This one.
Yeah.
Yeah, so that is the pancreas. You don't have to damage that because that will cause more problems. And from here also we will go ahead and take this off now. You see now, okay?
Yes.
I have almost taken this right below, yes? And now I can use a clip there. Click on. And now give me a bag to put that. अरे तुम बंद कर, इधर देखो ना, फर्स्ट टाइम कर रहे क्या? हाँ? क्या करना चाहिए? Hold the port for me. बस port को hold करो. And now I will use this hemoclip and scissors. So that is the complete excision part which is done now. Show me. And that's it. So we have taken it out. Now the next part is to do
Anastomosis.
कुछ भी रेडी मत रख, तू तुम्हारे हिसाब से चलता है. चल. Now this is the bag that we always use wherever we use this. We publish this as the Galaxy bag for removal of multiple specimen. And this entire thing will now go inside and sit there. Now I need a clip so that it doesn't come out. Vascular clip though. अरे तू क्या कर रहा है यार? फटाफट. Now this clip we will put so that it. अरे तू बंद कर. तू क्या कर रहा है यार? तू समझ के करना. उसको पोर्ट को पकड़ना तू. पोर्ट को नहीं पकड़ेगा तो कैसा होगा? You have to hold the port. पोर्ट को पकड़ो. हाँ छोड़ो. बस. Hold. Leave it. So I need now the suction. So we उधर उसको छोड़ दो उधर. So it will remain there now, and now we will go for jejunostomy, hepaticodoco. So this is, I will just suck it now for the timing. ऊपर पकड़ो, and this is the duct. Now before we go ahead for the jejunum, you have to make sure that it is separated out from all around. Can you see that?
We
Yes,
are
sir?
losing the picture in between. I do not know why.
What?
we are losing the picture.
Sir, can you see the bifurcation of
No,
the...
we can see very well, but in between it goes away. Yeah.
Sir, can you see the bifurcation of the portal vein?
Yes.
Don't imagine, tell me if
No,
you
no,
don't,
no, no.
then I will show you again.
No, it
because sir, this is very, very clearly seen.
I know,
See.
Shailesh, about the preemptive anatomy
The
which we
clear
always
view, I
highlight.
think audio visual bipolar though. So this is this is a clear picture, sir.
Yes.
Vashish sir.
Bilkul, bilkul.
So this is the division you can see, and these are the two ducts which are inside and go inside. Can you see the right and the left duct, sir?
Yes, sir.
Yes, and this is the duct. This is the CBD, which you can see and this is the bifurcation of the portal vein. Can you see that very clearly?
Yes.
Yes. So this is the end of the story now here. What I will now have to do is to take, come down.
Bring out
Idhar hi khade raho.
the jejunum.
Now we have to take, so I will take everything on the top there, show me. And from here, 1 minute, huh? Arey tu camera ko chhodna nahi hai re. Nahi. You have to hold with your left hand also. So what I have to do is, I have to take care of the, isko pakadna left hand se, isko. Now this is the duodeno, this is the duodenojejunal junction.
Yeah.
And now from here about 30 to 40 centimeters. So we will keep on moving this. And so we go. This is the distal part of the jejunum. So we just go there, go here, go. And I hope this is more than sufficient.
Yes, yes.
So can you with your right hand hold this? With your right hand. With your right hand. With your right hand. Hold this. Yes. And now show me on this side. So again what I will do here is, show me down. So this is the colon.
Yes.
This is, so what I have to get it is from below. So this is, can you see the duodenum and the pancreas, sir?
Yes, yes.
So now he has to hold this. Isko pakadna. Isko left hand side. You have to just hold this. And now I need a ligature. And this is the plane for hemicolectomy. So
Yes.
this is the plane that we go. We always identify the duodenum and go between the duodenum and the mesocolon. So can you see the pancreas coming up now?
Yes, yes.
So this is the mesocolon and the pancreas. I am making a plane there because this is the most avascular plane which is here. And then I have to go there from underneath, take the duodenum down. Can you see the duodenum
Yes,
going down now, sir? This one.
Yeah.
So this is the duodenum which is going downwards, and this is the plane from where you will have a nice window which I am creating so that you get a nice and clear retrocolic anastomosis. So this is the plane. You can see the pancreas beautifully there. I am remaining on the top of the pancreas and I am creating a plane there. So this is the plane that and there I can see the liver.
Yes.
Can you all identify the liver there now, sir? Yes?
Yes.
Vashish sir, ठीक चल रहा है ना?
Yes. I think, can you hear me?
Yes sir.
हाँ तो मैं बोल रहा हूँ भाई.
नहीं ठीक चल रहा है ना?
बहुत बढ़िया चल रहा है.
Because ये हरीश ने मेरे को लास्ट मोमेंट पे
नहीं हमने
ये
प्लानिंग
करवाया.
नहीं, दो घंटे से प्लानिंग कर रहे थे हम.
Because he said नहीं सर ये दिखा दो. तो I have made a plane now. This is the hemicolectomy plane that we normally use.
Yes.
And now show me the
It's a door
jejunum
rather
that he
than
is
a
holding.
window. Shailesh,
Sir.
it's more of a door than a window. Wide enough.
So all this is my oncology experience putting to the highest level.
Yes.
Because chod do, dono haath chhod do. So this is the area. I have got the jejunum on the top. See
Right.
this?
Yes.
And now what I have to do is I have to take this up as much as possible. And now, give me the, no, show me, अरे
छोड़ना नहीं बाबू.
कैमरा को नहीं छोड़ना है, कैमरा को और ऊपर लो. Now, ऊपर जाओ, चलो ना दिखाओ ना यार. अरे तुम दिखाओ भैया, तुम ऐसा क्या कर रहे हैं, ऊपर जाओ ना. And now we have to go and नहीं तुम्हारा हाथ है ना वो सिर्फ liver को
Inside
उठाएगा.
inside picture.
Yeah, अभी this is the plane that we have
Inside
to.
picture.
इधर पकड़ो. Left hand किधर है तुम्हारा? एक मिनट छोड़ो. इसको ऐसे पकड़ना और इसको ऊपर देके जाओ. बस. Can you see, sir? Vashist,
Yes,
sir?
yes.
Now I will use the Sony Season. इधर देखा करना, तू पीछे क्यों देखता है? Now just get your right hand up there. So you have to make sure that it reaches that area. I will need another 10 mm port if needed. And he is not able to show me. So this is the area that is reaching, and this area, if it is reaching, now I have to take a cut and I have to open the jejunum. Can you see the jejunum being opened now?
Me you have done.
Yes. So this is enough, and now I need a 30 Vicryl. So I don't know whether. अरे तू इधर देख ना. What is your problem? Without seeing, देख भैया अंदर जाना पड़ेगा ना, और ऐसा घुमा के नहीं. 6 o'clock को देखना चाहिए पूरा. 30 Vicryl. इसको उठाओ. So what now we have to do is अरे तू क्या कर रहे हैं यार? सिंपल है ना, 0 डिग्री है ना. अंदर चलो ना. चलो अंदर चलो. I have to see the bile duct,
Yes.
which is here, and now this is suction देना. कुछ भी तू रेडी नहीं रखता है क्या? तेरे को 30 लेने को बोला था ना, तो क्या issues है तुम्हारे? So this is the area, and now this is 1 minute. Now this is the plane. This is going to be a little bit of bile अरे यार sister ऐसे नहीं ना, with the reducer ना. Hero, हाँ? आता नहीं है क्या?
Fit नहीं हो रहा क्या reducer?
Yes is no. Now I have to use a 30, and this is I have been doing this Whipples for a very long time. In fact, we have demonstrated Whipples multiple times. Wait, you are not doing it right.
I have been lucky audience to your people so many times, including Galaxy Care.
Chalo. Now I have to take care.
Please. Shailesh, just a 2 minutes break.
Yes.
We are switching because he is completing the nephrectomy and closing the fascia. Hello, Amitabh.
Sir, I am done. Hello, sir.
Yes.
Yeah. So, थोड़ा सा नीचे दिखा दे specimen. So this is the specimen. Can you see this one? One second. Suction हटाओ. ये port नीचे दबाओ. आप port नीचे दबाओ. Yeah. So this is the specimen.
Yes.
Yeah. And I did rhinography after, and I have covered the kidney with the perinephric fat and the gyrota again, so that there should not be any torsion on the renal vessels, and it will just maintain the natural anatomy also. And after that, I'll just put the specimen into the bag and I'll just deliver the specimen. That's it.
Great.
So the operation is done.
Should we
There
clap?
is no bleeding, and warm ischemia is almost 30 minutes.
Good job done.
Yeah, thank you, sir.
Back to Shailesh.
Yes, sir. Now
So you are
the
doing
important thing.
posterior row.
Yes. So this is very important that you take the mucosa and the serosa. Show me on the top. छोड़ो, तुम बहुत आगे पीछे मत करो. So now it is important that I take this. Now 1 minute. So this is where we have to do the suturing very well. Go in. Once this is done, show me.
ऊपर लेके जाओ बेटा इसको.
Now you have to square the knot. So take your small the small end of the thread, lower down, छोड़ो, and go inside, and then it has to be there. So I have gone there. Can you see the
Yes,
CBT?
yes.
And come back. So this is the first suture that we have taken. Sister, थोड़ा instruments को पानी लगाओगे क्या? And then ये वाला left वाले को, and then हिलाना नहीं. So then again we go there and we take 1 and we take 2, and then we can go ahead and पानी नहीं लग रहा है ना, तो इसकी वजह से वो इंस्ट्रूमेंट अंदर नहीं जा रहा है सिस्टर.
बीटाडीन लगा दो पानी नहीं तो.
हाँ. So now once this is done with the right hand, scissors दो, scissors दो. अरे इसके ऊपर हाथ रखो. So once this is done, then what I am going to do is the excess amount of thread which is there has to be cut. This is out, this is out. Now I need the needle holder, and you have to use suction दो पहले, and you have to use your right hand with the Maryland. इनके हाथ के right hand में Maryland दो, इनके right hand में Maryland दो. So, and now what I am going to do is that he will now use this. Now slowly and steadily you will see how I do this. Give me the needle holder again. इसको पकड़ना. And now it is usually I never have done in my life interrupted suturing.
You will do continuous.
I have always done continuous non-locking sutures, and I have even in Whipple surgery, and I have never had any issues about this. So this is probably the most important suture, because this will straighten out my entire anastomosis. छोड़ो, एक मिनट, हाँ, एक मिनट.
थोड़ा ऊपर लेके जाओ उसको.
पकड़. नहीं. This I will now. I will take this out. तो दबा, वो दबा, छोड़. So I have taken out the gauze piece because it was coming in my way, and now you see that anastomosis becomes easy, because now can you see that?
Yes.
So you have to be careful.
Inside out and outside in.
So this is very important that you don't go through the portal vein. A lot of times I have seen people going through the portal vein and then landing up into controlling that. पीछे चलो ना. So then control. So I have to be sure that I have to rotate this. Can you see that now?
Yes.
Very clearly, sir?
Yes.
And you have to make sure that you go through the serosa as well as the mucosa. Because if you don't do that, then it is a difficult area. Have you brought stores forceps? चलो छोड़ो. नहीं ठीक है. So again, 1 minute. I will do it. चलो पकड़ो. अरे पकड़ के उस तरफ लो, तुम्हारी तरफ. हाँ, लीवर को लेफ्ट हैंड से उठाओ. Again, Vashish sir.
Length of suture 2 hand.
Length of suture is very critical, because you have to make sure that it is not a very big suture. And actually at this stage we use a very small and delicate forceps, which we haven't bought today with us, the one which we use for undilated CBDs. So this is something that I have not brought, but no complaints. We go ahead. take this out, and you will see slowly and steadily. See, okay?
Yeah, yeah.
Now it is coming in one line.
Yes.
Show me this needle. And sometimes if you don't see so higher up, then what I do is I take the port, one more higher port that I take, so that my cameraman is able to show a good picture. But fortunately, right now things look okay.
Yeah.
Can you see this?
Yes, yes, yes.
And we are taking nice and very good. One more Vicryl I will require, sister. उसको पकड़ो. ना 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 ना. अरे इसको छोड़ना नहीं भैया. Go in, go in. Now again you have to make sure this is the area. So तुम्हारी तरफ खींचो. And you have to make sure that this is. Now again here. And
now you will do the anterior one.
Yes,
So you have
this
taken
is
it
a
out.
very, very
Yes,
delicate
yes,
kind
yes.
of suturing.
Yes,
Do you agree or no?
Yes, yes, yes.
So you have to make sure that everything is in correct line, and you have to make sure. Now go inside. नहीं, इसके अंदर डालो रे. मेरे को दिखना चाहिए ना भैया. और तुम्हारी तरफ खींचना चाहिए.
और कम पकड़ना
So
चाहिए.
पकड़ के you have to pull it. He has to pull it towards him, and then actually we are using a 3-0 Vicryl. Ideally, sometimes when the things are not very, very delicate, then नहीं इसके अंदर डालो यार, तुम्हारा left है. And so sometimes no, छोड़ दो उसको. नहीं, जो मेरा पकड़ा है वो छोड़ो. जो पकड़ा है वो छोड़ो. थ्रेड को छोड़ो. Because you are preventing me from doing the suturing. So then, 1 minute, don't do anything. I have got this, I have got the needle there, and then what I will now do is again go through this, the last suture. Can you see it coming?
Yes, yes, yes.
Oh, oh, from where? And then again I will go from here, and 1 minute, and now I will come back. I will get out from here now. 1 minute, and from here I have to
Come back.
no get
Come out.
out.
Come out, yeah.
So that it is now a very, very. उसको पकड़ो. So this is the entire posterior suturing suction. Show me.
थोड़ा saline की पिचकारी मार लो यार.
So now this is the entire. I will show you. Go inside. Can you see the posterior suturing?
Yes, 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 yes.
Are you happy?
Absolutely.
Now we will start with the anterior
Anterior.
wall suturing, and then that should be the end. This is a very higher up anastomosis. So if you want to do open also, it is difficult. नहीं, liver के अंदर बराबर डालना भैया. If you want to do the anterior wall, I mean this is a way. तुम्हारी तरफ खींचो वो. हाँ, तुम्हारी तरफ खींचो. हाँ. Now I will start with the anterior wall suturing. So here it is very, very important to take the angle. So what I will do now is I have to take this outside. The knot has to be on the outside. So I will take outside in. Look at this, how
Yes,
we take
outside
it now. Yes, so we go there. 1 minute. And we go from the angle, which is very, very important. Yes?
Outside in and inside out.
Now,
from the duct.
once you go from outside in, then it is easier to go on the, chod do. Then it is very easy to go on outside in on the CBD.
Yes.
Okay?
Right.
So now once this is done, now बहुत ही छोटा दिया रे तुमने। इसको थोड़ा सा पानी लगाओ यार, नहीं जा रहा है वो इसका, मेरा पानी में से प्रॉब्लम है। सो वी विल, अरे मैं ले रहा हूँ तब नहीं। So this is, now you cross your hands and square your knot. नहीं रे, दूसरा reducer दो।
Knot लगा दिया।
You cross your hands and now you see it has gone very nicely. Can you
Yes.
see that?
Yes, yes, yes. Secure
And
knot.
once this is done, he has given, I told him that he has given a very, very short. अरे दूसरा देना यार। I'm just changing my reducer because there is a little problem with that knot coming out. अंदर डालो. And now I have to take 1, 2 more here. So this will square the knot nicely. I have already squared it, but still we just want to make. Okay?
Good.
It has broken. अरे तुमको क्या? So anyway, we will do another one now because this thing has got broken. So he has to hold this with his right hand now. 1 minute, yeah. And we will take another one because the thread broke. That's fine. And now we go ahead and take this suturing again. So this is 30 Vicryl. अरे इसको थोड़ा पानी लगाएंगे दोनों reducer को तो. Go in. Now we will again go and take this and no, go inside.
Dr. Shailesh?
Yes.
So as you're completing the anastomosis, we'll just have a very small talk by SSI Mantra. We'll continue to watch you do the anastomosis.
Just now?
Yeah.
Okay.
Thank you, sir. Can invite Dr. Vishwa. He's from SSI Mantra.
Okay. So this is, go inside. अरे अभी बहुत ही लंबा दे दिया यार तुमने। क्या optimum ले?
You have started from the duct side.
Size of the needle holder. वो ज़्यादा हो गया। ठीक है, चलो। दिखा। Okay. Dr. Vashisht. Scissors दो. चलो.
Good afternoon. First of all, on behalf of SS Innovations, I'd like to take a moment to extend our gratitude to Dr. Harish Sharma sir and Aadhar Hospital for arranging such a wonderful conference. I think it's been very captivating. It's been really nice to see all types of surgeries being done here. You saw 2 surgeries on the Mantra system, and now you're seeing Dr. Putambakar here. I just think it's been absolutely brilliant. So I wanted to talk to you just briefly about how to advance surgical robotics in India. And I'll go a little bit into just a short story of what got us transitioning from being clinical practitioners into the field of surgical robotics and trying to make robotics affordable, accessible, and available not only in India but around the world. So I'm Dr. Vishwajyoti Srivastava. I'm the President and Chief Operating Officer. Training was in general surgery back in Chicago, and I was recruited back in 2020 to help guide this project. Just quick disclaimers. So now let's just look at the robotic surgery scene globally. So currently, globally, there's approximately 9,000 surgical robotic systems. As you well know, the first robotic surgery system, FDA approved it in 2002. But till date, the majority of these remain country and economy specific. If you look at the statistics, about 90% are between North America, Europe, and Japan.
रुको.
That means that a population of 7 billion people
बराबर
have
है
only
ना?
10%
अरे मत करो
access
ना यार,
to
मेरे
such
को समझ रहा
technologies.
है.
And due to
You
this
don't do
uneven
anything,
penetration,
because if you
is
try to
primarily due
help
to the
me, it
high
will
cost
cause
of
more
acquisition and the
problems
steep
for
learning curve involved. If you cannot afford the system, you cannot become
Go
good.
in.
If you're not good, patients will not seek your help. And if that, then it becomes like a vicious cycle. And due to this absence of running robotic programs, then obviously
चलो
there's
छोड़ो.
an absence of organized training.
एकदम अभी कुछ मत करो.
So I show
till I
this
tell you.
picture here. So as you can see here, the first ever robotic surgery was done by our chairman and founder, Dr. Sudhir Srivastava. So he was the early pioneer in robotic cardiac surgery, who initially did all the FDA clinical trials for
क्या
the
है?
Da Vinci system. He did the first case here back in 2002, and actually the story
पीछे
behind this is that, so Dr. Fred Moll, he was the general surgeon who started Intuitive Surgical, makers of the Da Vinci system. Initially, they had done their indication for the FDA in cardiac surgery. Dr. Moll's logic was that if we can do
Go.
cardiac surgery, then we can do everything else very comfortably. So they had
मेरे को दिखता ही
identified
नहीं
10
है. सब
multi-center
उल्टा.
trial in the
minute.
US, 10
I
centers.
don't know what I
So
have
Dr.
Look,
Sudhir
छोड़ो.
had a small hospital, a
अरे,
75-bed
चुप
hospital
बैठ
in
जरा
West
थोड़ा.
Texas,
मैं करता
where he
हूँ
became quite famous for doing such minimally invasive cardiac surgical procedures. He was approached by the company,
ये
asking
खुलता ही
him
नहीं है.
to participate
दूसरा
and
दो.
carry them through the clinical trials, along with 9 other centers. He was given 10 cases. Back then, they were
Yo,
for 2
go inside.
indications,
चलो.
beating heart,
Liver
kidney,
को सिर्फ उठाओ तुम, अभी
endoscopic,
कुछ
coronary
मत करो.
bypass surgery, and
Liver को
atrial
उठाओ, चलो.
fibrillation. He was given 10 cases in each indication. He finished his cases in 2 weeks. All other centers took 15 months. So he got special permission from the FDA, came to India, came to Escorts Heart Institute at that time, was being run by Dr. Trehan, and then filled the rest of the gap and completed all of the remaining procedures. So in this picture, you can see Dr. Trehan on the left, President Abdul Kalamji in the middle, and Dr. Sudhir on the right. So he did the first ever robotic case in the country. And the reason I show this slide is that since 2002, 22 years later, India has, with a population of 1.4 billion, 70,000 hospitals,
किधर का है?
and the highest number of medical colleges, has only 220 surgical robotic systems
किधर का ना?
that were placed over 22 years.
ये किधर
Now
का?
it's
इधर
worth
का दिखाओ.
mentioning that in the last
इधर
18
है
months,
ना?
of this 220 number, we've placed 50 systems throughout the country. And I think a
दिखाओ.
lot of it has to do with, one was, now
ये
we've
इधर
made
का
our
है ना?
system more affordable,
और ये?
more accessible, and more available to surgeons. See, the
हाँ?
problem that exists is that technology, and this is one of our core
बराबर है ना?
philosophies as doctors in our organization,
पीछे.
technology is only good if it benefits
I'm not
most.
pulling it
If you
because-
cannot afford technology and you do not have access, then most people will not benefit. India has a huge opportunity because there is no shortage of excellent surgeons here in the country. Highest volume of laparoscopic surgeons globally you find in India. So now, if you see sort of the transition of how we progress through the evolution of surgery and medicine, when we train in the beginning in surgery, we always train from an open procedure standpoint. Why? Because it gives you complete, access, vision, tactile feedback. It's horrible for the patient, but it's excellent for the surgeon.
दिखा.
Then came the evolution to laparoscopy, where now it's very good for the patient, but it's not that good for the surgeon. Now I've imposed limitations onto myself. My movements become counterintuitive. Suturing can be quite challenging unless you're an expert surgeon like Dr. Pudambakar here. And then the transition came to robotics. So now you have the advantages of laparoscopic surgery and the advantage of having 3D vision and wristed instruments. So it's basically like doing the open procedure, but from an endoscopic setting.
चलो,
So
दिखाओ.
I think that what really drove us to develop this mantra system, I get this question asked a lot. So in 2011, we were recruited by Fortis group of hospitals to launch 10 robotic programs throughout the country. And we purchased the Da Vinci system ourselves, trained local teams here in India. But due to the high running cost, patients could not pay, 1.5, 1.75 lakh starting just for the instrument utilization. So that experiment had failed, and what turned Dr. Sudhir from being a robotic cardiac surgeon into technology development, he had a 20-year-old patient come visiting him at Escorts. She had atrial septal defect, and the brother brought her in saying if she has a huge sternotomy scar, chances of her getting marriage would be challenging. They offered to do it for free. Hospital insisted on charging 4 lakh rupees. They wouldn't allow us to pay for it. So then the brother said, okay, let me try to raise money. 1 month had gone by, 2 months had gone by, and then finally he called and he said, I'm still struggling to raise money. And then we never heard from him again. So that was really the catalyst, the turning point in the life of Dr. Sudhir, that he said that we must do something. If these larger companies are not going to do anything, then we must try to do something about it. So our vision was to create something new, utilizing the latest technologies that weren't available, 20 plus years ago. They weren't even imaginable 20 plus years ago. So, in the mission, being able to make something that's an affordable system without compromising on quality, I think also that has to do with the fact that we're a company that's started and run by surgeons. All the input we get and feedback are from surgeons, and we work with our team of engineers who are also scientists. So we want to remain a science company in order to bring this gold standard healthcare to every patient, not only in India, but throughout the world. A little bit about our company. So currently, we're based out of in Gurgaon. We have 350 team members, although we started with a team of 5 7, 8 years ago. So we've grown quite drastically since then. And you can see from our facility here, we wanted to make it a world-class facility, not compromising on quality. And in fact, when a lot of people come and visit our facility, they are shocked that this is something that's existing in Udyog Vihar in Gurgaon. We do have our Indian CDSCO approval. We qualify under Make in India, and we're also listed on GEM. So currently today, we're in 6 government institutions, and of those government institutions, 4 are teaching hospitals. We're in the process of getting our CE and FDA currently, and about this time next year, we should have it. So here's our roadmap. See, everybody always says, well, the FDA is important, CE is important. See, FDA is not the gold standard. There are many things off-label that are FDA approves off-label that are used globally. See, FDA is good in the United States. Our CDSCO in India is just as good. If not, it was more difficult getting that initial registration approval for surgical robotics, being that it was a new registration in the country. So our technologies, this is SSI Mantra 2. So this is what you saw Dr. Amitabh and Dr. Magan operating on today. So it's a modular system. Allows for utilization of 3, 4, and 5 arms. In Dr. Magan's center currently, he only uses 3 arms. And his logic was very sound in the sense that he wanted to see how the program was going. He was losing a lot of his patients to Noida and Lucknow and Delhi who were demanding robotic surgery. Although he had been trained in robotic surgery previously, though like many others, he didn't have access. So when he decided to get the system, his logic was, let me start with 3 arms. Let me hone my skill set, let me build up my acumen. And then once I transitioned the migration of the patients away from Moradabad back to Moradabad, based on my own revenues and volumes, then I can then purchase the 4th arm. And that's exactly what he's doing today.
All of you are
so in this Mantra 2 system, this is our flagship product where we've done now more than 2,000 robotic surgical procedures from transoral all the way down to the deep structures in the pelvis and everything in between. Our Mantra 3 system is a little bit different. So now we decided to get heavily involved into telesurgical applications, teleproctoring, how to best utilize technology so that we can actually keep pushing the envelope, beyond just the advancements of having a surgical robotic system, which from an engineering and development point of view was not an easy task. And it's actually very interesting that Intuitive Surgical, makers of the Da Vinci robot, they never once filed a single patent in India thinking that it'll never be done here. The irony is that 70% of people who work for Intuitive Surgical are from India. So I always thought that that was entertaining. But as you can see here now, our system is a little bit different. I'll go through it just one by one. But this is our telesurgery console. As you can see, it's very small and portable. So we have one in our office so that Dr. Sudhir can teleproctor and do telesurgery when required. Our arms, now we can use up to 5 arms. So Dr. Amitabh, who just presented his partial nephrectomy, so he was the first surgeon in the country to use 5 robotic arms from a single surgeon console. He didn't have to exchange instruments until the very end, where he just had to perform the anastomosis, and he replaced the harmonic with a needle holder. And then, of course, we have our vision tower, which gives 3D vision for the entire team. We're currently the only robotic surgical company globally that gives 3D for everybody. And the story behind that was we were launching a cardiac program in Korea. And we saw a quick flash of light, and then all this blood started pooling from the left ventricle. So it turned out that in the thorax, see in the abdomen with CO2, you can distend it, whereas in the thorax it's a very rigid structure. So the nurse, she didn't have enough room. She was using the Da Vinci platform at the time. She couldn't tell how deep she was going, and she put the knife right into the heart. Of course, we fixed it during that procedure, but the whole point is that, see, it made no sense why the tableside team could not have the same vision as the surgeon. It's basically like operating in an open setting but while covering one eye, because that's what 2D vision ultimately is. So we decided right from the beginning to integrate and incorporate this into our platform. We developed this back in 2012 timeline. So our Mantra 3 robotic arm is 40% slimmer than the Mantra 2. Has a maximum height of 7.5 feet and excellent reach. You can see here this little joint that's just beneath the top. It's in green. This is an extra pitch joint. So now if you're doing things on the anterior abdominal wall or anterior thoracic wall, you can bring the arms all the way down. Now the whole arm can then tilt up. So now you don't have to open the arm completely, which helps in the stability of the system. This is our Mantra 3 Surgeon Command Center. So now from what you saw in the cases today, you saw a mechanical surgeon-machine interface. It's called gimbal mechanism, where here we have these magnetic hand controls. So Dr. Amitabh and Dr. Rawal, they've also used it for almost 100 cases by now. But these magnetic hand controls, they operate based on a magnetic sensor, a source that's based in the middle of the console. It establishes an electromagnetic field with a radius of 2.5 feet spherically, wherein the movements are precise up to 0.1 millimeters and only adds about 4 milliseconds of system latency. They're quite precise, and Dr. Amitabh actually made a comment. He said, can you make them feel heavier because they're too light? And Dr. Rawal said that when I use these hand controls and I go back to my XI machine, the XI controls feel heavy. So this is just a point of how we want to maintain being a science company, utilizing available technologies to be able to progress rapidly, in this field of surgical robotics. And this is our telesurgery chair that we've developed. So I'll get a little bit later in the talk about what our philosophy is on telesurgery. Our philosophy on telesurgery is not having one excellent surgeon performing, being omnipresent, operating in 100 different places. But this is something that we were trying to incorporate more into our holistic training program. Then, of course, 3D vision for everybody. Our energy instruments are agnostic with any electrosurgical unit, so you can use Valley Lab, ConMed, it doesn't matter, so that we wanted to make it so that you don't have to buy anything special for our system. And then, of course, the stability of using UPS, so all of our very delicate electronic components are fed through the UPS to stabilize the current. As you well know, in India, we have a lot of fluctuations of current and spikes and etc. So this helps protect the system altogether. We partnered with Olympus as of now, although we have explored other endoscope companies. We like this scope because, one, you have articulation, so it removes the need of having two separate endoscopes, helps bring down the cost. Additionally, it's the longest working length currently. So for deeper structures, prostate, colorectal, etc., it's quite advantageous. And then it allows for 360 rotation, up and down, up to 85 degrees, left and right, 65 degrees. Now, one interesting thing, this is very important, we've developed more than 45 types of multi-specialty instruments. So this is, aside from intuitive surgical, we have the highest number of instruments that we've produced till date. So this covers all specialties, and now currently under development, we're developing a multi-fire clip applier so that you don't have to keep taking out and reloading your titanium clips and then bringing it back in. You can just fire them continuously, and that way you save time and it's much more efficient. And additionally, we do have a harmonic that's been utilized now clinically, and we are developing a vessel sealer, which we were calling a 3-in-1, where it will be a bipolar vessel sealer and a cutting instrument as well. More than 20 different types of cardiac instruments. So currently, we're also the only surgical robotic company that supports the full spectrum of cardiac surgery. Given the fact that our chairman, Dr. Sudhir, was an early pioneer of robotic cardiac surgery, he really wanted to revive the field because, see, with all due respect to other specialties, they all have endoscopic options. In the chest, aside from VATS approaches and thoracic surgery, 95 to 98% of all cardiac surgeries are still done via median sternotomy. Highly invasive, long recovery times, high risk of infection, blood loss, slower return to functional recovery. So we really wanted to see, we really wanted to revive robotic cardiac surgery in the sense that most robotic cardiac surgery patients, after bypass surgery, they'll go home next day or the day after, back to their functional status in a week to 10 days. So there's a huge benefit, and there's an enormous population of patients that currently do not have access to this wonderful technology. This is something that we've developed. We call it NADI, so it's an automated anastomotic connector. We've made initially for cabbages. So basically it's a micro-stapling device that will do an end-to-side anastomosis in 6 seconds. So we've made 2 versions, robotic and manual, so that what this will do is it will completely eliminate the variability of hand suturing skill level between surgeons. So for this, and in India, we'll do a trial. We'll have to do 3-month and 6-month post-op angiogram to evaluate for graft patency. And then the goal is, after successfully conducting this clinical trial, to begin making them in different sizes for different target vessel anastomoses. So for renal transplant, hepatobiliary, any type of anastomosis that's done in any complex procedure can then be utilized. This is our SSI Maya division, where it's one of our emerging and exploding verticals within the company, where we can take any DICOM image, so CT, MRI, PET scan, and literally on the fly within within 2 minutes, we can convert it into a 3D model where I can slice, dice, rotate. This is very helpful in surgical planning, so now it allows you to see exactly where the tumor is, or if there's any aberrant or accessory arteries in the body, so it really helps with surgical planning. In addition to that, we have teleproctoring, which we've now done successfully, and we have virtual surgery, which is our simulation protocol that we're developing. So this is an example of teleproctoring. Here you can see Dr. Sudhir sitting in our office in Gurgaon, and he's proctoring an ASD repair case in Bangalore, 2,000 kilometers away. Okay, so just to show you just quickly on our clinical highlights, we've now done more than 2,000 surgeries, 80 different types of procedures, from transoral to the prostate and everything in between, including the heart. Trained more than 500 surgeons and 1,000 clinical support people. These are our numbers, as you can see, thanks to doctors like Dr. Magan. Now general surgery is the highest, followed by urology. I'm proud to say we've done more than 100 cardiac cases, head and neck, and also breast surgery. 0 mortality, no injuries, no complications. And I think this is a testament to the fact that we are doctors who are leading this company, and we tell our engineers that at the end of the day, do your work in such a way so that you can be comfortable having your mother, father, brother, sister, being operated on the system you've made. And just to show you just one quick surgery, this is a beating heart, totally endoscopic bypass surgery. So basically you're conducting the bypass on the heart while it's beating in a totally closed chest manner. And this is a coronary stabilizer we place. Now you can see the silastic loops coming in, occlusion proximally and distally. Then you bring in you apply a shunt, bring in the internal mammary artery. On the stabilizer, we do have some irrigation, so it keeps the field clear. And then basically just a running suture on the internal mammary artery. See, so some people say that, because our system is affordable or cheaper, that it's only good for simple procedures. So and when they tell me this, I show them this video. Just the other day in Gujarat, Dr. Sanjeev Haribhakti, he successfully did a Whipple operation, completely intracorporeally. So I just wanted to say that we did not compromise on quality. If anything, we made it easier to use while being able to reduce the cost. It was always our goal to bring our per procedure cost within 10 to 15% of laparoscopy charges. Then you can justify utilization of the robot, like Dr. Magan had previously mentioned. And then just here's a transoral. As you can see, the workspace is very small, very shallow, but you're still able to successfully utilize the system. Now this was done using Mantra 2. So basically, we want to utilize teleproctoring, telesurgery, so that when it's not efficient for surgeons to have to fly here and there in today's day and age. You have to take time off out of your own practice You have your own patients to see. You have no idea about the skill level of the other surgeon or the complexity of the procedure based on the patient findings. So we utilize teleproctoring. It's like having an attending, a teacher in the room. Now, should that student doctor encounter some difficulty, then by a telesurgery, I can then take over, get them through that step, complete, whatever difficulties they're doing. See, ultimately the goal of the proctor is to bring the maturity into the student doctor. So this is sort of how we approach our training, so that the person who's learning, who's just launching their robotic program, they have the comfort that someone is looking over their shoulder and has their back should they encounter some difficulties. And in the future, we're making our next project will be a pediatric robotic system. I think there's a huge population that goes where they have unmet needs. Of course, we've done some pediatric cases anecdotally, pyeloplasties and such, but there's no surgical robotic system that exists till date, that can give proper treatment for up to 48 months. Telerobotic ultrasound, robotic endoscopy, tele-targeted therapies. So in the future, we're having discussions with the government to be able to run these camps. As you well know, by the time many patients come to you, the advanced staging and progression of their cancer is very high. So how to prevent that? And should surgery be required, then, I'm sorry, this is just a quick video of Dr. Rawal doing telesurgery. So this is we're the only company in India that's ever done robotic telesurgery. So this was a cystoprostatectomy. Was done. Dr. Rawal was sitting in our office and 40 kilometers away in Rohini. He was operating on the patient. And then lastly, this is something we're developing for now the remoter parts of India. This is a bus we're making, so now we can bring the care to the patients. This will be ready in the next 3 months, and we hope to bring it into regions like here in Hisar and other parts of the country, where now you can bring the care to the patients rather than them having to travel to the metro areas. And of course, we partnered with Airtel for our telesurgical applications. And the idea is to decentralize excellence and democratize access to such technologies moving forward. And with that, thank you.
Thank you, Dr. Vishwa. I think we're sure. So I think we're very proud and fortunate to have a robotic surgery company based right here in India. And I'm sure the acceptance and the proliferation will be much more.
Vocal for local.
So the same patient that we saw a partial nephrectomy, that patient also has a breast cancer. And Dr. Karvasara is going to demonstrate a beautiful open modified radical mastectomy. So we are really fortunate today to see everything. Sir, we can see you.
Hello.
Hanji sir.
I am audible.
Yes, audible and visible both.
Okay. Shall we start?
Yes.
Sister, give me. Right.
You have marked.
See, we have already marked the incision. We have marked the incision. Incision is just an elliptical horizontal incision. Almost all the patient we can operate in this incision, wherever the lump. The idea is it is not need to cover the lump if it is not fixed to the skin. And this is the idea we usually take, that it is the covering. Otherwise, what we lift the breast and mark like this thing, so that we get the idea that we will be able to cover this thing. Now with this, we just cut the skin.
ओ भाई कैमरे वाले, तू स्टडी रख इसको यार, हिल मत.
Here, if you notice that we have curved the incision, we have not made an angle.
Yes.
Because closure will be easier to balance this thing. Number 15 number. 15 number. जो टाइम पहले दिया था ना.
Why you are switching from 23 to 15?
No, at the angle, the body is small so that it is easier to make. The other unnecessary cut will be there. Back cut will be there unnecessary. So now, give me more.
Now the entire dissection will be by cautery.
Now first step is that in the breast surgery there is one important aspect is the raising of the flap. And flap, we have a knowledge, theoretical knowledge, background knowledge that it should be between, it should be how much thick. Nobody can measure during surgery that it should be such much thick. It is a theoretical aspect. Practical aspect is that the plane should be between the two type of the fats. One is of the skin and another is of the breast. Breast fat is the larger globular size and skin fat is smaller globular size. So we have to go in between that. And how we have to go, that is the only thing to be important to learn. Thank you. If you have observed, I have not cut the skin fully with the knife.
Yes. It was an epidermal incision.
Now just observe.
Yeah,
The
cutting
second
more
step is
in
we are
between
divided. Now
ovulation.
what we are doing is we are separating the two types of fats from each other.
Yes. Topi.
If you observe that the popping out the breast,
Yes.
fat is popping out. बाइपोलर ले लो. Now the skin hooks. Babcock assistant, Babcock. So we have to go between the
breast fat and
you
the
observe that I am
subcutaneous
using the एक Babcock हो रहा है. I have made an angle, and we have to go between this angle. So I am sorry. बोलो। So this is a practically avascular plane. If you observe, and we have to reach up to the muscle. Am I connected? Not really. बोलो।
Sir,
hello, am I connected?
Hello? Yes, sir. Yes. Sir, till you raise the flap, can we have a talk by Dr. Suresh Vashisht for 10 minutes on legal issues in robotic surgery? Hello? Yeah. Hello? Hello, sir.
Hello.
Hello, sir. Hi, sir. Harish here. Can you hear me?
Hello.
सर आप मुझे सुन सकते हैं?
हाँ. Hello.
सर आपके एक परमिशन चाहिए, छोटा सा एक टॉक है सर डॉक्टर वशिष्ठ का. By the time you raises the flap.
Start.
Thank you, sir.
Just observe.
हेलो डॉक्टर करवासरा.
यस.
डॉक्टर करवासरा.
यस. हियरिंग.
ये ना हरीश ने झूठ बोला है.
क्या?
ये 10 मिनट की झूठ बोल रही है, मैं 22 मिनट बोलूंगा.
वो तो पता है.
तो मेरे को फ्लैप रेज करने में 22 मिनट लगेंगे.
हाँ लेकिन सुनना सर आप भी. गुड आफ्टरनून फ्रेंड्स.
Dr. Vashisht, you can go on for any long time.
सॉरी.
You can go on for any time.
नहीं सर, मैं ज़्यादा बोल नहीं पाता हूँ. अभी डोंट स्टार्ट. अरे अभी वैसी फालतू बात करनी. हाँ 2 मिनट. 4 फरवरी 2024 when Harish started robotic surgery program in Aadhar Hospital, he posted about the first robotic cholecystectomy in our group and personally called me. We were very happy. 2 days later, he called me कि सर एक complication हो गई. मैंने कहा इतनी अच्छी सर्जरी हुई और उसमें complication हो गई. I could not understand. कहा नहीं सर, सर्जरी was good, but complication ये हो गई कि मरीज पैसे नहीं दे रहा है. तो मैंने कहा क्यों नहीं दे रहा? वो बोला जी आपने क्या किया, मैं इसमें सर्जन चार्ज नहीं दूंगा, मैं तो इसमें सिर्फ रोबोटिक के चार्ज दूंगा, क्योंकि आपने तो कुछ किया नहीं, तो रोबोट ने किया ऑपरेशन। तो दैट इज द spark which led me to present this lecture, because technology is growing, but it is the non-technical factors which will decide the future of all these high-tech surgeries. So friends, at the outset, I express my sincere gratitude to ASI Haryana, to मेरे भाई डॉक्टर बंगा, ब्रिज बंगा, एंड छोटा भाई मेरा हरीश, जिनके अनुग्रह और डंडे की वजह से मैं आपके सामने खड़ा हूँ. So the robotic surgery has rapidly evolved as groundbreaking field in medicine and has revolutionized surgical practice across the various specialties of surgery. There is a craze not only among the surgeons but among the patients also regarding robotic option of surgery, and it has got lot of benefits, having several advantages and risks, but simultaneously poses several medical challenges too. So all benefits are virtual information, superior precision, image resolution, geometric and spatial accuracy, improved dexterity, quicker maneuverability, ability to operate without fatigue, ensuring consistent and steady motion. It is less invasive, operate in space-constrained fields and difficult areas. Significant decrease in the blood loss is there, which leads to early recovery and less hospital stay and improved patient outcomes ultimately. But there are disadvantages also, with the limited availability and training and high cost, which are quite prohibitive, especially in developing countries like India. Then there could be robotic malfunctions, though rare, but can occur and may necessitate a change in the contemplated plan of surgery. Wear of insulating membrane because of the collision inside the abdomen or during insertion through the trocar. There could be instrument alteration, mechanical arm alteration, console defects, optical and software issues. Mechanical failure or malfunction can rarely even cause patient injury, complications, and even deaths have been reported, though rare, in robotic surgery. Robotic surgery also poses a danger to surgeons. गले मिल लो पहले भाई, मैं बंद कर देता हूँ बीच में. शैलेश, बैठो. So robotic surgery also poses as a danger to surgeons' operative capabilities, with the risk of him being overshadowed by a machine that is faster, stronger, more knowledgeable, and more efficient than him. So if we look broadly on the legal, moral, and ethical issues of robotic surgery, there are three factors. One is lack of standardized training and credentialing, which ultimately affects the patient safety and puts a mark on surgeon's competence. Then the informed consent, which is legally mandatory, has certain additional considerations and the legal liabilities because of multiple stakeholders. So we will discuss just these three issues in next 10 or 12 minutes. Despite robotic surgery decreasing and taking out the human error, safety depends on the skill of the surgeons and training of the surgeon. So the magic, as Dr. Ajad Singh mentioned, we have two magicians. दो जादूगर हैं, एक बाजीगर है. एक जादूगर आ गया, एक जादूगर ऑपरेट कर रहा है. So the magic lies in the magician, not in the magic wand. So it is the surgeon's skills which will matter. So there is need of more structured training programs. And there is a misconception that it is easy to transform the laparoscopic skills to robotic surgery skills, which is not totally a misconception. I have seen surgeons never doing laparoscopic surgery, switching directly from open surgery, and they are one of the leading robotic surgeons of the country. And incorporation of robotic surgery training as part of resident training program for better exposure, more adoption, and expertise has been contemplated. But could it be counterproductive? Because it might lead to hampering of acquisition of skills of conventional open surgery. So credentialing, there is it is quite inadequate and it is not standardized, which might lead to increased liability to risk for the litigations. There is no dedicated curriculum or credentialing system in our country, and for that matter in the globe itself. So proctoring and guidelines to protect surgeons, institutions and manufacturers for ultimate benefit of patients are the need of the day. Now the next is informed consent. Legally it is mandatory to obtain the consent before you do any invasive or whatever procedure you contemplate. But if a patient is planning to undergo robotic surgery, their consent for use of the robo must be obtained beforehand. Mind it, it is a medico-legal document. So very common misconception is that it is a completely automated machine that will be operating without a surgeon or a human interface. So robotic malfunction, failure, though minimal, should be disclosed and discussed with the patient. The exact steps of the surgery that will be robot assisted should also need to be informed to the patient. The advantages, the risks, the alternative options to robotic surgeries also should be disclosed. Some authors recommend disclosing the surgeon's expertise and training in robotic surgery, including number of procedures he has done already, but I think this could be counterproductive. But type of the procedure the patient is undergoing, the instruments involved, how the procedure is performed, what are the alternative options, and what the protocol is in the event of an emergency must be thoroughly discussed with the patient. So the risk, benefit and side effect of the procedure, nature and intended purpose of the procedure, reasonable alternatives, risk and consequences of not opting for the procedure or delaying the procedure, likelihood of results, estimated expenses, including the highlighting that should not happen like what happened with Harish in the first case, कि surgeon जो इसमें है उसका भी पैसा उसको चाहिए, and that should be highlighted because it is the surgeon who will control. वो दास है, वो slave है, उस slave का master मैं हूँ. I am going to operate, so I need my charges also. Now the last one is the legal liability. So the laws and guidelines about it are still evolving. The surgeon, the hospital, and the manufacturer of the machine are all involved in the functioning or application of the machine and hence have some share of responsibility and legal liability. The law today have predominantly seen the use of robots as tools of assistance to surgeons. The courts use their discretion on the proposed actions of robots and provide a level of human check on any proposed actions of the robots. So the analogy of the robot is with the automated cars, how they function. So self-driven automated cars monitored by a human being when a mishap occurs can be catastrophic and life-threatening. If the crash involved the fully autonomous vehicles, the human users were held less liable, and a majority of the responsibility was to be shouldered by the manufacturer and the government agencies that issued the manufacturing licenses or clearance of the license. So there is a theory like blame attributions asymmetry bias. This bias, humans are prejudiced to judge these cases more liberally and more harshly, and they put more blame to the automation and its creators, and be inclined to award a higher quantum of compensation to the victims than in a similar case where no autonomous vehicle was involved. This bias can impact the future policies and deter the adoption of such technologies. Every country has to evolve and consider its own legal principles and social factors and frame its own guidelines and laws which is suitable and in keeping with the other laws of the countries. And there can be an integration, and there is an integration, just a mention of AI, artificial intelligence. AI and robotics in healthcare, they have immense promise for revolutionizing surgery, patient care, diagnostics, and treatment modalities. These technologies can enhance the precision and efficiency of medical practices. They can improve patient outcomes and alleviate the burden on healthcare professionals. However, as AI and robots become increasingly integrated into healthcare system, some ethical implications they come in. These include privacy, data security, accountability, transparency, fairness, and the preservation of human anatomy. Understanding and addressing these ethical considerations are therefore very important to harness the full potential of AI and robotics in healthcare, while at the same time ensuring the well-being of trust of the patients, healthcare professionals, and the society at large. I will not go into these data. So there are three small cases. The complexities involved in converting from robotic-assisted surgery to laparoscopic or open surgery can increase patient risk. Surgeon performed a robot-assisted hysterectomy on a patient who was morbidly obese. Complications during surgery forced the surgeon to convert to traditional laparoscopy and then further to open surgery. Following the surgery, patient had brachial plexus injury because of the poor position and prolonged duration. Another case, lack of defined training standards and limited awareness of the learning curve for robo-assisted surgery have played a role in malpractice lawsuits. One example is a surgeon performed an unsupervised process surgery who had done just 2 supervised surgeries early. The surgery took more than 13 hours and resulted in multiple injuries and severe blood loss, as well as the need to convert to open surgery during the procedure. The complications from the surgery were alleged to have contributed to the patient's death. And the last one is, it's a quite popular case from the US. Accurately portraying the benefits and risk of the treatment is vital for the patients to make informed choice about their care. Failure to do so might result in patients feeling misled, which could potentially lead to malpractice claims. An Obgyne case, a doctor proposed a robot-assisted hysterectomy as an alternative treatment option for a woman who knew little about the procedure. The patient agreed to the surgery based on the doctor's claim and recommendation and online videos she had seen that extolled the precision of surgical robots. Unfortunately, during the course of the procedure, the surgeon punctured the patient's ball. The injury required 9 surgeries to fix, and patient had to be hospitalized multiple times. Following the incident, the patient stated that she felt deceived by the optimistic marketing of the robot from her doctor and the manufacturer. So to conclude, friends, there is still lack of clear legal framework and guidelines on the liability of surgeons and manufacturers. There is also a glaring deficiency. अरे बाहर जाके बात कर लो ना. बाहर जाके बात कर लो बेटा. There is glaring deficiency in organized training and credentialing of a robotic surgeon. The moral, ethical, and legal aspects of robotic surgery may be playing a bigger part in determining the future of surgery than most people think so. AI and robotics in healthcare have the potential to revolutionize patient care and healthcare delivery. However, their responsible and ethical use is contingent on addressing the multifaceted ethical considerations. By prioritizing patient welfare, transparency, fairness, and collaboration among healthcare systems, technologists, policymakers, and healthcare professionals can ensure that AI and robotics contribute positively and effectively to healthcare while upholding the highest ethical standards. As we move forward, we must recognize that the ethical journey in AI and robotics in healthcare is ongoing, and it is going to be very fast and northwest trajectory. Continuous reflection, adaptation, and collaboration will be essential to harness the full potential of these technologies while safeguarding patient well-being and trust. In the ever-evolving healthcare technology landscape, ethics must remain at the forefront to ensure that AI and robotics remain to be the tools and not the masters over the surgeon for the healing and empowerment benefiting the individuals and the society. Thank you so very much. So it is quite imperative on the part of robotic surgeons and robotic societies and other societies to go ahead with these guidelines, assess the credentialing system and improve it. Thank you.
Thank you, sir.
Bipolar. Bipolar.
Thank you, sir.
Many of the companies in India, they are not paying for robotic surgery. They say insurance companies, insurance companies, they are not paying for the robotic surgery. They say that we'll pay only 25% of the sum assured. What to do? What to do? Because 3 years back, I got my bilateral knee replacement, and the bill was 4,21,000. They paid me only 93,000 only. They say that we are paying only 25% of the sum assured. So yeah,
surgery part. Obesity surgery is was not included, still not included, but if you just change the term as metabolic surgery, then the claims are being processed and now they are given. So it will take time for the insurance companies also to adapt to the new technology. For that we need a collaboration and a group, a concerned group which impress upon the insurance companies, meets the IRDI chairman and tell them that this is a technology which is going to benefit the patient, not for the cost purpose.
that's right. But I went to the ombudsman and they paid me ultimately.
ले लिया ना?
Yeah.
You are intelligent.
That's
I clap for you.
but for the patients, they should get the amount. Once they are paying the premium, so they should get the amount.
सर बहुत ज़्यादा चोर बाजारी, अब क्या करें, अभी लेट अस एंजॉय द सर्जरी. आई एम सॉरी, मैं बीच में आ गया.
Hello, sir.
Vasisht, have you finished?
Sir, namaskar.
Namaskar.
Back to you again. Sorry for the
Okay.
interruption.
No, it is okay. I enjoyed your lecture.
Thank you. I was enjoying
And
your
I will
surgery side se
give
dekh
my
raha tha.
comments after my surgery.
Please.
Now, meanwhile, I raise the flap and if you observe, all the limits here, this is the LD muscle.
Yes.
We have to go up to lateral border of the LD. So, we have raised the almost raising of flap is completed. We have raised to the axilla.
Wonderful. These are small tricks. Yes, hold the skin
It is
margin.
falling because it will
it
tear
was
the tissue.
Yes. To prevent the unnecessary drag due to weight of the specimen, you have tucked it with the skin. Great. Cook picture. Commentary chalti rahe boss.
See, this is the, now we have reached to the LD pedicle.
Yes.
And ideal is that we have to take all the tissue and block. That's the thing which I am going to do more. So we are getting on to this pedicle. Bipolar.
वो एंगल पे दिख नहीं रहा कैमरा. This is the last part probably.
Like. This is the axillary vein. We should not go above the axillary vein. That is the, so. Forceps देखो मेरे हाथ में forceps.
कैमरामैन प्लीज सेंट्रलाइज करो जहाँ पे काम हो रहा है.
Can you show this part? We are just in lateral most part. We have to be move along the border of the LD. Nothing will come. Two vessels which are crossing, only they will come and we have to ligate them on. Artery. Bipolar. I used to tie, actually I watched Putam Baker doing no tie, and they are using the some advanced instrumentation, but for me it is the compulsion. Contrary.
This is the superolateral limit.
We are on the lateral part of the axilla. Now give me light. Artery. for artery. Seizure and then tie. Tie. One more tie. Tie दे दो. Cut. Cut cut. Cut. Place. So this is the lower border of the axillary vein. Artery. Place. Bipolar. Just appreciate this is the nerve LD.
Yes.
Now to latissimus dorsi, we are just dissecting along this panel, this pedicle. Place. So light इधर करना. बोलो. Okay. Okay. Bye बोलो तो. See, we have now separated out the whole of the LD pedicle.
Yes.
And we have taken all the lymph nodes, fascia and block.
Yes.
Medially, without any breach.
Excellent.
No, lace. Now another important area is the safeguarding the, basically MRM is that we have to preserve the muscle, the nerve to all the
Nerves,
three muscles. Pec major,
latissimus dorsi,
LD and latissimus dorsi. Lace do. An important photo. Bye बोलो. Now here it is the always this is pedicle is going like this thing and there is a branch here. So what we have to separate this, because the medial pectoral nerve is along this thing. If we safeguard this thing, then it will be saved. Or mosquito, artery the mosquito. Mosquito हल्की दो, कोई mosquito या कुछ. एक और देगा. Scissor. Three zero tie है. See this, during my time I learned that surgical oncology or cancer surgery is basically surgery of the lymphatics. And because majority patient has the lymph node, and unless until and this is the lymphadenectomy is the therapeutic in most of the cancers. And with this belief, I believe more on the lymphatic dissection and that too and block, cut, another type. Vasisht? Hello?
Yes, sir. Yes, sir.
Hearing me or not?
No, we are watching, we are hearing, and we are, loving you.
See, that important is that in breast, raising of the flap and lymphatic
clearance, yes.
Two important steps.
Yeah.
And we have to,
It is the
I spend some time on the lymphatic dissection. That is my belief. And this is also justified.
No, this is science. This is science.
No. This is the intercostal nerve which we have to sacrifice. Season. Pottery. Bible.
For the information of delegates and you, Dr. Vasra.
Yes.
Today is 230th day of robotic surgery program of Aadhar Hospital.
230th?
हाँ, 230वां दिन है आज, और इसमें 175 सर्जरीज कल तक हो गई थी. If we include 2 surgeries, one by Shailesh and another by Amitabh, एक उससे मगन ने भी किया ना, तो 178 हो गई सर अभी तक. तो तालियां हो जाए मेरे ख्याल से आधार के लिए. आधार मेका जगदस्तमेका, आधार भूता जगदस्तमेका, इसका मतलब जो आधार है वो आधार है यहाँ का पूरे क्षेत्र का, और आगे ऐसे ही चलते रहो. ऑल द बेस्ट. हरीश बाउंसर का रोल कर रहा है अभी कि ये एमआरएम से पहले कोई बाहर नहीं, यहाँ दरवाजे पे खड़ा है, बाहर नहीं जाने दे रहा किसी को.
Artery. See, all the vessels which are coming down to the axilla are to be taken down.
It is always a treat watching you operating.
Artery. Another artery and seizure. But not going to take much time, almost finished. Level 2 has been decided, level 3 is only left.
मेरे को तो भूख लग रही है, आपके साथ खाना है, that is the issue.
Artery. So we are already in a position that all the three nerves is safeguarded. This is the long thoracic. Got it. You can appreciate this is a long thoracic and we have to dissect out all the tissue along this. चला गया क्या खाना खाने का? हाय बोलो, हाय बोलो. Water. ले, बोलो, water. Babko, water there. No, water. वशिष्ठ ये चला गया. चलो चलो. ना water. Now we have cleared the area between the circular area between two nerves. So now only thing is left is the apical. Hi, bolo. Water. Ano bolo? Bye, bolo.
So we'll be starting with our next case also. That is carcinoma distal thoracic esophagus post neoadjuvant chemotherapy. Our patient is 46-year-old male with a BMI of 19.7 kilogram per meter square. His chief complaint, difficulty in swallowing semi-solid food for the past 3 months. Upper GI endoscopy is suggestive of ulcero-proliferative growth extending from 31 centimeters to 39 centimeters from the central incisors. Biopsy, moderately differentiated squamous cell carcinoma. CECT chest, pre-neoadjuvant chemotherapy CECT chest we are talking about, was suggestive of circumferential mural thickening of distal thoracic esophagus with a maximum thickness of 16 millimeter, extending from roughly 4.5 centimeter below carina, inferiorly involving the GE junction and adjacent cardia. Maximum interface with aorta is more than 90 degree. The patient received neoadjuvant chemotherapy 8 cycles weekly, and the regimen was paclitaxel with carboplatin. The chemotherapy was started on 19th of July 2024, and he received his last cycle on 7th of September 2024. These are the images from the endoscopy, pre-chemo and the post-chemo. Next. So we are planning now total thoraco-laparoscopic McKeown's esophagectomy. The thoracic part will be starting now.
Hello? Are you able to hear me?
Sir, yes, yes, sir.
Okay, can we start now? Hello? Hello? कौन है ऑडियंस में ये अपने? Hello? Let me know when to start. देखो ना, कोई तो उधर स्टार्ट करे कि नहीं पूछो ना. हेलो
सर, आप मेरी आवाज आ रही है आपको?
हेलो
सर, हरीश बोल रहा हूँ.
हेलो
हेलो.
या कैन वी स्टार्ट?
Yes, sir. Please.
Okay, so this is the entire esophagus. This is the carina. This is the vagus nerve. That's the azygous vein. That is the head end of the patient. This is the tail end of the patient. So I have put a gauze piece just in case we need something, but usually this is the best way. We have placed this patient in prone position, and now we are starting. So we start at the level lower down, that is at the level of the inferior pulmonary ligament.
Yes, sir.
And we will open this space. So this is the inferior pulmonary ligament.
Yes.
Hello?
Yes, sir. Yes, sir.
Just let me know if you are able to see the vision very well.
Excellent, sir. Vision is quite clear, sir.
So this is the inferior pulmonary ligament. You can see the lung there.
Yes, sir.
This will help you to take the lung completely away from us. So you see now,
yes, sir.
This is completely gone. And now I am working my way, turn the camera, towards the diaphragm. So this is towards the crura.
Yes,
I
sir.
have gone, so because this tumor apparently is going up to the lower 1/3 of esophagus. So you see now this is the area. Once we have done this, then we can again open this. You can see the vagus. Can you see the vagus there?
Yes, sir.
You lift up the vagus.
Yes,
and
sir.
you should go between the vagus and the pericardium. That's the best way to do the surgery, because if you lift up the vagus, then automatically the mesoesophagus will also come with you. So
Yes.
this is the mesoesophagus, which is initially we always thought that there is no serosa. Of course there is no serosa, but there is a small mesentery which is controlling this, and now we slowly and steadily. So this is the entire vagus.
Yes, sir.
And now this is where we are going. This is the plane between the pericardium and the esophagus, and we are moving our way. Now, what are the trick of the trade is to remain in the correct mesoesophageal plane. So can you see this is this is the mesoesophagus, this one. And this is the plane that we are going to go into this area, and you can see now slowly you can see the inferior the pulmonary vein.
Yes, sir.
You can see the pericardium lower down, and this is the complete mesoesophagus which we have taken in. And now you can see that this is how we have gone and completely taken the mesoesophagus.
Sure.
What the trick of the trade is that I am just using the vagus as the traction. So I am not holding the esophagus, and this is helping me to go in the correct plane. So this you can see nice and beautiful planes that we are getting into, and especially if the patient is neoadjuvant chemo, then these are usually having a lot of vascularity, because there is always a chance of
Sir, Dr. Putambekar?
Yes, sir.
Sir, Harish here. Just we can just taking 2 minutes for Dr. Vasra.
Yes.
He is summing up the final procedure, sir. Ji, sir. Yes, sir.
And I just want to show all the muscles we have exposed, all the tissue we have taken out from pec major, the serratus. This is the LD. These are the 3 muscles. This is the nerve of the LD which we have safeguarded. This is the long thoracic nerve which is safeguarded, and this is the medial pectoral nerve.
Yes, sir.
Which we have safeguarded. All the 3 nerves safeguarded, and this is specimen is taken out and block, and we have gone up to level 3 apical node.
Yes,
we have
sir.
taken, this is the first rib.
Yes, sir.
And up to we have taken out.
Excellent,
Up
sir.
to level 3, sir. Okay. So we are now closing back. Just watch this thing, how we are closing. That is the only thing.
Thank you so much, sir. Thank you.
No.
Dr. Putambekar?
No, skin.
Sailesh, sir?
Skin.
We are back to you.
Yeah, can you see now?
Yes, sir.
Now I am going towards the right main bronchus. This
Yes,
is
sir.
the right main bronchus. This is the vagus that I am holding.
Yes, sir.
And now I am going between the vagus, and these are the subcarinal nodes,
Yes, sir.
which are coming into the picture. Can you all see that very, very clearly?
Yes, sir.
And now once you go there, these are the subcarinal nodes. 9 out of 10 times these subcarinal nodes are negative.
Negative, sir.
Either you can take them off with the specimen, which I can take. So when you want to take out with the specimen, just hold them, and then this is the right main bronchus, this one.
Yes, sir.
And then you can go here, you can see the vagus nerves. It's always the neurovascular bundle. So vagus nerve is always with the vessels,
Yes,
which is supplying the bronchus. That's what I took. And now you see these are the subcarinal node. Invariably there is always a bleeding which takes place, because there is a vessel which is always there.
Yes,
so
sir.
I am going very, very slowly there. This is the subcarinal node which is coming out now. Can you see that?
Yes, sir.
And then this is from it, this will take me to the left main bronchus.
Yes, sir.
So that is the subcarinal node. I want to be very, very avascular in this area. So I have taken this off, and now you can see the left main bronchus. Yes, this is the left main bronchus. These are still the subcarinal nodes which are there. So I'm just holding it away. You can see this. These
Yes, sir.
are all the nodes which are along the left main bronchus. This is, you can see now the carina.
Yes,
This is the right main bronchus. This is the left main bronchus. This is the where my left hand grasper is. That is the left main bronchus which is coming up. And then these are the nodes that I want to take out. So I am just being very, very careful that I should not land up into any kind of bleeding.
Yes, sir.
So all these nodes we can take out. and they come out like grapes. But as I said, and a lot of people try to show that how nice clearance we have done, but the issue is these patients usually have these subcarinal nodes which are always negative.
Almost always negative.
Yes, so this is the carina, and now you can see that I have gone from the right side towards this area. So entire esophagus is lifted up. This is the area that is there. Come back, and now I can go here and then go between this area.
Yes.
So now we are going near the trachea. This is the trachea,
Yes,
this is below, and then slowly and steadily you can see the trachea which is coming up. That's the trachea, posterior wall of the trachea,
Yes, sir.
which is very clearly seen there. And now you can see that we are going there slowly but steadily, and we should not be having any issues. Now we go there. This is now underneath the azygous vein.
Yes,
This patient has a lesion which is subcarinal, so I can afford to preserve the entire azygous vein that will keep. So this is the entire mobilized esophagus as far as this is concerned, and this is the plane that we have gone into. I will tell my assistant to clean the camera, and we will now keep a gauze there. This is the best way to do that small kind of hemostasis which is required. We will clean the camera in the meantime.
Salish sir,
Yes.
I would like to share our experience with you that every esophagus at our center we do post chemo.
Yeah.
We are not following neoadjuvant RT and chemo.
Yes.
And you will be so pleased to know that we are almost having experience of 700 cases.
Wow. Fantastic.
Esophagus we do in good numbers.
Yeah.
Almost 4 to 5 esophagectomy per month, sir.
That is a very, very good number. So we also, I don't give radiation.
Yes, sir.
We also follow more or less the same thing.
Yes, sir.
Because radiation.
Lavnish, since from Tata,
Yeah.
he follows sir weekly chemotherapy for these patients, and now this is the thoracic duct.
Yeah, this is the thoracic duct,
Yes, sir.
which you can very clearly see. I am going between the esophagus and the entire aorta.
Yes,
And the important thing with now the ICG coming in, lot of people want to use ICG that has to be injected
Yes, sir.
about 1 hour or 2 hours before in the web space or in the inguinal region. But I don't think it is necessary. It is like using a stent when you can see the things better.
Actually,
So,
sir, in few of our cases we also use, but we stopped using it now.
yeah, it is not required because
Yes.
what you can see better, why do
Yes.
you want it to be recognized by the color?
Yes, sir.
Yeah, that is the reason we have stopped using this, and now you can see that slowly and steadily.
Excellent.
This is the area that we are going into. Again, you can see the esophagus coming in, always remain parallel. These are the direct branches of the aorta, and you will also see the other sided vagus nerve there. So that's the entire area. Now you see this is the pleura of the opposite side.
Yes,
You should not try and not damage, not that it matters, but if you do not damage it, then of course the things are better. You don't have to use the intercostal drainage at the time of surgery. So slowly but steadily we are making, now again you can see the direct branches of the aorta
Yes, sir.
which are coming in. These are the direct branches of the aorta. So you cut that, and again you can see the pleura coming in. This is the pleura. Can you see the pleura very well?
Absolutely, sir.
This is the pleura of the opposite side. So try and preserve the pleura as much as possible. So we will go here. This is the area that we can go. You can see the pleura which is going away. This is the pleura. Can you all see that very
Absolutely.
nicely?
Very nicely.
You see, this is the pleura which has gone away, and it will not create any problems if you stick to anatomy, because it's all, I always say the entire surgery is all about anatomy and understanding the anatomy, and predictive anatomy. So I predict the structures before they come, and that's how your surgery should be taking place in the mind first. Again, you see the esophagus now, and then I am completely mobilizing this, and I am going towards the crura. So this is the crura which we are going, and then this is the plane. Again, you have to make sure this is the pleura. I am pushing the pleura away. I am pushing the pleura away, and then it helps me not return the camera. Kya dikha rahe? So this is how the entire, and now can you see the crura of the?
This is the left crust, sir.
Yeah, so this is the crust, and this is the area that we have gone. As much as you can do the dissection around the crura, the lower part becomes much more easier. And you can see all around, I have gone there. This is the entire crural plane. I don't use any kind of sling. This is the vagus. On the opposite side, again, I will use the vagus as a traction. So this is the vagus. And when I use vagus as a traction, then things become easier. I use the vagus, the right vagus, and now this is the left vagus, and I am now taking away everything which is from here, and you see now the entire mobilized area. So slowly,
Harish, sir?
Yes.
Sir, in your technique, where do you divide the vagus?
Actually, I will divide it at the level of the carina.
Carina, sir.
Yeah, because it is the upper tracheal branches need not be sacrificed.
Okay, sir.
Because bronchial branches have to be sacrificed, because if you don't sacrifice the bronchial branches, then you will not be able to clear the nodes in the carina. So we have to sacrifice the bronchial branches, but I preserve the branches which are going towards the aorta, towards the trachea. Now you see that I have almost mobilized it completely.
Yes, sir.
And this is the area where the tumor was. So slowly and steadily we have gone there, and that's the end of the story on this side. And now I see this is the upper area. Again, I hold this vagus here, and now these are the branches. You can see the branches of the vagus going there, and this is, can you now see the direct aortic branches, and these are the branches which I have taken. Now you see the carina again from here. You can see the gauze coming up. Can you see that?
Yes, sir.
And that is the carina. And now I go above. Is it okay, or am I going too fast?
Sir?
Anyway, this is my normal speed, so I don't know whether I'm fast or slow.
No, sir, it's absolutely you are at your normal speed.
Yeah, so this is the area, and now I will go underneath the vagus. So this is azygous vein, and now I will divide the vagus here. So that's the vagus that I have divided now. And now you see this is the area. This is where I am going. Again, same way, this is where you are going to get the arch of aorta. So you have to be careful about the arch of aorta. And now again I am going from here, and now, so this is where I will now divide the left vagus also.
Yes, sir.
And now see, this is the left main bronchus. You can see this is the left main bronchus. And I don't know what the anesthetists have used, but we use a single lumen only.
We only use single lumen, sir.
Yeah, so
Patient
we have
is on
never.
single lumen, sir.
Yeah, so we have never used double lumen, and that's one of the biggest advantages is in the post-operative recovery of the patient.
Absolutely.
So
sir.
can you see the carina now? You can see this is the bronchus. Go inside. This is, you can see the cartilage. Yes?
Yes, sir.
This is the right main bronchus. Then this is the left main bronchus which is going. And then this is between the esophagus and the aorta.
Yes, sir.
So this is between the esophagus. You can see the aorta there,
Yes, sir.
almost pulsating. And now this is the area that we are going slowly but surely and making sure that it comes out very well. And now these are the branches. You can see the trachea lower down.
Yes, sir.
That is the trachea, yes. And these are the branches between the trachea and the esophagus. So this is the trachea and this is the plane that we are going into. Always remain parallel to the esophagus, and you can see that we have gone there and we have completely mobilized this area. So again, now you pull the esophagus. This is where you will get the bronchial artery going towards the right bronchus.
Yes, sir.
So this is all the anatomy that you should be knowing. We are again trying to go there. This is the plane. You can see that this is the wall of the trachea. This is the tracheal wall. I remain parallel to the tracheal wall and I will not damage anything there. So slowly and parallel, never do perpendicular. Look at my dissection, always parallel. And if I remain parallel, then there is no question of damaging anything. So I have gone quite high up there, and this is almost, I am going towards the neck area. So you can see that slowly but steadily we are going towards this area. This is the esophagus. Always remain parallel to the esophagus. Never go perpendicular to the esophagus. And this is very critical. So I have gone now below the azygous vein. This is the area that I have gone into. And now you can see slowly but steadily we are working towards this area. So I think we are almost at the neck area.
Yes, sir.
But still I have not opened the supraazygous pericardium, pleura, because I can go from here very easily. At some point of time, I will have to open this. You can see the trachea beautifully going down. Can you see the tracheal
Yes,
wall?
absolutely.
And this is the tracheal wall which is going down slowly and steadily. And this is one area where somebody was asking me, where is the robot that I would prefer to use? And this is the area where I am very happy to use robo, because here when I go in the supraazygous compartment, I have to use a lot of hand in pronation and supination.
Yes,
and not everybody will be able to do this. We compensate those movements by using, because 360 degrees, that is very important. Again, you see this is the plane, remain parallel and parallel, never perpendicular to a tubular structure. If you follow these guidelines in any of the dissections, then you will never ever be doing any mistake. So again, you see parallel, not perpendicular, parallel to the esophagus, and then you can see that I have gone almost at the upper end of this area.
Great.
Once this is done, then I will now, this is like a child's play now, because the this air CO2 has already gone above. This is the plane that you have to open. This is the supraazygous compartment. And once you open, you can see that I have already mobilized the esophagus right up to the neck area.
Yes.
Yeah. So this is the plane. Make sure that the azygous is completely denuded off. And this is the left main area. And now you see this is the entire esophagus that I am mobilizing. This is the neck area. And again, I go parallel and parallel and parallel. And if I go parallel, then there is no question. So all the people, youngsters who are in the audience, remember that the rules of dissection, if you follow in your life, you will never damage any major structure. Never go like this. It's a mistake. Go like this. esophagus and
Yes.
trachea. Both are complete tubular structures. So always go parallel, parallel, parallel. See that?
Yes, sir.
So these are the dissection techniques which have not been mentioned in any book, but this is something which you follow. And if I follow this, so worldwide when I demonstrate these surgeries, they call me the man with parallel, because that's what is my teaching. And a lot of people have benefited and not damaged any structure by following this rule. Again, go parallel, and then once you see that, that is the step, and that's it. So we are now almost in the neck. Anesthetists need to stop me, otherwise they will see me in the end there.
Yes.
So this is the step where our anesthetist walks in and says, Shailesh, enough now,
Yes.
bas.
Enough, sir.
But this is where we have done the last bit which is remaining. Again, see, there is a trachea, so just go parallel and then cut this. Just go here, go parallel and cut this. So small, small vessels which will come. This is right in the neck, and then this is, when we do transhiatal also, we always say that when you can see a surgical emphysema in the neck, that is the end. So again, you can see this is the area.
Yes, sir.
Again, don't do this. Always remain parallel and parallel and parallel and parallel, and you will see the trachea which is below. So no question of damaging. I have seen people damaging the posterior wall of the trachea. I have gone as a rescue to a lot of them, and this is the most important technique. Now I don't do the left recurrent laryngeal dissection because our morbidity has gone up.
Yes,
If
sir.
I try to do left recurrent laryngeal, because because right recurrent
Right,
laryngeal,
and
not
yes, sir.
left, because this is the in the groove there.
Yes,
So I don't do it because those nodes are also 9 out of the 10 times negative.
They are
But
negative.
yes, and we open the esophagus from the left side, where there is a chance of neuropraxia of the left recurrent laryngeal. And if you have also done a neuropraxia of the right side, these patients can never cough out very well.
Yes.
So I think this is the final part. You can see now that we have gone into the neck area there. Again, parallel, 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 and that's it. So that's the area that is there. And now you see, can you see the entire anatomy?
Beautiful, sir.
This is the end of the story. So you can see this is the carina, nicely done, complete removal. This is the carina, this is the left pulmonary vein, inferior pulmonary vein, which you can see, that's the left-sided inferior pulmonary vein going there into the left auricle. And this is the complete dissection that we have done. So Harish, thank you very much for this opportunity.
No, sir.
I hope I have done justice to all the surgeries that you gave me to do,
Yes.
and in time. So thank you, all of you.
So we all are privileged. मुझे बहुत खुशी है सर, आप हमारे कहने से आए. आप बहुत बिजी शेड्यूल से चल रहे थे, मैं जानता हूँ इस बात को. और एक बार सर खत्म करके कैमरे पे आप आए वापस, सारी क्राउड आपसे एक बार हेलो बोलेगी सर. और मुझे लगता है
मेरे को एक ट्रोकर दो.
या तो दीपक या मैं आके आपका एब्डोमेन वाला पार्ट पूरा करेंगे सर.
बिल्कुल बिल्कुल. So thank you everybody, thank you all of you, thank you all the entire part in Hisar. Thank you so much.
Sir, please be on the camera. On the.
अच्छा हुआ ना सर पूरा. I think we have finished in half an hour.
Yes, sir. Absolutely. So I'll be coming to OT to finish the abdomen and neck, sir.
Yeah. And thank you to the entire team of anesthesia, the nursing staff, and all your residents who have been very kind enough to give me the best kind of thing that I needed. Thank you, everybody.
Thank you, sir. Thank you very much.
Yeah.
Nice, sir.
चलो, हो गया? देखा? चलो खोलो खोलो. चलो टाइम पे हो गया. कितना बजा रहे?
केस कितने रहेंगे? अच्छा,
आना था, बीमार हो गए।
तो छोड़
भेजा।
Dr. Arun Prasad is not available. He sent his recorded lecture. Sir is not well. So my journey as a robotic surgeon, so it will be played in this screen.
Good morning, everyone. Congratulations to Dr. Banga and his team for organizing this wonderful meeting. I'm really sorry that I'm not well and I'm unable to be there physically. So my journey as a robotic surgeon is not exactly the same as you are seeing in this video clip. It's not like this, the current moment, maybe someday in future it might be. So my journey started as a general surgeon in 1988 when I qualified from Maulana Azhar Medical College and associated Loknayak Jai Prakash Hospital. So there I built expertise in traditional open surgeries, focusing on patient care and outcomes, and developed a strong foundation in anatomy, surgical principles, and complex cases. Subsequently, what we did all realize that open surgery had its own problems, whereby you had to cut muscle, it was pain, etc. I don't need to go into this list. And following this came my journey with minimal access and laparoscopic surgery, which began in London in 1992 at Charing Cross Hospital and Medical School. And there we started laparoscopic surgery, laparoscopic gallbladder surgery. At that time, unfortunately, these were the kind of articles that used to come in the journal, threat or opportunity, milestone or dangerous innovation, etc. And we all know now that minimal access surgery is the preferred method for cholecystectomy and similar abdominal surgeries. So laparoscopic surgery did have its limitations, but it was good for lap chole. Advanced cases were a problem. We needed an assistant active arm. Camera control could be having issues. 2D vision, non-intuitive movements were all some of the problems faced. The instruments' angles were restricted. They couldn't move, they couldn't bend. So as to always wish I had 4 arms. So if I ask you a question, can you control a machine with 4 controls by hands, 3 by foot, 3 places to look around, and while doing all this, you can also chat. So many would say this sounds like a difficult proposition, but what I'm talking about is driving a car, nothing more complicated, and we all know that after a while, we are all able to drive a car with foot going in 3 places, because God has given us human brains with adaptability, and we are able to learn things pretty fast. However, history of mankind has always been against new innovation. We saw this during laparoscopic surgery, where there was a lot of opposition. Similarly, there is opposition when it came to robotic surgery. So this is a small video I'm sharing, and this is a totally robotic bariatric surgery which you see in a 270 kg. Surgeon sits here at the console, and this is the Ravi S system. And this console means we have a place to first lock down as well as angulation. Control of instruments take place through the finger control, where the thumb and middle finger are drawn inside, and these fingers will control instruments inside the abdomen respectively. Foot pedals for energy sources, right instrument, left instrument, how we cut in, and we have a camera pedal, we have a clutch there, we also have a pedal to switch between instruments. This is what the instruments look like. That's a robotic program, not very different from a laparoscopic program. You have the robotic instruments, and if you can see there, the tip and the finger of these instruments are able to move in 360 degrees as opposed to human fingers which only move in one direction. So this is what gives a lot of versatility when it comes to instrument moving. This is the patient being prepared. After that, we will put in a Varus needle, supply the abdomen, and the robotic cannula which has been introduced. Through this, we will be putting in a telescope. What is interesting, if you note, you don't need any steep head up position when doing bariatric surgery, because the robotic arms which are going to lift the abdominal wall give us adequate space. You can see there is hardly any tilt of the table in this 270 kg patient. Anesthetist is very happy with such things. Now you can see the robot has been wheeled in, being brought to the head in the patient, like that. The robotic arms will then be connected to the cannula, which is known as talking of the work. You can see there, this is what our robotic theatre looks like after the surgery has started. Then we also have some special instruments we use during surgery, and that's the surgeon sitting at the console, the instrument moving inside the abdomen. This is a robotic stapler which has degree of artificial intelligence in it. It can sense the thickness of the tissue and guide us as to what color cartridge should be used, and also automatically compresses the tissue as per the requirement based on the thickness it is able to sense. So that's the robotic stapler that has gone inside. See, we have another clip on the robotic stapler in the right. This is the articulated stapler which is gauging the compression thickness and it fires by using artificial intelligence. Very firm in the grip, you can see the stapler does not move a millimeter here and there when firing. Firing completed. This is how the surgery is taking place. The instrument control and the surgeon console. So this is the patient. We have his own special beam plate. After 6 months or so, the kind of weight we lose. He's still wearing the same beams. 1.5 years later, this is him in the OPD. This time he had to buy a new pair of beams. So what are the notable milestones I have faced in robotic surgery? In 2012, I started with fundoplication, rectopexy, thymectomy. In 2013, I also started doing bariatric surgery by robotics, abdominal wall repair in 2015. So first time globally, I have the honor to have done certain surgery, the robotic LGB-OAGB, robotic thymoma of a large 500 grams thymus, robotic pancreatic surgery, robotic hepaticogestomy in benign features, and robotic TARM for ventral incisional hernias, which was also telecast at IHBS meeting in 2018. So this is our publication with the robotic vagina stenosis ventral bypass, the first in the world. also robotic hepatovaginoscopy, hernia series still under publication. So why do I prefer robotic? Better dexterity, and because of better dexterity, we have reduced technical errors, improved anastomotic integrity, and lower complication rates such as leaks or strictures. Then we have improved visualization because of the 3D immersive view, and this can lead to fluid-induced surrounding tissues, reduced blood loss, shorter operative times, which contribute to overall patient safety and outcomes. We also have improved ergonomics because the surgeon can sit at the chair as you saw in the video. Increased surgeon focus and precision over extended periods, potentially leading to better surgical outcomes and lower complication rates. Then we have a shorter learning curve informed by training criteria, and even when I think that the learning curve for robotic surgery is much less than other learning curves because of the superior technology. So new surgeons may achieve proficiency more quickly, which can enhance the overall safety and efficacy of the procedure and reduce long-term training costs. The precision and fulcrum ergonomics of robotic surgery leads to less trauma to surrounding tissue, resulting in less post-operative pain and faster recovery. Now, this is a question which a lot of people ask, that in laparoscopy you have 5 millimeter ports, here you have 8 millimeter ports. How can you say that the pain is less here? And that happens because of the fulcrum effect, because the instruments, they would move to a fulcrum and there would be no side to side or up and down movement of the trocars and cannulas, thereby reducing the amount of bruising that can take place in the abdominal wall muscle. And this continuum concept on the abdominal wall is what leads to less muscle trauma, less bruising, hence less pain and early recovery and early discharge. Then the indications also increase. So, you know, for example, super obese, the best example I can give here is that a lot of surgeons who would hesitate to do complex procedures laparoscopically are able to do the same procedures robotically. So it basically raises the standard and makes an average surgeon do advanced surgery with the same proficiency as the more skilled surgeons. So it reduces the difference between highly skilled surgeon and a relatively less skilled surgeon by giving them the platform whereby they can do better surgery. There is this My Intuitive app, and I've been doing this surgery since 2012, and what you can see here is that this is one example of a procedure, and where this is a sleeve plus operation where we did a sleeve gastrectomy with a bypass, and you can see that total surgery time was around 50 minutes with active time of 34. Now this is a surgery which, if I am asked to do laparoscopic, I would not be able to do in this much time. In other words, what I'm trying to say is that after the learning curve, we are able to do surgery much faster robotically technology, which is known as Firefly technology. Funnel stitch for the corner. This is a gastric tube being passed across the anastomosis. You can see the front hand, back hand, side hand, all sorts of movements which are possible with that needle holder to be able to get good anastomosis fairly rapidly. Final look. So do a methylene blue leak test on the anastomosis. That's the anastomosis. This is the sure form stapler which I was talking about. Here you can see how instruments can move in various directions, rotation, angulation in all directions. It acts like a good grasper as well as a stapler. Here we are using it to form the pouch. You see number 1 at the bottom left of the screen, that is what the stapler is showing. When it is clamped, it becomes blue. You see clamping being done. The firing, which we saw earlier also, totally steady without any movement. Excellent hemostasis. So another criticism is about the timetable. So this is an SI robot. This is a video which is about 10 years old. You can see that's the SI robot being created. There is a clock there where you can see the timing. That's the robot being docked. People talk about a lot of time being spent on docking, but as I say that once the team is familiar with the robot, after the initial learning curve, the docking should take very little time. Here, as you see in this video, the entire docking has been completed in 45 seconds. So, going back to the study which I was talking about, step 1, step 2, step 3, and we've done a statistical analysis. Graph chart will tell us what exactly we found. Now, the step 1 and the step 4, the robotics took a little longer. This is the yellow, but for step 2 and 3, robotics actually took less time. The total operating time invested by cardiology by me is less than the time I would take in laparoscopy. There are newer robots which have come in the market and also under development. The most important aspect which currently is being worked out is what is known as a single port robotics, where all the instruments would go through a single cannula, go inside the abdomen and move around via control. As you can see there, all movements of the camera instruments will take place through the robotic there. Then we have Made in India robot, which is the SSI Mantra. Very proud that the Indians have developed this wonderful technology of robotics. And there are many benefits of the SSI Mantra over the existing robots of other companies. I'm sure this is something which will be covered by other presenters in this meeting. And SSI Mantra we talked about. There are quite a few installations which have taken place in India, and surgeons have been very happy with it, and a lot of good work is being done using this robot. So to conclude, I would like to say, I'm not ready to say that robotic surgery is the future for our field. It's a good fit for specialist procedures, but not for all. However, see on the left, or whether you use it to open a beer bottle and pour beer, as you can see on the right, is your choice, the food. And last comment would be change is inevitable, growth is optional. With that, I come to the end of my presentation. Thank you very much for listening. Apologies again for not being physically present to attend this wonderful meeting that is being organized. Thank you very much.
थिएटर में कनेक्ट कर दो.
Hello.
उधर ही रख, उधर रखो। Gosh. कोटरी की देखो तार खींच रही है। सोनी सीजन चाहिए। लाइट बंद करना ऊपर की। ये पैडल वेडल सही करो भाई। थोड़ा हेड एंड और ऊपर करना।
Hello, Dr. Deepak sir.
Yeah.
You are connected, sir.
Okay. Hello.
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 And you are audible, Dr.
Hello.
Hello.
I'm sorry, I'm Dr. Deepak. Who is it?
I am
अच्छा अच्छा okay. Hello.
Hello.
Sir, I'm audible?
Yeah, you are audible.
Okay, okay, sir. Fine. I'm just starting the abdominal part. Just putting in the ports.
Liver is
Shailesh sir.
already retracted.
Sorry?
Liver is already retracted.
Yeah, but I need one more retractor actually. So can you see this? These are my port positions. Camera just at the umbilicus, 2 parietal ports, and 1 epigastric port. Okay?
Yeah.
Sponge. Head and raise कर, head and थोड़ा सा elevate कर. Gosh, please.
Hello.
Hello.
Is the same case in which thoracic part has been done?
Sir, your voice is not clear. Yeah, same case. Dr. Shailesh sir has done the thoracic part. I am doing the abdominal part. So planning a McEwan's total thoracolapparoscopic esophagectomy. So Dr. Shailesh mobilized the esophagus from the chest. I am going to do lymph node dissection and make the tube. And Dr. Harish is going to do the neck part. Washer change करना, washer दूसरा देना.
Is there any history of previous laparoscopy? Why there are so much?
Patient has history of open appendicectomy, sir. Hello.
Appendicectomy when the patient was 3 years.
Yeah.
Can we take down these adhesions with scissors because they are avascular?
You can.
Okay.
You can, obviously. Liver लेना. फोकस कर। कर लो यही तो आवाज गाना तो।
So we are starting with a case of carcinoma prostate. He's a 65-year-old male of BMI 27 kg per meter square. He complained of sensation of incomplete evacuation of bladder for the past 5 months. On ultrasound, the prostate volume was 70 cc, seminal vesicles were prominent, and an echogenic focus of size 5 millimeter was there in the prostate. The PSA of that time was 65.2 nanogram per ml. The trust biopsy was suggestive of adenocarcinoma, SNR type, not otherwise specified. The total Gleason score of the patient was 7, 3 plus 4. The proportion of prostate involved was 40 to 50%. However, there was no lymphovascular invasion and no perineural invasion. The PET scan of the patient was suggestive of prostate was enlarged of the size 551 into 41 into 48 millimeters, and there was diffuse
Hello. Okay. So after doing partial nephrectomy, this is second case, CA prostate. So good thing is like because he already got hormone treatment, neoadjuvant hormone, so prostate size is small. On DRE it's hardly palpable, and on MRI it is I think 28 gram only. So I don't see much of difficulty, and this is our port placement. This is assistant port, 12 mm for putting hemolock clip. Five. सेक्शन छोटा होगा इनका आई थिंक. बैरिएट्रिक सेक्शन है? हाँ है बैरिएट्रिक सेक्शन? वो मंगा लेना बैरिएट्रिक सेक्शन. हाँ वही लगेगा. पानी लाइट ऊपर कर दो। Can you see the external view of the patient?
Yes.
Yeah, so this is camera port. So this is head end of the patient, this is foot end of the patient, from where all the modular arms of the robot will come. This is umbilicus. So this camera dedicated port is just above the umbilicus. On the right side, I have kept one robotic port for the monopolar scissor. There are two assistant ports, one 12 mm and one 5 mm. And on the left side, there are two robotic ports. And this is the pretty standard port placement for any pelvic surgery. Whether you are doing radical prostatectomy, whether you are doing radical cystectomy or any gynae-oncological procedure like hysterectomy. So this is the standard port placement for every patient for pelvic surgery. So after docking the arms, now I will start with the procedure and I will just go into the details of surgical steps and the technique of radical prostatectomy. So if there are any question regarding the management of the CA prostate treatment plan, how to investigate, then you can ask me. I would like to. बहुत दूर से नहीं ला रहे हो? इतना इतना लाने की जरूरत है क्या? अच्छा पीछे लोगे अभी, एक सेकंड, थोड़ा और पीछे नहीं लोगे क्या? बहुत ज़्यादा आगे, बस एक सेकंड रुको जरा। सीजर सीजर थोड़ा जल्दी लगा लेना। वो कार्ड रजिस्ट्रेशन सही कर लेना बस, वो गड़बड़ ना हो। बहुत ज़्यादा मत लगाना, नहीं तो फिर स्लिप करेगा वो। इसका तो इसी तरफ होता है, इसका इस तरफ होता है, उसका उस तरफ होता है। अच्छा दिखता नहीं है, ऐसे ही डाल दें। थोड़ा और पास में नहीं आएगा वो? तब बज गया, 4 बज गया। कितना बजा टाइम? टाइम कितना हुआ? 4 बज ही जाएगा शुरू होते होते। जॉइंट पूरा स्ट्रेट है, वो थोड़ा सा बेंड करना पड़ेगा ना। हाँ हाँ, थोड़ा सा इसको और घुमा लो ना, तब पे लग जाए। हाँ हाँ। जॉइंट 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 बेंड करो। हाँ बस ठीक। कार्ड रजिस्ट्रेशन बाइपोलर, फेनेस्ट्रेटेड बाइपोलर। ग्रेस्पर ग्रेस्पर पोर्ट बाहर निकालना भी पड़ेगा, बहुत अंदर है वो, थोड़ा सा इसमें मिल जाएगा। थर्ड आर्म का बस इतना काफ़ी, नहीं तो पोर्ट निकल जाएगा बाहर। फिर ज़्यादा पास में हो गया क्या उसके, ये वाला यहाँ भी डाल सकते थे थोड़ा सा। हाँ ठीक है, काफ़ी बाइपोलर। एक सेकंड, हाँ और ऊपर की तरफ ले आओ, ऊपर की तरफ ले आओ। ये इधर आ रही है, हमको लग रहा है इधर हिट कर रहा है क्या। हाँ ये, हाँ हाँ। अब जैसे ये ना थोड़ा सा रोटेट बिल्कुल अंदर की तरफ है ना ये। हाइट कम कर दो। हाँ हाँ बस ठीक, बस बस। ठीक, कॉटरी 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 कॉटरी। रजिस्ट्रेशन हो गया कार्ड का, कर दो। और क्या हुआ, क्या हुआ, आराम से आराम से आराम से। हो रहा है ठीक, ठीक है। कंट्रोल, कंट्रोल दे दो। हो गया। हेलो, कैन यू हियर मी सर? कॉटरी थोड़ी सी कम कर सकते हैं क्या, कितने पे है? Is there anyone? Hello? Hello?
Hello?
Can you hear me, sir?
Yeah, we can hear you.
Yeah, so I started with the sigmoid mobilization because uh, this is a pelvic surgery, and first I will go posterior to the bladder and prostate. I will go into this rectovesical pouch. So I want to see this pouch, that's why I mobilize with the colon.
Okay.
Then I will just cut this peritoneum over the vas. So this is vas actually, which is coming from the deep ring on the left side. So I'll just dissect this peritoneum over the vas, and I'll extend this peritoneal cut towards the rectovesical pouch.
Okay.
So what it does actually, it free the space in posterior, this cul-de-sac. I can lift, because now this patient has got hormone injection, so I expect lot of fibrosis around the prostate in the fat. Let's see. Now you can see this is the vas of the left side.
Vas?
Yeah, left vas. Same, I will get right vas on this thing. So the whole concept is that where is the reflection of the rectovesical pouch, give peritoneal incision almost 2 centimeter above.
Okay.
And go into the denonvillar plane, mobilize the rectum, dissect the rectum away from the prostate and SV. Because in radical prostatectomy, we take bilateral SV also and some part of the vas, which is attached to the base of the prostate and SV. So I am cutting this denonvillar fascia, which is attached to the base of prostate, because this is a locally advanced disease to begin with. So I am not going for the nerve sparing. I will be completely extrafacial. So in extrafacial radical prostatectomy, we take always denonvillar along with the prostate. Same thing, we always try to keep the fat of the rectum along with the rectum. I am going into the same plane. Ha. ठीक है, और section अगर ला सकते हो तो. So I'll hold this denonvillar and I will tease off all the fat. Suction ला सकते हो तो ला दो, थोड़ा सा help मिल जाएगा मुझे. Now, so this is the maneuver. I always ask my assistant to retract the rectum down, and I'll just cut this denonvillar fascia layer from the prostate. So you can see this nice plane between the rectum and prostate, which is opening. Again, so actually when I'm going for the posterior dissection, I will try to finish it off as long as I can go deep into the pelvis. Now posterior dissection is complete. Now I will go for this vas and SV dissection. I will separate them from the prostate and denonvillar fascia, because what happens, this vas and SV is always, they are wrapped by the denonvillar fascia layer. Now I will just try to identify the vas. I'll cut the vas, and now I will follow this vas. So what happens in locally advanced cases, suppose to begin with SV and vas is involved with the disease, and if you give them neoadjuvant hormonal treatment, then because of the effect, anti-cancer, anti-tumor effect of this hormone treatment, all these structures, they get fibrous and they become very small in their size. Otherwise, in neo patient who are having very well localized disease, you can see the VAS and SV very well, and it takes hardly 5 minutes to dissect both of the VAS and both of the SV. But here you can very well appreciate he is having fibrosis around the structure, but still just with my experience I am trying to identify the SV on the left side, because SV will always be on the lateral aspect of the VAS. So if you have identify the VAS, just follow the VAS, it will lead you to the SV. ये ureter है क्या? Ureter है. हाँ. So now there is a point of caution here. In locally advanced cases, what happens because of the fibrosis, all the tissue, they bring the ureter very close to the structure. So probably this is ureter, which is very close to the SV. So in locally advanced cases, especially when they have already got the neoadjuvant hormonal treatment, then you need to be very careful. So always have a doubt that the ureters might have been like very, they might have been very close to the SV and VAS. And always be very suspicious. If you see any tubular structure, just identify it, check it twice, and when you are very much confirmed that it is not ureter, then go ahead with your dissection. Otherwise you will end up in either clipping the ureters. You can see the peristalsis also. Can you see this peristalsis? This peristalsis. So this is very important point for the beginners who want to do radical prostatectomy. Now you can see this is the SV, very small fibrosed SV. So that's why always dissect the VAS, trace the VAS up to the base of prostate. Always be cautious for any tubular structure. It could be ureter, very close to the SV. Then identify the SV at the base of prostate. Once you have identified the SV, go very close to this thing and dissect it. So now I am done with this left VAS and SV. So I will just separate it from the base of the prostate. So this is bladder. This one is bladder. So now they are attached to the base of prostate. So somewhere here there is a vesicoprostatic junction where all these SV and VAS will go into the base of prostate, and they will form an ejaculatory duct into the prostatic urethra. So now once you have traced this left VAS, it will lead you to the right side of the VAS. So this is right side VAS. Again same dissection, follow the VAS, be careful for the ureter, they might come in the field anytime. So whenever you see any tubular structure, be careful. So after hormone treatment, although prostate, they become very small in size, but because of the periprostatic fibrosis, you might not get planes very well. So this is VAS, you have seen it now. So always confirm before cutting anything that it is not ureter. If there is any question regarding the anatomy, then please ask, don't hesitate. So just I am tracing the VAS towards deep ring. So it will make me 100% confirm that it is VAS, it is not a ureter. Now I am 100% confirmed that this is a VAS. Okay, now after this I will just bipolar it and cut it. Same thing here, because you expect same kind of fibrosis here also. So always be careful while dissecting the SV. You could be very near to the ureters. So this is SV, this thing, fibrosed small SV.
All the dissection is behind the bladder.
Pardon, sir?
Up till now, the dissection is posterior to the urinary bladder. Where is the urinary bladder?
Urinary bladder is this. This one is urinary bladder actually.
Okay.
So SV and VAS, they will be posterior to the urinary bladder. Yeah. So this is the pedicle of SV, where you will get a small arterial supply to the SV. You just fulgurate them. So because I am not planning for the nerve sparings, I can use the cautery very frequently, very deliberately, so there is no harm. But once you are planning for the nerve sparing, then you need to restrict your cautery while dissecting the SV, because you may injure, or it will definitely injure, I would say, the nerves. So this is, now you have got it complete SV, okay. So I am blessed to have Dr. Sarvartha today, because he is assisting just like he is doing at Rajiv Gandhi Cancer Institute. It makes my life very easy. Otherwise, most of the time just I spend instructing my assistant to how to retract. Because pelvic dissection is not easy one, even with the robot also sometimes. So you need to have a very good assistant, trained assistant, who is helping you day and out, day and night, all the day. So now I am done with this both side VAS and SV dissection. So now this is the pedicle of the prostate, this one, this is the pedicle. So these are just the non-velar fascia attachment. You might dissect them a bit more, otherwise you can just leave them, or you can go ahead with your, कोई नहीं, बाद में करेंगे, pedicle के समय कर लेंगे. Now I am done with the posterior dissection, so I will go for the bladder drop. So it's the same, these are the obliterated, right side obliterated. I'll just cut it and separate it from anterior abdominal wall. Then I will open the radius space of the patient. एक बार कैमरा क्लीन करने के लिए तैयार रहना, गर्म पानी वगैरह मंगा लेना. हाँ ठीक, कर लेता है. कोई ना, भी कर ले, ड्रॉप होगा तो कर लेंगे.
Dr. Amitabh, this is the bladder?
Yeah, so I am dropping the bladder actually. So
Yeah,
this
yeah.
one is complete bladder.
You're coming
This is
anterior-
anterior abdominal wall. Yes, sir.
But you're taking down the bladder.
Yeah, I'm taking down the bladder. So I'll continue this till a space of red GS
Okay.
behind the pubic bone. So this patient is a bit obese. So there is a lot of fat in this patient, but is still. So here I'll just open the lateral pelvic area also.
That is the ureter?
No, sir. So this is vas actually. This is vas,
Acha, vas.
which I had already cut. So ureter will be here, down here, so somewhere here. But you can see this ureter here, actually very close. So there is no need of, if you feel, then you cut the vas again at the deep ring. It will help in opening the space, where pelvic space. So here you need to be careful about the external iliac artery and vein. Now you can see this is the artery, external iliac artery. So we call it cycle space actually, which is just lateral to the bladder. तुम्हारा वो सक्शन शायद हिट कर रहा है मेरे किसी पे. अच्छा, प्रोग्रेस फिट कर रहा है. ओके 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 ओके. So same anatomy Dr. Salis showed you while doing Vardheim cystectomy with the lap. So here just I am opening the space. You can see this is obturator nerve. Now I will drop the bladder completely on the both side, right and left. I need to see pubic bone of the patient and the arch. So now you can see this pubic arch and bone. So this is the fat of the bladder and prostate. So you need to dissect this fat and you need to keep this fat on the prostate. Now this is the pubic arch on the right side. Again I'll open the right pelvic area, external iliac vessel, obturator artery, ureter. This is again vas on the right side. Was it? So obliterated artery, so here he must be having ureter. I will show you while doing lymph node dissection. So just separating out all the fat of the lateral pelvic along with the lymph node from the bladder and prostate. This is this obturator nerve. Okay, so I'm done with the lateral dissection. Now I will finish my anterior dissection. I'll just refine my dissection in the space of radius. So this is radius space behind the pubic bone. So now this is very important area because all the superficial DVC vein and the prostate apex will be here. So you need to be very careful here because there might be some veins also periprostatic, perivesical, which are full always. And if they start bleeding, then it becomes very difficult to control them in open surgery, not in robotic surgery. So here you just try to minimize your cautery because all these muscles, they are very important levator and eye muscles for the continence purpose. Even if you want to use the cautery, use bipolar instead of using monopolar. Use bipolar always, buzz the fat, dissect it, then you will find the superficial branch of DVC. So this is superficial part of the DVC. You just bipolar it and you cut it. Now it will open the anterior surface of the prostate for you. Now you can see this is anterior surface of the prostate, this is bladder, and this is probably junction of the bladder and prostate. So always try to have a very bloodless field so that you can see the structures very well. एक बार कैमरा क्लीन करेगा क्या सर वार्ता? कितना बजा? टाइम 4:30 4:15 So now what I will do, I will try to defatten this thing. अभी नहीं काटा, काट लेंगे अभी. जरूरत नहीं है काटने की, इसको ऐसे छोड़ देते हैं. Now the next step is incise the endopelvic fascia, both sides. So we need to understand the anatomy because this prostate is all around wrapped into the endopelvic fascia. So we need to cut it while doing the radical prostatectomy. So this is endopelvic fascia. I'll just cut it to separate all the levator ani muscle from the prostate.
This muscle is levator ani.
Yeah, this is levator ani muscle, sir. So these are the periprostatic veins.
So the fascia covering the levator ani is the endopelvic.
Pardon, sir?
The fascia covering the levator ani.
Yeah. So that's why we call this fascia as a levator ani fascia. So it not only wraps up the levator ani muscle, it also wraps the prostate also. So I'm done on the right side with the levator ani fascia incision. I'll again go on the left side. Teasing of all the levator ani muscle fiber from the prostate like this. So we need to be very gentle here. Even if you want to apply the cautery, always use bipolar, not monopolar. It's a very important aspect of this, preserving the continence function. Otherwise these muscles, they get injured with the cautery and patient suffers a lot. So now you can see the outline of the prostate very well. So this is the bladder, detrusor fiber. अभी नहीं, मेरे हिसाब से हो जाएगा. So this is the prostate. So we do this maneuver to identify where is the bladder neck. So here we pinch, we try to pinch the bladder neck. So here if I can't pinch, that means there is a prostatic parenchyma. So I'll go further down. So now here I can pinch my instruments and they are joining each other. So that means here we will get the bladder neck. So I'll start my dissection here. First I will divide the anterior bladder neck, then posterior bladder neck.
And that area of this levator ani, that is external sphincter.
So external sphincter is this one, sir. So what happens, this is a very complex diaphragm muscle fiber. So the part of levator ani, they form puborectalis and pubourethralis. So these pubourethralis, they form external sphincter. So they are in U-shaped fashion. They are attached to the pubic bone and they encircle the urethra. So when you are at the apex of the prostate, so that's why we minimize the monopolar cautery. So this is prostate parenchyma. So it's very important to notice whether you are into the avascular field or not. if you are encountering bleeding while dissecting the prostate from the bladder, that means you are not in a right plane. Whereas if you are having a complete avascular plane, that means you are having a very good plane. Just like this. फ्यूम बहुत आ रही है ना. थोड़ा सा टिप नीचे करोगे कैमरे का. Suction. So now if you observe if you are observing it very carefully, so this is the prostate. So now this is very thin layer of the mucosa of the bladder. You can see this catheter. Now I have opened the anterior bladder neck. I will dissect it a bit more on the both lateral sides. Balloon deflate karo. You can see?
Yeah, we can see.
Yeah. इधर दिखाओ, यहाँ कुछ ब्लीडर है क्या एंटीरियर ब्लडर नेक से? यहाँ से दिखाओ एक बार बस. ओके ठीक है. एक सेकंड अभी रुक जाओ जरा, पहले मुझे पकड़ने तो नहीं, पूरे निकाल दे. रुक जाओ रुक जाओ रुक जाओ रुक जाओ रुक जाओ. बाहर से भी खींचना पड़ेगा. बाहर से खींचो. Now you can see this is the posterior bladder neck, okay, and this is the ureteric orifice, right side ureteric orifice and the left side ureteric orifice. So because he had locally advanced disease and he already had got this neoadjuvant hormonal treatment, he had got a scar, and these ureteric orifices, they came very close to the posterior bladder neck.
You will do stenting?
No, so they are too far actually. Okay. So I'll not go for the stenting.
Okay.
Yeah. I think this patient had a median lobe before, and because of the hormone it got shrink, and that's why these ureteric orifices, they are very close to the posterior bladder neck. Otherwise, if there is no median lobe, we don't see that much close bilateral ureteric orifices. Again, same concept. If you are not having any bleeding, that means you are into the right plane. So here we try to be very well controlled manner so that you don't go into the prostate. Either you should not go into the bladder also. Otherwise you will make a buttonhole into the posterior wall of the bladder. Now we call this as a retrotrigonal layer. Once I will cut this retrotrigonal layer, my posterior plane will be matched. Then I can see my VAS and SV from here only. खींचो, कैथेटर खींचो बाहर. खींचो खींचो और खींचो और खींचो और खींचो और खींचो और थोड़ा सा इधर. ये पोस्टर ब्लैडर देखने तो सेक्शन हटाना सर था वहाँ से। Now you can see my posterior plane is matched with the anterior plane.
Exactly. You are a wonderful surgeon, Dr. Mittal.
Okay, clean camera once again. दो डाले हैं बॉस, एक 12 mm का, एक 5 mm का। दो, हाँ, कैमरा और सीजर के बीच में 5 mm और स्केयर थोड़ा सा सुपीरियर। दूसरा वाला इधर 12 mm के इस तरफ, हाँ लेटरल, 12 mm, हाँ 12 mm। बिकॉज कभी कभी निडल फिर ना वो 20 वाली ना जाती नहीं है 10 mm से ना वो। तो सब ऑरिफिसेस वगैरह सब क्लोज आ गए। मतलब फॉर मी आई वाज एक्सपेक्टिंग कि थोड़ा दूर होंगे, लेकिन हमको लग रहा पहले मीडियन लोब था, अब वो हार्मोन की वजह से वो श्रिंक कर गया, अब वो श्रिंक करके वो यूरेट्रिक ऑरिफिसेस को भी अपने पास ले आया पोस्टर ब्लैडर वाला। बस कोई मतलब ही नहीं है, ऐसे भी इतना कॉन्ट्रैक्टेड होगा कोई निकलेगा ही नहीं। वो ना अगर बचाना है ना तो स्ट्रिप ऑफ हो जाएगा पैरेन्काइमा ना, वो छूटेगा ही नहीं, प्लेन ही नहीं मिलेगा वो। हाँ हाँ हाँ, वो करना ही पड़ता, लोकली एडवांस में करना ही पड़ता है। अगर लोकलाइज डिसीज है तब आप प्रिजर्व कर सकते हो, वो फिर अलग टेक्निक है, वो फिर कंप्लीट इंट्राफेशियल नर्व स्पेयरिंग की टेक्निक है, वो फिर मैं उससे ही करता हूँ, डाविंची से ही करता हूँ, इससे नहीं हो पाता उतना प्रिसाइज ना सारा। थोड़ा नीचे नीचे नीचे, वहाँ मत जाओ, यहीं पे लगाओ, हाँ यहाँ पे लगाओ, नहीं तो लगेगा नहीं वहाँ पे। हाँ ठीक, लग गया? नहीं लगा? नहीं लगा तो ऐसा करो, एनर्जी सोर्स ले लो, मैं बताऊँ। हाँ हाँ लिगा श्योर ले, क्योंकि एक्चुअली टिश्यू टफ है ना तो लगेगा नहीं और टाइम भी लगेगा। एनर्जी सोर्स लो, फटाफट फटाफट काट के चलते हैं, टाइम बच जाएगा, नहीं तो एक क्लिप लगाएंगे फिर खराब भी होगा। अच्छा ठीक, बस वेन होती है ना एक्चुअली, वो पूरी तरह से आती नहीं है जब तक डिट्रूसर फाइबर हैं। जैसे अभी ये डिट्रूसर फाइबर है ना थोड़े से, तब तक तो ठीक है। अब जहाँ से ये साइनसेस आने लगेंगे ना, ये पेरी प्रोस्टेटिक और पेरी वेसिकल, आओ आ जाओ लगा दो, तब फिर दिक्कत है। नहीं नहीं, अभी तो क्या है ना, जब इस तरह की सिचुएशन आती तभी मैं लेता हूँ, नहीं तो नहीं लेता हूँ मैं। हाँ हाँ, अब देखो ना वो लगेगी नहीं, वो प्लेन ही नहीं। हाँ वो एक्चुअली नहीं नहीं, टिश्यू टफ हो गया है, हाँ वो इसलिए। नहीं तो ये फैट सॉफ्ट होता है यूजली और अपने आप लग जाता है, उसका पोस्टीरियर विंडो बनाने की जरूरत भी नहीं पड़ती है। इसीलिए मैं कह रहा हूँ लिगा श्योर लो और काटते चलते हैं दड़ा। आओ, टाइम बच जाएगा हमारा।
What is this vessel, Dr. Mittal?
So these are, sir, actually attachment of the bladder fibers, detrusor fiber to the prostate.
Okay.
So what happens, all these periprostatic veins, they actually over the bladder also. ये एक सेकंड रुक जाना सर्वार्था जरा। हाँ, एक तो मुझे लग रहा है कुछ कार्ट रजिस्ट्रेशन में इशू हो गया है क्या, हमको लग रहा है। ये मैं अब इधर देख रहा हूँ नॉर्मली आकर के, देखना है रजिस्ट्रेशन, मेरा कैमरा हिल गया है, क्या हो गया है। अब मुझे ऐसा लग रहा है जैसे मैं राइट साइड से देख रहा हूँ इंस्टेड ऑफ सेंट्रल। अरे नहीं, मैं सेंटर में दिखना चाहिए ना, मेरा कैमरा नेचुरल। हाँ ये ना हिल रहा था ना, कहीं पे फंसा हुआ था ना ये। ओ अच्छा, डाउन पे था इसलिए ऐसा था। ओ चलो आओ, एनर्जी सोर्स लेकर के आओ, कट करो इसको। ये एनर्जी सोर्स लेगा, शो रोटेट करो, उल्टा 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 रोटेट करो। हाँ लगाओ, पूरा 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 जंग पकड़ो। हाँ हाँ, नीचे की तरफ, थोड़ा थोड़ा नीचे। हाँ और नीचे 5 mm से आ जाओ, नहीं तो। हाँ, क्योंकि फिर ऐसे जाएंगे ना तो फिर मार्जिन छूट जाएगा प्रोस्टेट का। हाँ हाँ, अब सही है, ये सही है। हाँ हाँ, लो नीचे और नीचे आओ, ब्लडर की तरफ। हाँ हाँ लो, अब ये क्लिप लगेगी नहीं। अब लिगाश्योर से क्या है कि एक सा, हाँ वो हार्ड है ना टिश्यू। हाँ, अब लिगाश्योर उड़ा के खत्म करेंगे काम। सब तरीके ढूंढ रखे हैं बॉस, सिखाने जाते हैं ना तो ऐसी ऐसी सिचुएशन होती पूछो ही नहीं, आप इमेजिन नहीं कर सकते। कहीं पे इंस्ट्रूमेंट नहीं होते, क्लिप नहीं रखते हैं, असिस्टेंट नया होता उसे लैब कभी नहीं कराई होती है उसने। चलो भैया आ जाओ थोड़ा सा। हाँ पहले और थोड़ा सेपरेट कर लेते हैं, ये दोनों तरफ की उठा लेते हैं ना ये, तब फिर करते हैं सेपरेट। तुम ग्रेस्पर से इसको उठा सकते हो, इधर वाला। आओ आओ, ये वाला इसको उठाओ। नाउ आई विल फिनिश माई पोस्टीरियर डायसेक्शन फर्स्ट। आई विल सेपरेट द रेक्टम फ्रॉम द प्रोस्टेट। हाँ आ जाओ। वो ले लो, ऑपरेटर ले लो, हमको लग रहा है हमने वो लगाया है ना ये होल्ड करने के लिए ग्रास्पर। तो, हाँ रिड्यूसर। हाँ कैमरा फॉल्ट देखना, कैमरा फॉल्ट क्यों आ रहा है यार तुम्हारा आज। एक यहाँ से आर्टरी है। क्या हुआ। अच्छा, हाँ हाँ कर दो कर दो कर दो। चलो देखता हूँ एक बार, आओ जरा फिर से आओ सक्शन लेकर के। हाँ ठीक है। हाँ आओ सक्शन, ओहो हो पकड़ के ऊपर करो। हाँ थोड़ा सा यहाँ से, ये अभी है यहाँ पे आर्टरी है, ये थोड़ा सा दिखा यहाँ पे आर्टरी ना, ये माई फॉल्ट में जल्दबाजी में मैंने सोचा बाद में बस कर देंगे, खाली जो है जिसको सोचो कि नहीं परेशान करेगा वही परेशान करता है। हाँ फिर से एक्चुअली सक्शन भी लग जा रहा है ना, तो खुल जा रहा है ब्लीडर, वो हटाना जरा सक्शन हटाना। हाँ एक बार बस मुझे दिखा दो फिर से, ये रेक्टम यहाँ पे दबाओ, यहाँ पे दबाओ, यहाँ से। हाँ हाँ चलो पहले इधर के पट्टी लेते हैं फिर उधर मोबिलाइज करेंगे, है ना। नहीं नहीं पकड़ के, अच्छा लेकिन फिर एनर्जी सोर्स लाना पड़ेगा ना। हाँ ओके ठीक है, रुको बस मैं इधर का पकड़ता हूँ एसवी। अभी करता हूँ मैं, एक सेकेंड, इधर थोड़ा सा कर दोगे, मुझे दिखा दोगे फैशिया। थोड़ा सा दबाओ और अच्छे से। चलो ओके आओ एनर्जी सोर्स, ये है ना ऊपर 5 mm से ही आना, वहीं से एंगल सही बनेगा। दिखाऊं पीछे, हाँ आओ, हाँ ठीक लो। कट रहा है तो कट रहा, नहीं तो मैं सीजर से कट कर देता हूँ। हाँ हाँ देते हैं, बट नर्व स्पेयरिंग अगर हो रखी तभी फायदा है उसका, कोई मतलब नहीं है फिर तो मन के संतोष के लिए नहीं, तब भी नहीं लगेगा। उधर हार्ड है ना, ये मिडली हार्ड है टिश्यू, लेकर के आओ ऊपर की तरफ लगाओ, और ऊपर और ऊपर और ऊपर और ऊपर, हाँ लगाओ। हाँ ठीक है, वो डिलॉक्सिटीन तो कंट्रोल के लिए है, कॉन्टिनेंस के लिए, इरेक्शन से उसका कोई मतलब नहीं है। कट, वो बस पेनाइल रिहेबिलिटेशन के लिए है, बाकी तो और कोई मतलब नहीं है। ये एक सेकंड, इस पे क्लिप लगा दे, नहीं तो ये बाद में ब्लीड करेगी। हाँ इसके नीचे से आओ और क्लिप लगा दो, मोटी आर्टरी है ना ये, नीचे और नीचे से, हाँ लगाओ, हाँ, लग गया लग गया लग गया, बस ठीक, कंट्रोल रहेगा अब। कितना हार्ड टिश्यू हो गया ये क्लिप लगती ही नहीं। हाँ अब ये अगर हम क्लिप लगाते रहते बस 1 घंटे झूलते रहेंगे, प्लेन डाइसेक्ट करते रहेंगे, कुछ ना होने वाला इसमें। वो ये रेक्टम को फैट सारा, आओ क्लिप लाओ। ये अच्छी चीज ये है ना, वेन का साइनस खुल जाएगा ना, इधर से ब्लीड नहीं करेगा, ब्लीड उधर से ही करेगा वो। हाँ, बस ठीक। हाँ हाँ वो बस बोल दीजिए अभी एक घंटे बाद निकलेंगे। हाँ, बात करा दीजिए, कोई नहीं। हेलो, हाँ कहाँ? मैं 1 घंटे बाद निकलूंगा बेटू, लगभग वही 9-10 बजे तक पहुंचूंगा घर। मैं कह रहा हूँ 1 घंटे बाद निकलूंगा, 10-10 बजे तक पहुंचूंगा, मम्मी को बोल देना। हाँ 1 सेकेंड। फाइव mm। आओ, कहाँ गए? अबे लगेगी नहीं, छोड़ो। छोड़ दे छोड़ कोई नहीं। यार पकड़ लो, हार्ड हो गया साला। अब इधर थोड़ा सा लगा सकते हो ऐसे। हाँ। यार डीआरई में तो बहुत छोटा प्रोस्टेट थे, तो साला खत्म ही नहीं हो रहा। हाँ उसमें तो मैं साला डीआरई करके तो इतना खुश हुआ था कि जो है, वो तो मुझे कैथेटर फील हो रहा उसका। मैंने सोचे तो इतना छोटा है कि साला कैथेटर फील हो रहा है अपेक्स का डीआरई में। मेरा अच्छा सर्वर था वही कॉटरी, वो लिगाशोर लाओ, इधर इधर लगाओ, इधर से आओ, साइड से आओ, साइड से लग जाएगा। एक इधर लगाओ, एक इधर पे। एक सेकेंड और थोड़ा सा। हाँ चलो, एक सेकंड प्लेन बनाता हूँ, रुको मैं थोड़ा सा रुक जा बनाता हूँ मैं। हाँ चलो आओ, डालो इसके अंदर। हाँ हाँ बस एक सेकेंड अब। हाँ सब, हाँ नहीं डिसीज़ नहीं, पहले यहाँ पे डिसीज़ रही होगी ना। हाँ तो इन्फ्लेमेशन भी कभी कभी रहता है ना, तो उसकी वजह से फिर फाइब्रोसिस हो ही जाती है मेरी प्रोस्टेटिक। हाँ अब 5 mm से आओ जरा, और ये पूरा लो। हाँ ऊपर 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 कर ऊपर की तरफ, कर ऊपर। हाँ 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 नीचे और नीचे और नीचे। हाँ थोड़ा ले लो। हाँ 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 बस एक सेकेंड फिर से, लेट मी शो यू अगेन, 1 सेकेंड। आओ चलो ऊपर की तरफ जाओ। हाँ जाओ। हाँ ले लो। बस एक सेकंड, अब रुको, गिव मी सम टाइम, 1 सेकंड। वन सेकेंड। ये पूरा है ना? हाँ, अब इसमें it was very difficult to apply Hemolog clip thing. तुम इससे ना इसको दबा भी सकते हो। हाँ। Now, okay. बस एक सेकंड, थोड़ा सा और प्लेन बेटर बना दे, फिर ले लेना। हाँ, वेन होगी। ठीक है, चलो अब ये पूरा ही ले लो, आओ। हाँ, ठीक। हाँ, दूर है। कट। बस एक सेकेंड। कहाँ गया मेरा बाइपोलर? ओके, वहाँ पे। अब इसको दबा लो थोड़ा सा। हाँ, बस ऐसे ही दबा के रख लो। ब्लेड हॉट तो नहीं है उसकी? तो बाइपोलर है ना, अब वो तो अब ठीक। ओके, ओए शिट। कैमरा क्लीन करो, मुझे दिखाई नहीं पड़ रहा अब। अब केस खत्म हो जाएगा, तब थोड़ी चाय पी के फिर निकल जाएंगे। ठीक। बहुत अच्छा क्लीन। हाँ लाओ, और ये कैमरा भी बहुत अच्छा क्लीन है नहीं अभी ना। यहाँ पे हमको लग रहा कुछ है वेसल है इसमें ना, तो इसको प्लेन बना लेते हैं। हाँ, लगा दे इस पे। इस पे लगा दो। 5 भी लगा सकते हो, छोटी सी ला करके ना, प्लेन तो बन ही गया है ये। किधर से आ रहे हो? 5 से आओ। कैमरा ठीक बताते हैं, थोड़ा सा और डाइसेक्ट हो जाए फिर कराते हैं क्लीन ना। इसमें भी वैसा ही हमको लग रहा है। हाँ, 5 देना। दिखाऊं? आओ। आओ। अच्छा, थोड़ा नीचे की तरफ लगाना, कट करने के लिए स्पेस मिले मुझे। हाँ देखता हूँ अभी मैं, कई चीजें हैं ना इसमें। आव अगर लग जाता है इसमें, हाँ इसमें पूरा लग जाता है ना तो वेन है, वेरी प्रोस्टेटिक। ये तो बाद में सूचर लगाना पड़ेगा फिर ना। करो 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 करो, हाँ लगाओ, गुड। ये था ना वेन। ओके, एक सेकेंड बस। एक वाइक्रल रख ही लेना, कुछ कुछ शायद लगाने ही पड़ेंगे। चलो अब एंटीरियर आ जाते हैं। एक बार कैमरा अगर क्लीन कर सकते हो क्लीन कर दो, मुझे लग रहा पोर्ट डर्टी हो गया है। इसके बाद सूचर है इनके पास, क्या क्या है? 3015 के 3 ले लेते हैं ना, 30 यूज करेंगे फिर उसको हैंडल करने में टाइम लगेगा। थोड़ा 5 मिनट 5 सेकंड के लिए रखो तो थोड़ा ज़्यादा क्लीन हो जाता है फिर। कितना टाइम हुआ यार? टाइम 5 बज गया ना। मैं सोच रहा था कि प्रोस्टेट ख़त्म करके नासोसिस करके मैं चला जाऊँ। बॉस कहाँ गए? नहीं वो नोड ऑपरेटर सैम्पलिंग कर देना है ना, हमारा भी टाइम बच जाएगा। हाँ हाँ, ओ गंदा है क्या फिर से? नहीं टॉप में गंदा है। क्योंकि जितना जल्दी निकल जाएंगे फिर ना। हाँ उधर कोई है? हॉल में है कोई? अभी बैठे हैं लोग? और भी कोई केस चल रहा है क्या अभी? लाइव ट्रांसमिशन उसका भी चल रहा है? थोड़ा कैथेटर, कैथेटर, पुट द कैथेटर। कैथेटर डाल दो। वो ट्रम्पेट वाला होगा। डाल रहे ब्रदर? कैथेटर डालो। डालो, थोड़ा और डालो, डालो डालो डालो, बस 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 बस, इतना ही रखना है। चल ही नहीं रहा सर, हार्ड हो गया टिश्यू। अरे यार, थोड़ा सक भी कर लो। चल ही नहीं रही है यार सिजरी। इधर साइड में सक कर लो। कोई नहीं, आ जाओ 12 mm से आ जाओ, नहीं तो अगर हिट कर रहा है तो। ये बहुत बड़ा चैलेंज है ना सीजर कैन का। सो यूरेथ्रा आ गया। हाँ थोड़ा सा इधर और पिलर ये कट करते हैं। लाओ नडल होल्डर दे दो। ये वो है 15 सेंटीमीटर है। अच्छा, और ये साइज तो बड़ी है। अच्छा ही है, साइज बड़ी है तो। तो 30 छोटा रहता था ना। बट वही एनास्मोसिस में भी अगर यही होगा तो थोड़ा सा टाइम लगेगा संभालने में। क्या है पीछे, वो है बटन है क्या है? अच्छा वही है। कोई दूसरा कंपनी है? नहीं दूसरा कंपनी है, वीलॉक नहीं है। वीलॉक का कलर ऐसा होता ही नहीं है। स्ट्रेटाफिक्स का इस तरह का कलर होता है, ये कोई दूसरा। एक सेकंड होल्ड करने तो पहले उसके बाद करते हैं.
What is this maneuver you are doing, Dr. Amitabh?
So this is DVC, sir. I have cut it. Now I am suturing it. In open surgery, actually, this was the most you can say feared step of the radical prostatectomy. Like it was very difficult initially how to control the DVC, because in open surgery when it starts bleeding, within minute you can get a 500 ml blood loss, because they are so full of the blood supply and there is no valve actually in these veins. So you can have a very significant amount of bleeding within very short span. But here, because this we have got of almost 20 of the pneumo, they remain closed. So now just I am suturing them. So once I will suture them, I will go for the apex dissection. एक सेकंड सर बता प्लीज, अभी रुक जाओ प्लीज, मेरा ना फिर सुचर जा रहा है ना, एक तो मुझे छोड़ना पड़ रहा है ना. लाओ सीजर दे दो, अपेक्स डायसेक्ट कर लेते हैं. प्रेशर कम करना है, कम करा दो. सीजर दे दो मुझे. ये इस पे से सक कर लो क्लॉट, प्रोग्रेस से क्लॉट सक कर लो. ठीक है, इतना काफ़ी है. मुझे सिसर दे दो. एक्चुअली थोड़े इसके पोस्टीरियर से ऊज है ना, वहाँ पे सुचर लेना पड़ेगा. 40 वाइक्रिल, तो 40 वाइक्रिल बनवा लेना. चलो अब लेटरल से आ जाते हैं. ओके ठीक, 1 सेकेंड बस बस बस. नाउ आई विल कंप्लीट माय एपिकल डायसेक्शन. यहाँ पे सब करो. सो दिस इज रेक्टम. आई विल बी वेरी केयरफुल so that I should not enter into the rectum. I will be very close to the prostate. अब यहाँ पे थोड़ा सा सक करोगे, ये वाला क्लॉट, यहाँ वाला. 12 mm से आ जाओ ना. 12 mm से आ जाओगे तो फिर इतना हिट नहीं करेगा कैमरे पे. So now this is a rectum which is completely separated from prostate now. Okay, so this is urethra. These are the non-velar fascia fibers. You can also cut them and separate them.
You avoid using cautery here in this area.
Yeah, definitely, sir. Because the thermal injury could be very actually dangerous for you. Because sometimes, like, even if forget about the continence, you can have a thermal rectal injury also. Immediately you won't be recognized, like, is there any injury, but later on POD3, POD4, you will get the necrosis of the rectum because of the thermal injury. So better not to use cautery here. If you want to do, if there are like bleeders, then better to take them with suture.
While doing TURP,
Yes, sir.
we see the verumontanum, and that is just at the apex of the prostate.
Yeah.
And now
So,
we have dissected so far down.
so in TURP, actually, we don't go beyond verumontanum.
Yeah.
Yeah. So the concept is same. If you'll go across the verumontanum, you will injure the external sphincter because there will be collateral damage, energy leak. Now, because of the neoadjuvant hormone treatment, the whole thing is stuck. Denon-velar fascia, rectum, everything. That's why I am going very slow. ये यहाँ कैथेटर डालना थोड़ा सा ब्रदर. This is rectum, which I have already separated from the right side. Now I am 100% confident that I didn't do any injury on the rectum. This is urethra. Yeah. Now I am done with the apical dissection. So because he had locally advanced disease and because of the neoadjuvant hormonal treatment, everything got fibrosed. So you can't see the planes. But just with the experience, I am doing this dissection. Yeah, it's done. Needle holder. एक नहीं क्लिप scissor ये ले लो हाँ 40 नहीं वो वाइक्रिल हाँ वाइक्रिल Vicryl. सब सुलझा हुआ नहीं है ना। ये पहले सक कर लो, थोड़ा पानी मार दो इस तरफ। ये अगर इधर से 5 mm से नहीं आ रहा तो 12 mm से आ जाओ, नहीं तो और देख से। अच्छा इधर कुछ है, ब्लीडर है, एक बार देखना है यहाँ पे क्या है। हाँ 1 सेकेंड बस, जाओ देखता हूँ। एक सेकेंड। सिजर आ सकती है क्या? नहीं थोड़ा लंबाई काट दो, चलेगा। ओए होए 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 होए, कट गया। ये यहाँ से कुछ ब्लीड कर रहा है क्या? या यहाँ से? एक सेकंड को पहले ये बंद कर देते हैं। सक्शन लड़ा या तुमने कुछ किया नहीं था? चलो अब एक सेकंड बस। सेकंड। पोस्चरिंग बिकम सो डिफिकल्ट, है ना? तो पीछे से ब्लीडिंग हो रही है क्या? बस एक सेकंड को जरा, बंद हो गया मेरे हिसाब से तो। हाँ बंद हो गया। ये इधर सप्लाई है ना एक, ये नहीं नहीं नॉट आ जाएगी। हाँ हाँ बंद हो गया। हाँ आओ सीजर। इसके बाद मुझे वी लॉक दे दो 30 15 सेंटीमीटर। वो सब उसी में आ जाएगा, रोको ले लेंगे ना। 15 ही दे दे यार, 30 फिर ना वो हैंडल करने में टाइम लगता बहुत ज़्यादा। हाँ ओके तो पास में ही है यूरेट्रिक ऑरिफिस इसका ना, बिल्कुल यहाँ पे है। और इधर तो तब भी थोड़ा दूर है ना? ये है यहाँ पे, ठीक। ला हाँ ठीक। तो निडल साइज बड़ी है एक्चुअली ना प्रोस्टेट के लिए। मतलब अब जैसे डाल रहे हैं ना अब ये, तो अब ये रेक्टम बिल्कुल क्लोज है ना, तो यूजली जैसे छोटी निडल होती है ना तो फिर इतना डर नहीं लगता। अब इसमें बड़ा गाइडेड हमें। हाँ हाँ वही वाली हम लोग यूज़ करते हैं इसको। हाँ वो छोटी निडल रहती है ना, तो फिर उसमें डर नहीं लगता कि वो रेक्टम के थ्रू आ जाएगा या कुछ होगा। अच्छा अच्छा अच्छा। ये सब करो जरा यहाँ पे सर आए। पानी भी मार सकते हो अगर है तो। वो एक बार ना डीआरई करना पड़ेगा देखने के लिए ना कि हाँ, फिर उसके बाद जो है इसके बाद 2 और मुझे चाहिए होंगे, जान रहे हो? ये 3015। हाँ ठीक है, कोई सूचर तो नहीं है? चल ठीक, बढ़िया। देख लो भैया, कोई डाउट हो तो बता दो। रिवाइज कर दें, निकाल दें? अच्छा ठीक। आया सूचर, आया सूचर? हाँ दे दो, दे दो। हमने 4 बजे के आसपास शुरू किया था ना केस ये लगभग, हाँ मोटा मोटा 3:30 बजे शुरू किया है।